Good afternoon, everybody, and welcome to this afternoon session on empowering healthcare through research, innovation, and regional collaboration. Across the Caribbean and right here in the Bahamas, we stand at a pivotal moment in healthcare. The challenges we face demand not only medical expertise, but also creativity, collaboration, and a strong public Hospitals Authority, Spotty Doc, Springer Nature, SATA, and the Ministry of Health and Wellness, as well as individual contributors, Dr. Pinda Butler and Dr. Wells. Your continued support makes events like this possible and ensures that research remains at the heart of regional progress. So just a few matters of business. Our keynote speakers are allotted 30 minutes and all other speakers are allowed 10 minutes. And then after that, we allow 5 minutes at the end for questions and answers. So with that being said, let us begin. And it is my honor to introduce our keynote speaker, Professor Marvin Reed, Principal Director of the Office of Research, Innovation, and Partnerships at the University of the West Indies, Mona campus. Professor Reed provides strategic leadership in advancing research collaboration, innovation, and the translation of scientific findings into real-world solutions that promote sustainable development and global health equity. He is a family physician and professor of community medicine and human nutrition with over 150 peer-reviewed publications and a distinguished record of regional service, including as co-chair of Jamaica's Essential National Research Committee, advisor to CARFA, and president of the Medical Association of Jamaica. Please join me in welcoming Professor Marvin Reed, presenting on regional partnerships and opportunities in research.
Thank you so much for that kind introduction. I seem to be having a bit of a challenge here on the internet, so I'm going to close the video just to conserve on bandwidth. I'm really happy to be here speaking to you on a topic that's relatively dear to my heart, and that topic has to do basically with research. All right, so essentially the objectives of our talk today will be right there to highlight the importance of regional research collaborations, explain how strategic partnerships among Caribbean institutions, governments, and private sector can strengthen research capacity and impact, identify existing and emerging opportunities for collaborative research, as well as discuss the challenges that one may experience and the barriers for sustainable research partnerships. And last but not least, is really to introduce the concept or the new created office, the Mona Office of Research, Innovation, and Partnership, which we've created here at the Mona campus. So I'd like to start by trying to define what's the role of research in the medical sciences. And essentially what I would share is that it's really to facilitate the judicious use of research information and to kindle an interest in knowledge creation to improve lives. There are three main pillars under which research in the medical sciences are undertaken. These are epidemiology, which really speaks to what are the factors that implicate or result in the causes of various diseases. Biostatistics, how do we conflate or utilize data to come up with some evidence of sort. And of course, when we are practicing, how do we incorporate that evidence in our practice? So essentially, when we try to demystify research, what we're left with is what is the overall goal of research? What do we mean by research? And simply put, the overall goal of research is really to answer a question. That's really all it does. So we apply standardized metrics or methods, which we call research methods, with the overall goal of answering a question. Now, having gotten the answers to the question, ultimately the answers are of no use. So by themselves, unless it is that they're applied to the community in which we serve. And hopefully what we're hoping is that these answers would lead to improved outcomes. We recognize over the last few years that just getting the answer, just generating the answer in of itself does not necessarily translate to improved outcome. So that is, as a consequence, a new branch of medical science has emerged, which we call implementation science, which seeks to move those answers, scale those answers, so that we can, at a population level, have demonstrable improvements in community outcomes. Research tends to be cyclical rather than linear, because sometimes the answers that we get to a particular question may not be fulsome answers, may not answer all of the elements of the questions. And sometimes, even when it does answer the element of the question, it generates new questions. So in a sense, we almost have like a vortex in a hurricane, where we generate an answer, and those answers itself triggers even more questions. So having said that, what does the research process look like? Based on the menu that I saw, the agenda that I saw that where you would have had discussions earlier about grant applications and so on. So I think many of you would have had some introduction to what this research process is. So essentially, once you have your question, the current paradigm requires you to encapsulate that question into the form of a proposal. And what are the factors that goes into creating the proposals? Proposal writing is an iterative process, which often involves you identifying the appropriate team members or networks that are going to be important for the helping you write the proposal effectively, the target funding agency, how this project is going to be funded, and more importantly, to have structural support that allows you to submit this proposal for regulatory approval as well as for funding. And then even once you've received the funding, how that project will be managed. So we call that post-award management. Notwithstanding, the issue is the basic element of any research is the acquisition of data. So how that data is captured and the whole ecosystem around that capturing of that data is very important, especially as we move into an era of artificial intelligence and increasing digitalization. How the data is managed and what sort of data analytical resource are also important considerations for this research process. As the investigator and investigating team, once you've collected the data, the important thing now becomes interpretation and how you communicate. We're living in a time where scientific communications take many forms. In the old days, it used to be the form of a peer-reviewed paper, but now we have blogs, now we have internet, now we have TikTok, now we have YouTube. So we have many, many different media outlets through which scientific communications can occur. One of the important things is that once you've interpreted the data, the next steps then become what else, how are you going to then utilize or act on it? And I mentioned in the previous slide, this whole science of implementation sciences. Oftentimes, your data interpretation would allow you to create some form of interventions. And how it is that you monitor and evaluate these interventions and assess the impact is also an important consideration of the research process. As I said, the whole idea behind research is the application of standardized tools to answer a research question. And these tools we consider that to be research study design, of which there are different classification schemes. And on the slide here, all I've done is really just illustrate some of the classical or more common types of classification study types that you can do. Notwithstanding that, at the end of the process, what we have littered in the medical literature is different types of evidence. And classically, we divide them in terms of their strengths. which a systematic review is considered to be the highest level of evidence we have, and the individual case study the lowest level of evidence that we have. So in part of the research question then becomes, how do you define it? How do you go about? What's the process of conceptualizing this question? And there's several factors, which I'll just briefly mention, because as I said, I suspect you'd have done this as part of your grant writing exercise. But some of the things to consider are some personal factors. What is it that I'm interested in? What is the science that underpins it? What are the model theories or framework for which you're going to structure the question within? What's the sort of organizational level of support that you have? Are you a DM student? Are you a PhD student? Where are you located? Are you in the Bahamas? Are you in Jamaica? What sort of support will we have? And importantly, since ultimately what you would want your research to do is to help the community, does the community have a voice? Is it of interest to them? Is it consistent with a national research priority? Is it consistent with some regional research priority or some international research priority? So all of these factors will help you transform your original idea into an idea that is feasible, that is fundable, for which you have the appropriate human and physical resources. Ideally, the idea should be interesting, not only to you, but to your stakeholders, and it should move the field forward. It should be ethical, and of course, it should provide, at the end of the day, relevant and useful information. So in making this transformation, a couple of factors you take into consideration. These would include some biological factors, epidemiological factors, within the context of your conference theme, and within the context of the health priorities in the Caribbean, whether or not there are climate implications, as well as whether or not there are any social determinants of health. More and more, funders are more interested in research questions that incorporate social developmental determinants of health as part of the attributes of the questions. So science has moved from beyond the single individual kind of activity or adventure to more of a collaborative adventure. And so some of the advantages of collaboration includes the fact that most of the questions that we'll have, most of the problems that affect man, have complex underpinnings. The advantages of collaboration is that it allows the convergence of different perspectives, skills, and theories and methodologies, and therefore have more powerful approaches to get a better understanding of the problem and how the world works and how the human works. It therefore requires diverse expertise. It allows or facilitates the sharing of resources and optimize efficiency, often allowing the answers to be more impactful and generalizable. And an important concept overall in science is this whole concept of reproducibility. That is, can other groups get the same answers doing similar kinds of experiments? Importantly, is that it also fosters a developmental component in that skills transfer can occur in a more efficient manner, and human capacity development to do research can also occur. So collaboration is what I consider to be an important, if not the most important, attributes in making reasonable or good scientific progress as we move along. This is, I think, a consistent theme across the scientific community, so much so that Larkin has published a set of attributes of what makes good collaboration. He published this back in the Globalization of Health paper back in 2016. And the characteristics include things like the group should have common goals, they should have trust, they should appreciate and have tolerance for differences in cultural and societal norm, mutual respect. They should be transparent and open and honest in their communication. How rules are apportioned and should be in such a way that there's an accountability. There should be appropriate leadership, and there should be mechanism for conflict resolution amongst the team members. So when you look at it, generally speaking, the key attributes of successful research collaborations would include focus, values, equity, benefit, communication, leadership, and resolution. An important also construct, not as part of his own description, has to do with what we call sustainable funding or investments. So the research network and the collaborative initiative really needs to have some mechanism that to keep them together outside of the science. And one of the key components of that is whether or not there's research funding available. So that takes me now down to the Caribbean. Caribbean is a multilingual, geographically diverse community consisting roughly about 7,000 islands, islets, reefs, and cays. We're all small island developing states. There's a considerable variation in topography. Many of us arose because of volcanic activities, and therefore we represent volcanic islands, quite mountainous. Um, and attached to that is the fact there are quite a many coral islands. And an important attribute, which is an important resource, is that we do have quite a bit of diversity in our fauna and flora. Many of the countries have a high dependency on the service sector, in particular tourism, and there's quite a big difference in economic disparity between the various islands. Notwithstanding, there's very limited agriculture manufacturing capacity amongst the Caribbean islands, but on the health side, there's quite a lot of similarity in terms of the country's health profile. So within that construct, we recognize that there are opportunities or structural collaborations at the regional level. CARICOM is one of the main organizational structural grouping, and in particular, one of the major organs of CARICOM, which is COTED, which stands for the Council for Trade and Economic Development, as part of its articles, state explicitly that there is an emphasis or facilitation of research across the island. And Article 64 speaks to encouraging public and private sector agencies, research establishments, tertiary institutions such as the university, to conduct research and to utilize these technological development to identify or to assist the populations within the Caribbean. And to try, the COTED actually tries to promote cooperation research among member states and to facilitate interactions or partnerships with international organizations. The facilitation is to occur both in training and the exchange of scientific and technical information and in the free movement of researchers within the communities. So in general then, what CARICOM sees as an explicit activity within that umbrella organization is that countries collaborate, both individuals, universities within the various countries and researchers, and that we should have relatively free movement throughout the community. At the regional level as well, there's PAHO, which is the regional branch of the World Health Organization. There's some regional institutions, such as the University of the West Indies, who has footprints in many of the islands. And another important actor in this space is the Caribbean Public Health Agency, which is a creature of CARICOM. And the idea here behind CARIFOR is to provide strategic directions in analyzing, defining, and responding to the public health priorities of CARICOM member states and associate members in order to prevent disease, promote health, and to respond to public health emergencies. CARIFOR, as you know, as one of the tools that it uses to facilitate the cooperation amongst member states, is that it hosts an annual conference. And the 70th annual conference is coming up next year, April 22nd to the 24th. And the call for papers is already out. So I would encourage individuals on the call that you may wish to participate in this conference and share with us some of the medical advances and research that you've been doing in your own countries in Guyana next year, April. So when we think about regional collaborations, what we're trying to do within the Caribbean is to help build what we call resilience. It helps contribute to the economic and human development of our peoples and leverage the Caribbean as a knowledge center and have better leverage in the global domain. And to overcome 7,000 islands scattered across many thousand square kilometers is really to try and overcome some of the fragmentation. So research really then represents a developmental construct and represents what I call a quadripartite collaboration between academia, the private sector, civil society, and the public sector. Some examples of us already doing this. This represents the Lancet Climate Change Countdown. You may have seen this paper, George Strawn and colleagues published this in the Lancet, which really speaks to the impact of climate change on the Caribbean. And then in the bottom half of the slide is our health minister, as well as our CARICOM Secretary General, being part of the champion in the Caribbean has been part of the champion of putting non-communicable disease on the international roadmap, because that represents one of the most serious health challenges that the Caribbean faces. And so there was a high-level meeting in September in New York, where the Caribbean, as I said, initiated and sponsored and kept this movement going at the United Nations level. There's some opportunities as we speak. The idea here is that when you're doing research, the truth be told is that you have to try and pick your winners. So within the Caribbean, we've already said we wanted to focus on some of the diseases, especially non-communicable diseases. Another important emerging areas for research with us has to do with violence and the impact that is having on many of our Caribbean societies. Various countries may have national health research priorities. Jamaica has just completed its exercise of identifying what are the national health research priorities for us. But as I said, because of the similarity of the country health profiles across the Caribbean, there are a lot of, I anticipate there are a lot of similarities. Digital transformation and artificial intelligence represents new areas or emerging areas that we can focus on. Natural products, because of the diversity in our fauna and flora, we really can actually do some work there. And of course, this whole One Health approach, the interface between human health, animal health, and plant health, and the emergence of antimicrobial resistance as a key determinant of health outcomes is an area that we can focus on. We recognize that in the current geopolitical context, some of the funding structures that we used to depend on the past may not be there, but still fundings are still accessible through foundations, international partners, national governments, and of course some of the other international research funders such as Wellcome, the EU, and the Canadians. Notwithstanding, one of the things that we have done and advocated in the Jamaican context is for our national government to try and provide some additional research fundings for that. And certainly in health, we have created a national research fund for wellness, which does contribute or does help some of our researchers here. And it's something that we will want to continue to advocate, certainly at the CARICOM level. The particular methodology that I like to speak about, which is clinical trials, which came to the fore during the COVID pandemic, because one of the things that arose is that we recognized that the treatment options in the development of vaccines had to come through this whole process, and therefore it came to the national attention of what are clinical trials and how useful are those. And essentially, as I said, clinical trials provide some of the higher level of evidence that an individual may have or policy maker may have in making therapeutic decisions. The World Health Organization defined clinical trials as any study that prospectively assigns individuals to a health-related intervention to evaluate the effect on health outcome. And a similar definition is what the NIH proposes, except that they specifically says health-related biological or behavioral outcomes. So there are some characteristics of clinical trials. The assignment is prospective. There is a specified defined intervention, there's specified outcome, health-related outcomes, and some of these outcomes can be the disease of interest or what we call surrogate end outcomes. They provide the strongest evidence for the causal relationship, and from a design perspective, they minimize bias and confounding and provide the strongest basis for policy decisions. classically defined as 4 main phases, which really says phase 1 is the treatment safe, phase 2 does the treatment work, phase 3 is the treatment better than what's already available, and what else do we need to know in the pharmacovigilance component. There's an ecosystem that is required, a regulatory framework, a sponsor who's going to be sponsoring the trial and whose product we're going to be testing, a research site, and that has certain characteristics that are required. That is, does the site have the physical and informatic structure, the standard operating procedure, the persons who are trained? Typically, there's also has to be some monitoring mechanism, which would be the trial auditors and your data safety monitoring committee. Sometimes you may also have to have clinical outcome assessors to make sure that the adjudication of the outcomes are done according to the predefined standards. So here I've put on the slide commonly parts of the ecosystem, the regulatory components, the monitors, the sponsors, and more importantly, the communities, what it is that they would wish for us to define. Different internationally, there's been a move to try to standardize the quality of clinical trials. So we have what is called good clinical practice, or GCP, which is really a standard for design, conduct, performance, monitoring, auditing, recording, and analysis of clinical trials. The International Conference on Harmonization is releasing their third release this year. So that's really going to be the format that most of us will be conforming to when we do our clinical trials. The World Health Organization has seen it fit to enter in the fray to make some recommendations to try and get better, faster, more equitable and optimized clinical trials. And this is part of the 75th World Assembly Declaration. And what they have encouraged us to do as a society is really to prioritize the development and strengthening of national clinical trials capabilities. So this is one of the things that we're trying to work through here in the Jamaican context, and certainly at the CARICOM level is something that we're trying to promote as well. PAHO took the initiative in this region to actually hold several meetings, one of which was the last was in September 2024, where it created some guidance for the best practices for clinical trial. And ultimately what the goal is, as I said, is to have more sustainable, strong national clinical trials ecosystems. So certain barriers were identified, main related to the regulatory environment and the funding environment. And so certain recommendations by PAHO have been made to regional governments as to how it is that we can strengthen and improve the clinical trials ecosystem within the Caribbean. In Jamaica, we have looking at some of these issues that we can actually try and resolve. Notwithstanding, there are quite a few players within the Caribbean. Certainly CARE at the University of West Indies Mona campus and the Faculty of Medical Sciences Clinical Trial Unit are just two of the institutions at UWI that are involved in the clinical trial space and have produced phase 1 to 3 clinical trials over the last 10 or so years. We do have centers in Puerto Rico, and in the Bahamas, you have the Partners Clinical Research Center that also conducts phase 1 to phase 4 clinical trials. So notwithstanding the barriers, we do have clinical trials players, but the idea is really to strengthen this whole ecosystem across the Caribbean. I'll be closing my presentation by briefly mentioning the roles of this newly created office of the Office of Research, Innovation and Partnership. And so in order to understand this, we really have to step back and say, what are the roles of universities? The role of universities are mainly threefold: knowledge creation, knowledge transmission, and the holistic development of individuals and our societies. So how do we go about knowledge creation? Knowledge creation is one of the products of research, right? That's really what we do when we do research. And of course, knowledge transmission speaks to the teaching and learning activities that all universities are involved in. And so when we undertook to restructure the Mona campus at the executive level, what it basically meant was that the end product of that is for us to identify and put at 2 executive levels individuals, one for the teaching and learning. So we have a deputy principal for student success. And at the deputy principal level, we have now created a new principal director for research, innovation, and partnership, which is myself. So we now have a principal director of research. And of course, the other supporting levels at the executive levels will be like our bursar, campus registrar, and facilities manager, what we call the business support executives. So the function goals of ORIP is really to ensure that we coordinate campus-wide all the research activities to try and advance our research reputation and to leverage a quadripartite grouping, which is private sector, public and institutional partnership to drive research in our teaching and learning, to facilitate a culture of innovation across the campus, and to facilitate the translation of our research findings for societal impact. We do have a special project in the office, which we call our Global Health Project. And so that project will also be handled by the office. So as a consequence, the Office of Principal Director, we do have quite a wide range of reports across the UMONA ecosystem, which involves our MONA Office of Research, our Office of Director of Graduate Studies, the Ethics Committee, MONA Library, other campus-wide research entities, and for the social accountability component, we have a Center for Community Development and our School of Global Health. And our innovation ecosystem that we're trying to launch will involve a wide diversity of players. The digital enablers, which will come from our Faculty of Computing Sciences, our entrepreneurship component, which is MONA School of Business, or MONA Entrepreneurial Center, and our Community Center for Community Outreach, as well as our legal and innovation hubs that we'll be creating over the next few months. The office will really be focused on, of the many sustainable developmental goals, we'll be focusing primarily on 3: good health and well-being, industry innovation and infrastructure, and partnerships for goal. That concludes my quick run on research collaborations, both from a regional perspective and from a UMONA perspective. Thank you, and I'll take any questions now.
So I have a question. What strategies have proven most effective in sustaining long-term research partnerships between the Caribbean and international institutions?
So the main strategy is really institutional. So that's really it. So it's really the creation of these institutional framework and institutional agreements that helps. So that's the top level thing. The other thing really has to be what we call shared research interest and goals. So that really requires you the establishment of what we call research networks. Research networks, as I said, there are several ingredients for their success. One is the ideas, the things that we would wish to continue. So for I give an example, I'm part of a network called CARIS, which is the Caribbean Association for Research on thalassemia and sickle cell. And what are the things that drives that organization? The main thing is, of course, the interest of the members in trying to improve the lives of persons with sickle cell disease. And of course, the ability to get some funding. And so the short answer to your question is really twofold. First is institutional. And then the second one is really going to be, what are the commonalities? What are the research areas or research questions that you will wish to create? Once you create that, there's what we call network dynamics that will help keep the network alive and allow the partnership to be productive.
Thank you so much. Any other questions? So Professor Reed, I don't think we have any further questions. And before I thank you, I also want to send prayers from the MONA campus, Bahamas, to everybody in Jamaica with the possibility of a hurricane hitting, we definitely will keep you in our thoughts and prayers. And we thank you graciously for those insightful reflections on how regional partnerships strengthen our research impact and capacity.
All right, thank you so much. Fortunately for me, I'm not in Jamaica, unfortunately, returning tomorrow. But I do hope, as I said, that you do continue to have a successful conference. I think it's important that as Caribbean people, we try and investigate problems that are unique to us, that will improve the health of our own people. Oftentimes, one of the things which I didn't mention is because sometimes we're unwilling to invest in our own in research nationally. A lot of time researchers seek foreign funding to do the research. The challenge to that is to be competitive in those foreign funding. You have to now work on problems that they are more interested in rather than what you are genuinely more interested in. And so what that produces is that it produces a Caribbean person who internationally is well respected, but the output or the product of that work may not necessarily be as beneficial to the community from which he originated. And so that's one of the big challenges. And so one of the things that we have done is really to try to encourage our local community, both the private sector as well as the government, to try and invest some more in health research for our own people and for our own development. That has received variable level of success. As I said, one of the things here we were successful in getting is a fund for wellness. But I do think more and more governments will have to earmark, especially as some of the other traditional funders become more insular in their approach for funding. More and more will have to be thinking through how can we utilize the talent that we have here in the Caribbean to address the issues that are important to us. So I know in the Bahamas, you will have to be doing the same sort of things with your own government. But also importantly, how do we bring the private sector foundations, typically, how can we sell it to them that research is not an esoteric thing? It's really finding out what it is that is important to you as a community and applying these standard techniques that we have at our disposal to give you the answers that you have. And that research represents an investment in your human and so societal development. So that's really the idea that I really wanted to convey and to encourage you all to continue along the road and to encourage you to continue your lobbying efforts, both at the private sector and with the public sector, to get the research dollars that you need to do your work.
Yes, definitely. And on that note, our local research not is only going to affect our community now, but our future communities going forward in terms of how we build healthcare and other areas of our country. So our next presentation brings a message of the importance of research home. It's a global problem, but a lot of times looking at our unique population is helpful in terms of how we can combat these problems. So our next presentation brings that message home, addressing one of the most heartbreaking challenges in pediatrics, which is sudden infant death syndrome, or SIDS. Having personally been involved in several SIDS cases, I know the pain of those moments and lasting impact they have on families and care teams alike. That is why research and education in this area are so vital. Please join me in welcoming Dr. Olivia Lockhart Chase, pediatrician in the Department of Pediatrics, presenting her study entitled Evaluating the Knowledge of Parents and Caretakers in New Providence, the Bahamas, on the risk and preventative measures of sudden infant death syndrome.
Was 2 minutes. Just give us 2 minutes, please.
I'm Dr. Olivia Chase. Good afternoon. My topic is evaluating the knowledge of parents and caretakers in New Providence, the Bahamas, on the risk and preventative measures for sudden infant death syndrome. I don't have any conflicts of interest with regards to this presentation. So sudden infant death syndrome is the leading cause of death worldwide. It has a global mortality rate of 20.9%. This was found in 2019. It is defined as a sudden unexpected death of a child under 1 year of age that remains unexplained after thorough investigation. So the triple risk model, in order to explain SIDS, was developed by Fulano and Kinney in 1994. It describes a vulnerable infant who has a critical developmental period and outside stressors all combined together to lead to the cause for SIDS. Now, this concept has been debated due to cultural and practices and beliefs worldwide. A study done by Caesar et al. In 2019 in Brazil, this involved over 2,000 women. It found that 8 out of 10 women had no knowledge of the correct sleeping position of an infant. Factors that played a role included low level of education, high parity, as well as having an increased number of persons in the bedroom. Now, during this research, despite them providing prenatal consultations, sleep positions were influenced by the maternal grandmother, as well as cultural practices strongly influenced the risk for SIDS. The CDC conducted a sudden unexpected infant death case registry in 2022. In the US, they discovered that of the 1,800 deaths that were done between 2011 to 2014, 79% of these infants at the scene of the investigation had soft objects that obstructed the airway, and 69% of these infants that were found dead had use of a soft mattress. So for my methodology, The study involved parents or caregivers from both PMH as well as the private health sectors in Nassau, Bahamas. Interviews were conducted with parents of the infants that were under 12 months of age in either the hospital obstetric wards or at private physician offices. And ethics was approved by the PHA-UE Ethics Committee. A cross-sectional quantitative approach was used, with participants being selected through convenience sampling. Data was collected using online questionnaires via SurveyMonkey over a 3-month period between June and August 2024. The study focused on parents or guardians responsible for infants under the age of 12 months, excluded where the parents were not primary caregivers or the parents of children with any specific medical conditions like GERD, or those who were under the age of 18. 251 participants were needed for this study. The instrument used was a questionnaire adapted from a study by A. Algoez in 2021, which included 30 questions, which included the participants' demographics, sleep practices, as well as the knowledge on SIDS. Now, the knowledge score ranged from 0 to 6, with 0 to 3, a score of that meaning that the participant was not aware, 4 to 5 meaning they had acceptable awareness, and 6 meaning that they were fully aware, based on their responses to specific statements. The data was securely stored on SurveyMonkey and analyzed using statistical software. Now, confidentiality was maintained throughout the entire study, and the data collection was supervised to ensure integrity and proper handling. For the results, looking at the socio-demographic profile, the age group most significant was ages 25 to 34, which had 47.1% of the population. For the nationality of the participants, 79.3% were non-Bahamian and 98.4% of the participants were mothers. In regards to the level of education, the participants, 63.1% of them at least had a secondary school education. And looking at the smoking status, 68.6% of the participants were non-smoking or did not have a family member who smoked. For the method of feeding in the first 2 months, for breastfeeding, whether it was combined feeding with continued breastfeeding for 2 months or breastfeeding alone, a combined total of 93.5% of these participants had breastfed their infants. In looking at sleeping practices, the position of the infant slept in, 54% of participants placed their infants on their back, which is the correct sleeping position. 16.1% placed the infant in the bed, which is the incorrect sleeping position out of the 4 options available. And 76.9% of the participants would use a thick blanket or comforter for their infant, which is not recommended and is actually one of the leading causes for SIDS. For mattress use, 51.7% preferred a soft mattress over the recommended firm mattress use for the infant. When asked about pacifier use while the infant was sleeping, 62.5% said they preferred not to have a pacifier for the infant to use. However, the American Academy of Pediatrics actually recommends using a pacifier to help prevent SIDS. And 70.9% of the participants said they would place some type of object in the infant's bed, which is one of the major causes for SIDS. And 75.8% said they would not have the infant sleeping in a separate room from the parent, which the recommendation is to wait until 6 months of age. Now, they're planning to sleep the parents at nighttime. 61.9% said that they would have the infant sleep with them at nighttime. And 9.6% of participants said that they would have the infant sleeping in the bed with someone who smokes. In regards to the source of knowledge where participants were getting their information from, 61.8% 1% said that social media and online content was their major source of information. And only 24.5% had a full awareness score on SIDS with a score of 6. In looking at the factors associated with the knowledge score, including educational level, income, nationality, location where the questionnaire was filled, and the age and relationship to the child, the only significant factor was the educational level, which played a significant role when it came to the knowledge score on SIDS. Findings, there was significant correlation between educational level and knowledge of SIDS, and many of the participants, they lacked full awareness. This is particularly with unsafe sleep practices like co-sleeping. So despite many of them saying where they knew where to put the baby, as in a separate apparatus from the parent's bed, a lot of them still co-sleep together and having the infant come in their bed. Smoking was also a major risk factor. And while many parents, they knew about the safe sleep positions, their dangerous behavior still persisted based on their answers to the questionnaire. And just in looking at the results, the influence of online resources and social media on parents' knowledge, it may lead to inaccurate or outdated information on SIDS. The recommendations after this study was completed was to promote government-sponsored prenatal classes, to educate parents about SIDS, the risk, and the prevention methods. Also to place on healthcare workers their education level. We can do this by organizing seminars for healthcare workers in obstetrics and pediatric departments to ensure accurate information on SIDS are shared with the family. And then also to request some SIDS awareness campaigns. So we can ask for government funding, for national ads, especially on social media, since that seems to be the most popular platform to help educate parents and relatives. And then also it would be good to collaborate with the pathology department at PMH to gather postmortem data on SIDS, helping to strengthen the case to increase for funding and awareness on efforts, because we don't really know what the actual numbers are for SIDS in our population. So in conclusion, this study aimed to assess parents and caretakers' knowledge of SIDS. We concluded that most of the population lacks full awareness of risk factors related to sleep practices and objects. This knowledge gap is attributed to the factors such as poor health literacy, limited access to reliable information, as well as possible cultural influences. Now, further research is needed on SIDS-related infant death rates in the Bahamas, particularly in both urban and rural areas. This is to better address the issue throughout the targeted public through health campaigns. These are my references. Thank you very much. And just to acknowledge those who helped in creating and having this presentation and this research followed through. Sincere thanks.
Thank you, Dr. Lockhart Chase. I'll now open the floor for any questions.
I have a question for May, please.
Go ahead.
Thank you. I enjoyed the presentation, and I note that you excluded the participants under 18, and I definitely would recognize that there's some practical reasons for you doing that. My question is, what do you think is the impact of excluding that population from the study?
Hi, good day. Thank you for your question. So for the population under 18, of course, that will require us getting both consent and assent with them being minors. So that was the reason why they weren't included in the study. I think it would be ideal to include young mothers, just because they may be a vulnerable population who may not be as well educated as their adult counterparts. So I think it would be good to actually explore that population in terms of adolescent pregnancy and seeing what the impact is. And I think further research can be done to even compare, let's say, because we have a high rate in teenage pregnancy compared to that of adults, and to see what the actual, so the root of the matter is actually finding out what our SIDS numbers are in terms of what rate is occurring in the country. We can actually compare to see what is the age of the mothers in terms of how old are they and who is it happening to? Is it more so older moms, middle-aged moms, or young moms? So I think it's a very good question and something we can take a look at.
Yeah, you may be able to get yourself an estimate of the size of the error introduced by looking at the percentage of those minors with children compared to the rest of your population with children. But thank you very much for your answer.
Any further questions for Dr. Lockhart Chase?
Sure. May I be permitted to just ask her one question?
Sure.
All right. So, Dr. Lockhart, how generalizable do you think your findings are?
Okay, she's trying to log back on. We'll give her a moment.
Hi, good day. Sorry, it got disconnected. My apologies.
Prof. Reed, can you repeat the question, please?
Sure. I was just asking, how generalizable do you think your findings are?
Oh, so I was saying for my population size, it mainly targeted mothers. Ideally, it would be ideal. I mean, ideally, we would like to look at other participants, including fathers, as well as other caretakers and grandparents. Now, of course, this is just a starting study, and we would need to get more information, whether that would be on other persons who play a factor, so other caretakers, and even possibly healthcare staff, and even persons who run daycares or nurseries who take care of younger children.
No, I accept that. But amongst a group of individuals who identify as mothers, how generalizable would that information be that you have collected?
Well, based on the amount of based on the population I looked at and those who are coming into the hospital, I think the statement is pretty generalized in terms of the population.
So just to emphasize, so the challenge I have is the sampling frame that you use were women who attend the hospital, right? But ideally, you would want to make a statement as to what is the burden of this issue in the Bahamas, in the island, whichever it is. And so the extent to which you have sampled to reflect that is really the extent to which you can make a generalizable statement. So if the hospital you think would capture the vast majority of women who would have a baby within the age span, then yes. But if the hospital doesn't, then the truth be told is that you wouldn't be able to make that sort of a generalizable statement as to the level of knowledge of the community. So that's really what I'm trying to get a feel for.
So just for that question, the majority of women who come from the family islands to have their baby, with us being the hub hospital or the main hospital, a lot of them come here to have their baby once they're at term. So, I mean, that would exclude Freeport, but for the outer islands, for the most part, they will have to come here.
Yeah, that helps.
Any further questions for Dr. Lockhart Chase? Okay, I think that ends that segment. Thank you, Dr. Lockhart Chase, for that powerful and deeply meaningful presentation. Your work reminds us of how knowledge and awareness can truly save lives. Continuing our focus on maternal and child health, our next presentation examines another important area, neural tube defects. Our next presenter, Dr. Lovell Murray, will share her research entitled Neural Tube Defects, Screening, Risk Factors, and Management with the Use of an Illustrative Case Report in the Bahamas. Please join me in welcoming Dr. Lovell Murray.
Good afternoon. My name is Dr. Lovell Murphy, and today I'll be presenting on a case entitled Neural Tube Defects, Screening, Risk Factors, and Management with the Use of an Illustrative Case Report in the Bahamas. I, along with Dr. Simone Joaquin, as well as Dr. Nicholas Burrows, were collaborators on this report. I don't have any disclosures at this time. So neural tube defects are congenital abnormalities of the central nervous system, inclusive of the brain and spinal cord. They occur due to a failure of proper closure of the neural tube, which is an embryologic precursor of the CNS. It is a well-researched disease entity on the international basis. However, Bahamian data is scarce. According to an article produced by Benklo et al., these defects are relatively uncommon globally, as the prevalence among live births in the United States is 1 in 1,200, whereas worldwide the prevalence ranges from 1 in 1,000. The etiopathogenesis of the disease process is complex, and there are a number of proposed risk factors for the development of neural tube defects, with most cases occurring from inadequate supplementary folic acid intake. There are many different types of neural tube defects affecting the brain and the spinal cord, as seen here in this image. The report seeks to report on a rare case in the Bahamas of a newborn with myelomeningocele with concomitant Chiari-4 malformation. It seeks to highlight the risk factors and importance of antenatal screening management principles of neural tube defects, with an emphasis on myelomeningoceles. The study involves a 31-year-old woman, gravida 2 power 1, who was noted on routine fetal antenatal anomaly scan screening at 22 weeks gestation to have an open neural tube defect in the lumbosacral spine, with presence of hydrocephalus and an absent cerebellum. Upon proper extensive history taking, physical and laboratory screening, there were no associated maternal or familial risk factors for the development of neural tube defects in this case. The patient lacked comorbid conditions, no known chemical exposure history, no surgical history, and no significant family history of prior neural tube defects. She denied any prior or current illicit drug use and initiated folic acid supplementation very early on in the pregnancy. Throughout the pregnancy, the mother had consistent antenatal care, and routine antenatal testing was remarkable for a chlamydial infection, which she was treated for successfully. She had close follow-up and was categorized as being high risk. A multidisciplinary approach was initiated early in the managing teams, inclusive of neonatology, obs and gynae, as well as neurosurgery. They were made aware for collaboration for delivery and management thereafter. An uneventful elective C-section was carried out at 38 weeks gestation under spinal anesthesia. At the time of delivery, the infant had an APGAR score of 6 and 8 at 1 and 5 minutes, respectively. On physical exam, the child was alert and awake with a head circumference of 33 centimeters, hypotelorism, low set airs, and a 5x7 myelomeningocele in the lumbosacral region with no active CSF detected. There was paraplegia of the bilateral lower limbs with no sensation below the level of the lesion. This figure here shows 5x7, figure here shows a 5x7 oval-shaped neural defect at the posterior lumbar region with no active leakage. Vitals shown here were significant for mild respiratory distress. The cardiovascular and abdominal system was normal, and a widened metotic suture was noted. The child was kept in the prone position and a wet gauze was placed to the defect. Given the ultrasound findings, physical exam, and respiratory distress at birth, the patient was transferred promptly and managed in a NICU setting under close supervision. Before undergoing surgery, the neonate received comprehensive pre-op care, which included blood investigations inclusive of cultures, which all came back normal. The patient was also started on empiric antibiotic therapy, received a 2D echo and a CT brain that showed no evidence of hydrocephalus at that time. A KUB and voiding cystourethrogram revealed, as expected, a neurogenic bladder, which required intermittent catheterization thereafter. Before surgery was undertaken, informed consent was obtained from the parents. CT brain performed prior to surgery showed a Chiari-4 malformation, but no evidence of hydrocephalus. Here in this image under microscopy, the margin between the arachnoid of the neuroplacoid and dystrophic epidermis was incised. The neuroplacoid was dissected free from the surrounding junctional zone, and the placoid was closed, as we see here in the second image. The sacral myelomeningocele was surgically repaired successfully by the neurosurgical team, and plastic surgery assisted with wound closure. The patient received intermittent catheterization secondary to neurogenic bladder. It was noted on cultures that he developed a UTI and required antibiotic coverage. In the subsequent days following surgery, a VP shunt was placed given the gradual progression of the head circumference, and evidence of communicating hydrocephalus was seen on CT scan. However, the child remained stable with no features of raised intracranial pressure. The shunt was placed after confirmation and treatment and clearance of the UTI. Here we see the before and after pictures, and in the after picture, there's a complex reconstruction of skin post-repair with a pinwheel flap and drain in situ to evacuate any collection under the skin flaps. After surgery and adequate stabilization, MRI scans are performed to further analysis of the brain and spinal cord defects. Imaging revealed an atrophic, severely hypoplastic cerebellum with occipital lobe occupying the posterior fossa with associated herniation across the foramen magnum and evidence of a cervical cord syrinx. In the first image here, we see that the occipital cortex extends into the posterior fossa where the cerebellum should normally be anatomically. In the second image, the occipital horn of the lateral ventricle in the posterior fossa is shown by this hyperintense area. Here we have two images. One, the first one being post-surgery that shows no evidence of hydrocephalus, and the second showing evidence of hydrocephalus. Myelomeningocele must be recognized early, especially through antenatal screening, so that parents can be informed of the possible outcomes. Screening programs for neural tube defects became available in the 1980s. Patients are screened with ultrasound as well as measurement of maternal serum alpha-fetoprotein, which is a glycoprotein produced by the fetus. Initially, MSAFP levels were the mainstay of screening protocols for patients until there was advancement in ultrasounds. It is important to note that an elevated level may also be due to benign causes such as multiple gestations and incorrect gestational age dating. Therefore, an abnormal MSAFP level must be followed up with fetal ultrasound. This can detect multiple gestations, determine an accurate gestational age, as well as visualize any CNS defects. The clinical presentation of myelomeningocele can range from mild cognitive impairment to severe developmental abnormalities and neurologic deficits. The malformations can be associated with defects including a syrinx and hydrocephalus as seen in this case. At the time of diagnosis, the mother was extensively counseled and informed on the different types of neural tube defects, and most specifically the Chiari-4, which was seen on her ultrasound. Of note, the Chiari-4 is rare, accounting for about 1 to 4.5% of all Chiari cases. It is known to have a poor prognosis, with most cases culminating in death. The other types of Chiari's, Chiari malformations are seen here in this table. And of note, Chiari 2 malformation is mostly associated with myelomeningoceles. When discussing neural tube defects, it's important to understand the risk factors. And in the 1970s, Smithers et al. Noted that the serum concentrations of folate were reduced in mothers with fetuses that had neural tube defects. In a subsequent trial by the Medical Research Council in 1991, it was concluded that folic acid is the essential factor for significant prevention of neural tube defect recurrence. Strategies were implemented to fortify food with folic acid, as well as guidelines to ensure all pregnant women took increased supplements during their pregnancy. High-risk pregnant women should adhere strictly to the recommendations in order to decrease their risks. High-risk factors include maternal diabetes as well as obesity, and other risk factors include environmental exposure like arsenic and teratogenic medication. The genetic causes can involve multiple factors, including genetic mutations and familial patterns. For example, mutations involving the folate metabolism, such as the methylene tetrahydrofolate reductase, have been linked to a higher incidence of these defects. We cannot definitively rule out the possibility of genetic factors. Genetic testing could be done to further investigate. Management of neural tube defects requires a multidisciplinary approach that addresses the various medical needs of affected individuals, starting from prenatal diagnosis all the way through long-term follow-up. In this case, the myelomeningocele repair was carried out on the third day of life and was followed up by reconstruction of the skin defect for closure. Urgent repair of the myelomeningocele is paramount to aid in the prevention of any further neurologic damage, to prevent environmental exposure, as well as, most importantly, to decrease the risk of infection. Closure should ideally be done within the first 72 hours of life. However, experts in the field note that anywhere between 24 to 72 hours is suitable. And the closure technique employed here was the layered closure approach. In more developed nations with access to specialist care, fetoscopic repair is opted for. The MOMS trial is a clinical trial that studied intrauterine repair versus repair postnatal. This trial demonstrated that intrauterine repair decreased the incidence of developing a hydrocephalus. However, there was no significant change in the extent of neural deficits. Based on these outcomes, fetal repair is now considered a standard of care in some specialty fetal centers if the criteria is met. And here we see a table of the inclusion and exclusion criteria for MOMS. After surgical intervention, regular monitoring for neurologic, orthopedic, and neurologic complications and resources are necessary for the child and the family. Shunt placement requires long-term monitoring, and the average patient may also require 2 revisions of the shunt during their lifetime. Of note, in more advanced centers, choroid plexus cauterization and endoscopic third ventriculostomy are used as an alternative to VP shunts. This can possibly reduce long-term complications. During follow-up appointments, screening for tethered cord syndrome and scoliosis should also be done. In conclusion, neural tube defects are congenital abnormalities whose management is based upon symptomatology and complications of the disease. In this case, we evaluate a child with cerebellar agenesis, myelomeningocele, and hydrocephalus necessitating a VP shunt. The child is currently 15 months with global developmental delay, showing signs of babbling and attempts to sit upright unassisted. Regarding this clinical case, we emphasize the importance of an early prenatal diagnosis and folate administration in mothers before conception to decrease the risks. Knowledge of family history and genetic screening is also influential to clinical decisions. Once the case report is finalized, a crucial next step involves conducting additional research to examine the trends in the incidence and prevalence of neural tube defects in the Bahamas following the fortification of foods with folate in the year 2000. Here are our references, and we extend our sincere gratitude to Dr. Burrows and other members of the management team for their contributions to this case. And at this time, we will start accepting questions.
So I have a question. Given the fact that we don't test for the MTHFR gene for our folate metabolism, do you think it would be well advised, or did you see any related research on giving all mothers methylated folate to prevent the possibility of neurotube defects in those that have this gene mutation?
So genetic testing is a consideration. However, there are a lot of factors that would prevent people having access to it because of the cost and the accessibility of it. So there could be a benefit of giving mothers methylated folate to prevent the increased risk of neurotube defects.
Great, thank you. Any further questions for Dr. Murphy?
And just to add to that, there have been studies done that fortified certain birth control with methylated folate to aid in the prevention of neurotube defects as well.
Good day, Dr. Hannah here. Just a question concerning the risk factor you mentioned of diabetes. How strong is this correlation with diabetes? Sorry, what type of diabetes is the causative agent or seem to be associated, whether it's gestational or versus adult onset or juvenile onset?
So in general, diabetes is considered to be a high risk factor because it doesn't really vary by the type, whether it's type 1 or type 2. But because of the disease process, there's oxidative stress that causes disruption of the genes that control folic acid. And so that within itself causes an increased risk of neurotube defects.
Okay, thank you.
Any further questions?
Mic test.
Okay, thank you, Dr. Murphy, for that thoughtful and necessary presentation. Your research highlights an often overlooked area of prenatal care. We now move on to an inspiring example of innovation in clinical care with the novel use of fish xenograft in an immunocompromised child. And I would like to mention that pediatrics was also involved with this case. It was definitely a roller coaster ride, and I think it's going to be a very interesting presentation. Please join me in welcoming Dr. Whitney Ferguson-Winder, presenting her case report entitled Novel Use of Fish Skin Xenograft for Wound Management in an Immunocompromised Child.
Hello, good afternoon. Right. So I'm so happy to be here. I am Dr. Whitney Ferguson-Winder, and I...
Speak up.
Okay, is this better?
Yeah.
Okay, great. I'm so happy to be here. I'm Dr. Whitney Ferguson-Winder. I'm a part of the plastic surgery team, which is led by Dr. Greg Parthy, Dr. Fitzcharles, and I have co-registrars, Dr. Scabella, and at the time, Dr. Isaac. And so our case report is entitled The Novel Use of Fish Skin Xenograft for Wound Management in an Immunocompromised Child. We have nothing to disclose. And so wound healing, as we know, is a complex process as it involves the patient's wound level conditions, as well as biological, environmental, and socioeconomic factors. This process is even more complicated in an immunocompromised child or patients who exhibit an increased susceptibility to infection and delayed healing. While conventional strategies exist, such as skin grafting, they may be less effective in this population, leading to the exploration of different approaches. And so this case report describes the successful use of a fish skin xenograft for the potential management of a wound in an immunocompromised child, highlighting the potential of this novel therapeutic option. So this is a case of a 4-year-old male who presented to the pediatric team with sudden deterioration in his ability to ambulate, with hypertonia in his lower limbs. Upon investigations, he was diagnosed with a malignant intramedullary rhabdoid teratoma of the spine at the levels C6 to T1 on MRI. He was commenced on chemotherapy after a multidisciplinary team discussion. And during his 9th cycle of chemotherapy, including the drugs etoposide and ifosfamide, he sustained an IV extravasation to the dorsum of the right foot. With rapidly progressive cellulitis and skin necrosis to the IV site, the protocol of the hospital was established and the plastic surgery team was consulted. On general examination, we noted an emaciated child with abnormal frog leg posturing of his lower limbs. The focus examination of the lower limbs revealed a decrease in the bulk, hypertonia, and hyperreflexia. The power was noted to be 1/5 bilaterally. His lower limbs were also insensate. The right foot dorsum showed extensive skin necrosis at the old IV site with no associated signs of infection. The assessment was an extravasation of the chemotherapy agents with likely full thickness elements of necrosis of his skin and the subcutaneous tissue. The plan was to allow demarcation, to debride, and to select an appropriate method of wound coverage. This figure 2 is an image of the injury day 9 post-consult. So we had a wound 5 by 6 centimeters with a central area of necrosis with surrounding erythema. He was monitored regularly, and we allowed the wound to demarcate itself. Figure 3 shows a fully demarcated injury. This would have been day 11 post-consult. And so at this time, debridement and irrigation of the wound was done. There was no exposure of any underlying critical structures. Serial dressings were done until the wound bed was deemed fit for grafting. This is day 11 post-debridement. It was at this time that the plastic surgery team considered autografting versus xenografting. And given the fact that this patient was immunocompromised, the creation of a second wound discouraged the consideration of an autograft, and the trial of xenografting was considered even more. Thankfully, we had keratase that was donated. 14 days post-debridement, the plastic surgery team used a fish skin-derived xenograft. The right lower limb was prepped and draped for asepsis. The wound was excised to a healthy bed. The fish skin graft was moistened in a room temperature saline as per the recommendations of the manufacturer. The graft was applied and secured with 5-0 monocryl sutures. We applied a non-adherent sterile bolster, and we reapplied his resting splint. The dressing was removed 2 days post-application, and figure 5 shows what the wound looks like. Since then, he had serial dressings done. The image to the left, figure 6, shows day 15 post-grafting. The image to the right, figure 7, shows 18 days post-grafting. And here we note a healthy wound. Figure 8 shows the actual outcome when reepithelialization of the wound took place. And this is exactly 2 months post-grafting. It showed that there was adherence, there was minimal inflammation, you had progressive epithelialization over an 8-week time frame, which aligns with the findings of keratase. It induces low immunogenic responses due to the preserved structural proteins, making it suitable for the immunocompromised child. Unfortunately, it was at this time that the patient succumbed to his illness, so we have no further follow-up images to show. How is the Caricis prepared? So the fish itself is the wild-caught North Atlantic cod, and it's harvested from clean, cold Icelandic waters. Sourcing is done under sustainable fishing practices regulated by the directories of the fisheries. The dorsal skin is preferred for harvesting because it is the thickest and it has the most rich collagen supply. It is removed under sterile conditions. It is then trimmed and appropriated for thickness and size. Then it undergoes the decellularization process, where there is removal of the cellular and the antigenic material, such as the DNA, the cellular debris. But there's preservation of the native extracellular matrix structure, including collagen type 1 and type 3, elastin, as well as the glycosaminoglycans, which are all beneficial. Lipid retention, the lipids are retained, which includes the omega-3 fatty acids, unlike mammalian grafts. And that contributes to anti-inflammation as well as the antimicrobial benefits, which greatly help the wound. Sterilization is done via gamma irradiation. We remove the microbial contaminants, and then packaging is done. So it's dried under controlled conditions, it's cut, and it's sealed in sterile single-use packaging. And then it's stored on shelf. So I've included a picture of what the Caricis fish skin looks like. I've also decided to include an electron microscopic picture of the human skin to the right and the fish skin to the left to show the similarities between the two. So as said before, skin grafting is a common method of assisted wound closure, and here in the Bahamas, autologous skin grafting is considered to be the standard. Fish skin prevents the creation of another wound, especially in the immunocompromised patient, and it is a hypoallergenic xenograft derived from the Atlantic cod. Another option can be the Nile tilapia. With this xenograph, Caricis, we met the complications of a target. Targets of a complication-free treatment, which was the improvement and acceleration of the wound healing process, the prevention of the potential colonization of a pathogenic biofilm, the reduction of pain, and necessary dressing changes. So the use of Caricis allowed graft integration, rapid granulation, which was done within 1 to 2 weeks, epithelialization. The wound progressed through different phases through proliferation and re-epithelialization in a 2 to 4 week time period. We had inflammation control thanks to the omega-3 fatty acids. We had infection control as a result of the sterilization and again the omega-3 fatty acids. And we had a timely wound closure. There was no need for a second wound or reoperation or grafting, and there was good cosmesis. So why is it that we are talking about using or the use of fish skin? It is because, one, there are no documented cases of the use of fish skin for wound management in the Caribbean. The first study that I came across, a multi-centered, blinded, randomized control study, showed that the application of fish skin to previously non-responsive diabetic foot ulcers resulted in significantly more fully healed wounds at 12 weeks rather than the standard of care alone. Another study on diabetic foot ulcers also showed that treatment with intact fish skin graft was superior to the standard of care in proportions of wounds healed at 16 weeks, and it was associated with a faster healing time. So this shows that the fish skin does not need to be limited to plastic surgery, but it can also be or expand to general surgery for diabetic foot ulcers and necrotizing fasciitis. In conclusion, this was a novel approach that proved effective in the management of a complex wound in an immunocompromised child. The fish skin xenograph has been shown to provide a biodegradable scaffold that promotes cell proliferation, angiogenesis, and the deposition of new extracellular matrix, thereby facilitating the wound healing process. These are my references. Thank you. Any questions from the audience for me or my team members?
Yes, may I intervene? I'm Dr. Bloomfield.
Hello, Dr. Bloomfield.
Yeah, wonderful presentation. Certainly shows progress. But
Thank you.
can you just let me have further information, everybody that's listening? How easily is this available and what is the cost like? Because again, we have several persons who could benefit from this patient population. But again, is it something that the average person or even a few can look forward to being treated with?
Well, the cost of it. So research shows that the cost of Kerecis is $155 per square centimeter. And while it is costly upfront, there have been studies that showed that the long-term care for patients actually exceed the cost of Kerecis upfront. Now, in our setting, most things are free or reasonably affordable for the Bahamian population. So I can understand why it may be more expensive upfront, but the studies show that long-term, it's more reasonable, it's more affordable for the Kerecis. I hope that answers the question.
Availability.
Honestly, it's not very available or easily available to our population. The access that we had was by donation. And so I do believe that, if we make contact and there's a possibility of us having more, the amount I can't speak to, but it's certainly something to look into.
Thank you very much. Well done. I said thank you very much. Well done.
Thank you, sir.
Just another question.
Sure.
Whitney, can the fish be used to treat persons with sickle cell disease with leg ulcers? Did you see any
Absolutely
on that in your research?
Yeah, it can be used to treat persons with sickle cell disease. We've done a venous ulcer. We've done a patient who had a venous ulcer, and we've also done it in burns patients. We had a patient recently, that you may be familiar with, who had a scald burn. And initially he was healing well. And it turned out that he had an episode that caused hypoperfusion to his burns. And so after debridement, we used the Kerecis on him, and it turned out to be a beautiful outcome. And so, yes, it can be used with patients with sickle cell disease. I've not come across any research that says that it can't be. Any other questions?
Thank you. Any further questions?
Okay, thank you so much for your time.
Thank you, Whitney.
Thank you.
Thank you, Whitney, for that remarkable and innovative presentation. Your work beautifully captures the spirit of this session, where science, creativity, and compassion come together to improve care. I want to thank everybody for coming to such a dynamic segment. Unfortunately, our last keynote speaker is unavailable due to unforeseen circumstances. So we will end shortly. And everyone is to return for 3:10 for a start time of 3:15 for this afternoon session. Just a reminder to complete feedback information in order to request CMEs. The cost is $100, which can be paid at the UE office in cash or via wire transfer. And if you have any further questions with regards to that, you can email the UE office. Thank you, everybody, for joining. Have a great day.
Welcome to another Nestle Education Segment Bite for healthcare professionals only. The World Health Organization recommends exclusive breastfeeding during the 4 months of life and continued breastfeeding for as long as possible. In our quest to provide the best, we have gone a step further, studying breast milk to understand what it delivers for growth and development. This study has birthed our newest option, NAN, with optimized protein, probiotics, and human milk oligosaccharides, while maintaining the proven macro and micronutrients we combined before. As we balance the ingredients of our exclusive combination for reconstitution by your little patients, we ensure even more of the solid components are represented in our infant formula, now including HMOs, specifically 2FL found in 80% of breast milk worldwide and account for 30% of the HMO component. Coupled with the right amount of protein for structural cell and tissue formation, essential neurons and hormones, and general overall body functions, NAN has all that an infant formula currently needs. Even the probiotic blend is superior among infant formulas on the market with our specific selection for the growing infant. Choose NAN with your patients unable to breastfeed for this exclusive combination today. For any further questions, please reach out to a Nestle representative via telephone or WhatsApp. Do enjoy a fruitful conference. Goodbye.
all began with the dream of a team holding in hand a disruptive 10-year strategic plan intended to rekindle growth in the Caribbean economy. A strategy to refashion an excellent academy, the University of the West Indies, now 7 decades deep in service to its community, with an objective to lead it beyond its historic legacy, to grasp its long-desired destiny. The UWI, a strategy group, 5 campus principals, pro-vice chancellors, registrars and finance officers, student organizers, ardent administrators and managers, and a vice chancellor. Backed by 17 Caribbean governments, supported by tested global partners, over a dozen distinguished universities, and a network of determined development donors. The plan, bold and courageous, was to take it to a place it had never before inhabited, to the top, there to dwell among the best, the world's best. For 5 arduous years, it was prepared to take international ranking tests. It did emerge at the top with the very best. First in the Caribbean, from a field of over 100 distinguished universities and top 4% of the global best. The journey to the top took 1,000 steps, each a calculated choice, options for opportunities, rising on the shoulders of veterans and stalwarts, hundreds of men and women who fought heroically through the colonial phase to arrive at this stage. Revitalized with a one UWI vision, the UWI was launched upon its next voyage, leaving behind, with solemn celebration, the ancestral university of the prior century. Upward and onward, the new UWI was forged and refashioned as a university system, a system with multiple sectors, local and global. A 21st century university system redesigned to meet the region's future needs, guided by its AAA strategic plan with pillars of access, alignment, and agility, a vehicle for the voyage along the higher education highways of the future. First came the restructuring and refocusing of the open campus, and finally a 5th campus led by Principal Griffith, experience in action, erupting in the 5 islands community of Antigua and Barbuda and bearing its name. But in between, 8 new global university centers planned in partnership with the best universities. With the State University of New York, a joint center for leadership and sustainable development. In China, with the Global Institute for Software Technology, a joint center to train Caribbean software engineers in the sizzling technology park of Suzhou. In Africa, with the University of Lagos, Nigeria, a center for culture and arts. And in South Africa, with the University of Johannesburg, a joint center for global African studies. In Canada, with Brock University, a center for Canada-Caribbean studies. In Cuba, with the University of Havana, an institute for sustainable development of the Caribbean peoples. In England, with Coventry University, a joint center for industry academic partnerships. In Scotland, the UWI University of Glasgow Centre for Research and Reparatory Justice, making history, the first university to apologize for enrichment from slavery and agreeing to pay reparations. And in the making, 2 new centers, one in the European Union to foster Caribbean post-Brexit interests, the other in South America, in Colombia, a joint teaching and research project at the University of the Andes. Finally, UWA rose as a founding partner in the 10-member University of Miami-based Hemispheric University Consortium, an online strategy to revolutionize research collaboration across the hemisphere. The UWI system then is a re-engineered global enterprise rooted in the Caribbean with a Caribbean mandate. While forging a bright future, it is sweeping away the dark colonial past. First, It institutionalized a gender policy, empowering and celebrating women within the system. Then Milner Hall, symbol of a celebrated imperial apartheid era, now erased and renamed by resident students, Freedom Hall, a lesson in liberation. Repatriated to regional justice, the role and function of the Queen of England as our visitor. Finally, a Center for Reparations Research and the P.J. Patterson Center for Africa Caribbean Advocacy, established to promote and guide the completion of the decolonization process. The UWI system, a new academic enterprise, transformed to better serve and sustain the transformation of the Caribbean region. The journey to the top was principally driven by programs with specific pedagogical purposes to protect and propel the people of the region. See, for example, the excellence of UWI medicine and UWI science active in the field, side by side with governments, fighting the war against viral pandemics. First with the Zika task force in 2016, now with the COVID-19 task force, both led by the persistent, dependable Professor Clive Landis. COVID, chronic disease, and climate change, the three deadly C's of Caribbean society, confronted, contested by UWI science. The UWI science sector, selected to lead climate change advocacy by the International Association of Universities, with a team of top-class scientists, Michael Taylor, David Smith, and John Agard, now preparing to pioneer the creation in the Caribbean of the world's first climate-smart university. The UWI system, a 21st century alignment-ready academy, now prepared to bond in capital markets with the private sector, aligned with top-class companies, companion travelers, Sagicor, NCB, JMMB, Republic Bank, Flow, Grace Kennedy, and a dozen others, focusing on funding top-class teaching and research. The Mona model, the passionate pursuit of revenue. Principal Weber, weaving magic to keep his city bright and well-watered, capturing capital to bring fruit home to his beloved Mona. Professors of practice, a class of honorary icons of industry brought on board to pave the path, strengthening industry academic relations. The UWI system ready for a new funding frontier beyond the public treasury into the territory of private equity, inviting investment partners to sustain the academy. Heads of governments meeting in Haiti agreed to reconcile all receivables in an assets for cash exchange. Prime Minister Rowley leading the field with the Couva Hospital deal, government and university owning and revenue sharing, calling Principal Copeland to craft UWI's largest ever project, an artery from St. Augustine to Couva to Destiny de Bay. Prime Minister Motley, sincerity on show, honored the Barbados debt, injected cash, reviving Cave Hill, connecting Principal Barito to Bridgetown, there to imagine a smart campus from gown to town. Grenada, granting 88 acres of land, and the Bahamas pledging 20 in Nassau. St. Vincent financing the largest open campus site, launching the mind of Principal Longsworth of the open campus into a new online orbit. But rising and capturing the top, ball beating were the students, creating sporting history on the journey. The combined campuses team, gloriously winning the 2018 Regional Super 50 Cricket Championship, defeating all challenges, claiming the status best cricket team in the West Indies. And there was more to the tour. Two students, Jason Holder and Carlos Brathwaite, carefully nurtured.
Testing. Testing. All right, so good afternoon, colleagues and esteemed guests. Welcome back to the 2025 Research Day Conference. I am Dr. Cherie Longley Thompson, family medicine physician for the Public Hospitals Authority Family Medicine Department. Today, I have the privilege of moderating this afternoon session under the theme From Screening to Management, Addressing Health Challenges in the Bahamian Population. As we start this new segment, I encourage all of you to fully connect with our speakers through your undivided attention. Be engaged with your thought-provoking questions and commentary, and to be receptive to the ideas and information shared by our presenters today. To minimize interruptions, please remember to mute your microphones and wait for permission to ask your questions at the end of each presentation. This segment is worth 2 CME hours, which you can claim with payment of the $100 registration fee and by completing the feedback questionnaires on Sunshine Learner. The CME code will be displayed on the screen. During this session, we will have research presented by the Department of Family Medicine, as well as the Rand Memorial Obstetrics and Gynecology Department and the UWI Mona Campus Medical School. But first, on behalf of the Research Committee, I have the distinct honor to introduce our keynote speaker, consultant obstetrician gynecologist at the Sir Lester Bird Medical Center in Antigua and Barbuda, Dr. Cherie Tulloch. She will speak on cervical cancer screening with her topic, HPV-based cervical screening in the Caribbean, Opportunities and Challenges. Dr. Tulloch is a consultant obstetrician gynecologist at the Sir Lester Bird Medical Center and is the technical lead for Antigua and Barbuda Ministry of Health Cervical Cancer Elimination Program. She is also an honorary fellow in the medical research at the University of the West Indies, Five Islands. Dr. Tulloch is a graduate and a postgraduate alumna of the University of the West Indies Mona Campus, and a fellow of the American College of Obstetricians and Gynecologists. She is a published author, contributing to numerous peer-reviewed research concerning women's health and cervical cancer prevention. And she co-authored Data Journey Map, a process for co-creating data requirements for healthcare artificial intelligence. Nationally, Dr. Tulloch is recognized for her exemplary leadership in cervical cancer prevention initiatives, such as directing the expansion of the colposcopy services and establishing gynecologic oncology service at the Sir Lester Bird Medical Center, spearheading the introduction of high-risk HPV DNA testing as the primary screening modality, and guiding the development of Antigua and Barbuda's first comprehensive cervical screening and pre-cancer treatment guidelines with the support of Pan American Health Organization and Basic Health International. In recognition of her incredible work, Dr. Tulloch was the first Caribbean national to be selected as a young leader in global cancer control by the Union for International Cancer Control in 2023 and completed her UICC Technical Fellowship in 2024. So without further ado, let us extend a warm welcome to Dr. Cherie Tulloch, here to speak on HPV-based cervical screening in the Caribbean, Opportunities and Challenges. Dr. Tulloch, you have the floor.
Organizers for inviting me to speak today. I'm trying to navigate screen. Okay, right. I have no disclosures, no conflicts of interest. Today, we're going to speak about, we're going to just describe the current burden of cervical cancer internationally and regionally, look at the pathogenesis of cervical cancer very briefly, and cervical screening, outline the principles of screening and the components of a screening program, and understand the shift from cytology-based screening to HPV-based screening. We're going to describe the current state of cervical screening in the region and outline the challenges and opportunities that come with HPV testing, and use Antigua and Barbuda as the Antigua and Barbuda experience to demonstrate some of the opportunities and challenges. So cervical cancer, the reason we're speaking about cervical cancer is because internationally, we have about more than 500,000 new cases being diagnosed, with more than 250,000 deaths every single year. And unlike the other cancers that affect women, the disparity between the developed and the developing countries is most widely seen with the biggest disparity, seen with cervical cancer. Cervical cancer is the fourth most common cancer being diagnosed in women worldwide. Now, when we look at the Caribbean region and we look at the incidence of cervical cancer, we're just a little above the world average. And when we look at the individual incidence rates for some of our countries in the Caribbean, we see that countries like Jamaica and Trinidad and Tobago have historically had the highest incidence rates. When we look at the mortality, again, Jamaica is seen having one of the highest incidence rates, only surpassed by Guyana, and this is 2019 data. The most recent data that we have still confirms that cervical cancer is the fourth most common cancer affecting women in the Caribbean. And presently, it's the 8th most common cause of death from cancer amongst both men and women. Now, the cause of cervical cancer is the human papillomavirus, which is responsible for about 95% of the cases that we see. There are about more than 150 types. But when we talk about high-risk HPV testing, we're talking about the 14 high-risk types that are associated with the development of cancer. Now, cervical cancer is not just cancer that develops on the cervix. There are different histological types. The most common being squamous cell carcinoma and adenocarcinoma, both of which are mostly associated with HPV infection, most commonly type 16 and 18. Of course, there are other cofactors such as smoking, early coitarchy, having HIV, and long-term oral contraceptive use. Now, when we look at cervical cancer, if I ever have anything good to say about it, is that there's this really long stage before the development of cancer that we call precancer. And it's broken down into cervical and intraepithelial 1, 2, and 3, with most persons who would actually get HPV and develop what we call CN1, 90% of persons will actually clear it on their own over about a 2-year period. But with the persistence of HPV infection over average of about 10 to 15 years, sometimes longer, persons go on to develop CN2 and CN3, which is of course the immediate precursor to development of cervical cancer. And the pictures that you see at the top are images that we see at colposcopy when we take a closer look at the cervix. And if we can detect women, and if we can detect those changes, at colposcopy, then we can treat women and prevent them from going on to develop cervical cancer altogether. So it's the only cancer, when you look at all the cancers affecting women, this is one cancer where 95% of the time we can actually prevent altogether. Now, all HPV, all high-risk HPV is not the same. Type 16 and type 18 carry a higher cumulative incidence rate compared to the other high-risk types. Now, in the WHO life course approach to cervical cancer control, what you see is HPV infection is common. Let me just start there. More than 80% of us will get HPV at some point in our lives. We see the highest prevalence of HPV infection in the late teens going into the 20s. And then usually after that, as women approach their 30s, that's when we start to see the development of precancer. And that's where our screening is focused. Now, as much as I've said, as you approach 30s, in some Caribbean islands, they're seeing cervical cancer in a slightly younger demographic. Now, once we've identified cervical precancer, we have different treatment modalities. We have ablation, where we use you can either freeze or you can use heat to treat. And then, of course, we also have our excisional procedures where we remove that area on the cervix that has started to undergo the change and prevent the cervical cancer. So when we talk about the concept of screening, I think we would have already made the argument for the condition, cervical cancer being an important health problem, and of course already indicating that there's a very clear treatment that can be carried out to prevent the woman from going on to develop cervical cancer. As we transition to HPV testing from cytology, we have to uphold the other components of screening, such as the test being valid, reliable, safe, and acceptable, and it being in the context of a program that is sustainable and cost-effective, and of course, equitable, meaning that it's accessible to everyone, and there is, you uphold the ethical and social principles. Now, organized cervical screening is not just a test, it is a system, right? A system that has some core components where it must be governed by a national policy, and there must be a clear linkage between screening and treatment, and you have to integrate that screening program in other existing services, and you have to have quality assurance, you have to train your staff, you have to engage your community, and you have to have ongoing monitoring and evaluation. So let's talk about which screening test. Well, in the Caribbean, the two most common tests available are your conventional pap smear and your HPV testing. So we'll speak mostly about that. In certain instances, you may see visual inspection with acetic acid, but that's not very common. Now, most of the screening tests are provider collected, but there are opportunities for self-collection, as we'll see with HPV testing. Now, in this Denmark study that was done between 2002 to 2003 and involved more than 25,000 women, it was demonstrated that high-risk HPV testing was significantly more sensitive than cytology in identifying women who had high-grade lesions, that CN2 and CN3 that we spoke about in the earlier slide, while cytology had a slightly higher specificity in these two instances. By and large together, women who have a positive high-risk HPV test and an abnormal cytology have about a 42% chance of having a high-grade lesion, as opposed to a woman who may have a high-risk HPV test and a negative cytology. So when we look at screening in this context, we have to be clear on the question we're trying to answer, which is who is at risk? And when we ask this question, based on all the information we've just shared, we know that HPV testing is better than cytology. Once you've identified a woman at risk through HPV testing, the next question you have to ask is, how likely is she to have a high-grade lesion? And by doing HPV typing, by using your cytology, by using HPV mRNA testing or VIE or colposcopy, you can better identify the woman who therefore needs treatment to prevent her from going on to develop cervical cancer. So why HPV testing? Well, it has a higher sensitivity. You have longer screening intervals because of its high negative predictive value. So you can actually go as far as 5 years to 10 years before the next test. It is objective and reproducible because it's not dependent on human interpretation. It detects women earlier in the disease process, which is a good thing because you can actually monitor those women more closely. And as you'll see later on, the problem with that is that you will have, you capture a lot more women, and not all of them are actually going to necessarily go on to develop high-grade lesions. You have the possibility of self-collection. It's better suited for low resource settings, especially when you have low human resource settings, and it's cost-effective long-term with, of course, the decreased screening to treatment intervals because of the quicker turnaround for results. So the WHO, having recognized the superiority of the HPV testing as part of its 90-70-90 targets to eliminate cervical cancer as a public health problem, has actually recommended that we aim to screen 70% of our women with HPV testing, once by the age of 35 and again by the age of 45. And if we can do this, and by 2050, we would have millions of women would be saved from going on to develop cervical cancer. Many guidelines have actually adopted this approach. So certainly for women aged 30 and above, most screening recommendations involve either primary HPV DNA testing or co-testing, where it is combined with the cytology. The alternative, of course, is using the cytology as a triage test and also using genotyping. Now, when we look at what countries are doing internationally, we can see that most countries here in light blue are still have cytology-based screening programs. And the Caribbean is no different, with very few countries actually introducing HPV testing as a primary modality. When we look at the progress in our region with HPV testing, Antigua and Barbuda would have piloted HPV testing and already scaled up and introduced it as the primary screening method in our country. And then you have St. Vincent and the Grenadines, which is preparing to pilot HPV testing as well. But most countries are not yet at a point where it is being adopted as the national approach. The good thing is that most countries, all countries, I should say most countries, have colposcopy and pre-cancer treatment facilities. So we recognize that in the Caribbean, we still have about a 56% screening coverage when it comes to cervical screening. And only about 35% of countries in the Americas actually have achieved a 70% coverage target. So in recognition of this, the WHO and the PAHO are helping us improve access to HPV testing so that we can increase our screening coverage. There are a few HPV DNA testing platforms available that have been WHO pre-qualified and are available through pooled procurement through the strategic fund, the PAHO strategic fund. Of course, this helps us to better make it easier for us to access these platforms, which can cost individuals anywhere from 30 to 100 US outside of this procurement mechanisms. So let's talk about the screening program. Well, the countries that are already on their way to eliminating cervical cancer characteristically have very high HPV vaccination coverage, and their screening programs are very well organized with HPV and HPV based. They have strong treatment and diagnostic infrastructure. They have good data systems to allow for monitoring and evaluation of their program, and there's a strong national commitment for the elimination of cervical cancer. And we see that especially in Australia. When we look at the situation here in the Caribbean, and of course, this is data a little old, 2012 to 2013, but that's most available. We see that most countries in the Caribbean have capacity, of course, for treatment of pre-cancer and cancer. They have clinical guidelines, but they don't, a lot of them lack policy, programs, management of those programs, and a dedicated budget for cervical cancer programs. So the answer for us here in the Caribbean, and it's been said many times throughout the sessions this afternoon, is international collaboration, I would say regional collaboration, and leveraging our support from overseas, and of course, strong political advocacy. We specifically would have to make screening evidence-based. We have to improve our screening coverage through our community mobilization, and we have to transition from opportunistic screening to invitation-based screening. We have to improve the efficiency of our services through training, and we have to be able to assure or ensure quality. And I'm just going to go through Antigua and Barbuda's experience in implementing HPV testing. and this was heavily supported through PAHO, Basic Health International. Before this began, Antigua and Barbuda demonstrated readiness, first by being the first country to access HPV vaccination through PAHO and introduced it in our vaccination program, with our primary target group being ages 9 to 13, both boys and girls. And we did that in 2018. We also were among the countries that participated in the CanScreen 5 training, which was put on by the WHO and IARC, and basically helped to strengthen countries' ability to collect data and, of course, monitor and evaluate their screening programs. We even hosted a virtual cervical cancer symposium during the COVID pandemic, which brought together our experts in the region as well as internationally to discuss the WHO global strategy for elimination. So recognizing that Antigua and Barbuda was ready, PAHO worked and Basic Health International worked with us to have training sessions. That was the first step, where we looked at HPV testing and treatment and how we would introduce and scale up that program in our country. It started off virtually over 5 sessions. We spoke about planning, implementation and scaling, monitoring and evaluation and development of a plan. And we aimed to have to screen at least around 2,500 women in the target age group of 30 to 49 over a 5-year cycle to achieve the WHO target. No, okay, I don't know what it's, okay. All right, so Antigua and Barbuda has all the facilities really to combat cervical cancer. Screening takes place in private facilities as well as in our 26 clinics. All colposcopy takes place at our sole public hospital, which is the Sir Lester Bird Medical Center. We used to have a radiation center. We're waiting for that to come back on board. And of course, our oncology services, our medical oncology services, are also available at our hospital. All testing goes to our lab at the Sir Lester Bird Medical Center, and Sir Lester Bird Medical Center is, of course, also where a lot of our treatment takes place. And when we looked at our hospital between 2016 and 2020 and looked at the cases being referred to the oncology unit, the gynae oncology cases, we recognized that cervical cancer accounted for almost half of the cases that were being referred, and most of those women were stage 2 and beyond at referral. 70% of women were receiving treatment, and unfortunately, we lost 33% of our women during that time. During that time as well, we saw an increase in the number of cases being referred to the oncology department. This in no way represents all the cancer on our island, but of course would represent a majority of the cases. When we looked at our screening between 2018 and 2020, when we were mainly cytology based, we were screening less than 50% of our target population, with only 13% of that screening taking place in the public service. So of course, we started to collaborate with our local and regional stakeholders, and we got support again from PAHO to move towards the elimination of cervical cancer with an aim to screen 1,500 women over a 6-month period using the Gene Expert platform, which represented about 11.6% of the target population. Testing would take place in the clinics where women were very carefully counseled, of course, because HPV testing is different from cytology, and to help women understand this change and understand what the results were going to mean. This was done in the clinics, and then all the samples were transported to the hospital weekly and processed in the lab. And we began using an electronic health record system to allow results to be available electronically within a 2-week period. So we, for women who had type 16, 18, or 45, those women were referred directly to colposcopy. For women who were positive for other high-risk types, they underwent cytology triage and then would have gone to colposcopy if they had ASCUS or higher. For women who had a normal cytology, they would be tested again in 1 year. For women who were negative, they would be tested again in 5 years. So we were able to actually screen more than the 1,500. We screened 1,545 women, and we found that we had a 21.7% positive high-risk HPV positivity rate. Of that, 7.5% had 16, 18, and 45. No, this wasn't really out of keeping with the already existing data in the region. As you can see here, I think Martinique had the largest population size sample that we could come across, and they had a similar HPV prevalence of 19.4%. In terms of follow-up, all our women with 16, 18, and 45, of those women, 90.5% of those women followed up. But for the women who underwent a cytology triage, we lost some of those women to follow up, and so we only had a 67% follow-up. Overall, 76% of our women received treatment and 75% were followed up. Now, just for comparison, when we went back and looked at what we were, our biopsy results between 2019 and 2020, and in our gynae department at the then Mount St. John's Medical Center, we found that we were picking up a lot of negative cases, or CN1, with only 30% of our women having the high-grade lesions, which are the lesions that we focus on the most for treatment and prevention of cervical cancer. When we compare this to our what we saw in the pilot, we were picking up a significantly more high-grade lesions with very little negative biopsy results. In terms of our time indicators, there was a significant difference in the time from HPV testing to treatment for our women who had type 16, 18, and 45, and who would not have undergone a cytology triage, compared to the women who needed a cytology triage of almost 2 months. So introducing this, cytology in our region has been challenging, and so we weren't surprised to see this time difference, and that remains a challenge for systems, not just our system, but for many. In terms of the challenges that we identified that we still had, well, we still needed to develop our policy. We needed quality assurance. We needed to expand our treatment availability, because we were picking up a significantly more cases. We needed to develop a protocol, and we needed to have more information and education taking place. And so the first thing we did is that we had an on-site training workshop in our lab for quality control for HPV testing. We, through PAHO, we were able to undergo pre-invasive disease training with the IGCS. And this is our team of doctors and nurses who underwent that training. And so Antigua and Barbuda has really been the first country to benefit from the PAHO WHO guidance in HPV implementation and scaling. Now, we were actually also picking up cases of cervical cancer earlier, which meant that they were now, instead of being rendered only for chemotherapy and radiation, we were now able to offer surgery for cure. And we picked up about 4 cases. All of those cases came from the 16, 18, and 45 group. And of course, in order to meet the needs of those patients and our other gynae oncology needs, the Ministry of Health got Dr. Wayne Quinlan, who is a gynecologic oncologist, to work with us. And now we have established that service to provide better care for our women, not just with cervical cancer, but other gynae cancers. We were also able to establish leadership from management of our cervical cancer program. We updated our screening forms to capture the data points that you would need to calculate your indicators for monitoring and evaluation of the program. And we utilize health information system called SELMA, which is available through RealMed. And we now are using that to capture all our data for our women being screened in primary care. We also convened a stakeholder consultation for the development of our national guidelines. in November 2023. And by 2024, we were able to present our first national guidelines for screening and the treatment of precancer lesions, which outlined our national approach for screening, including for women living with HIV. And we went on, of course, to utilize the strategic fund to continue to procure HPV testing. From our experience in the pilot, we recognized that we needed to centralize our HPV testing. What do I mean by that? So when testing took place in the clinics, we actually bring all the tests to a central unit, and we are able to capture all of the data in the electronic health record system, whereas it would have been difficult for us for each clinic to have reliable internet service, and also for nurses to have the time to be able to put in that information that we need. So we centralized all of that. And of course, we send those samples off to the hospital, we receive the results, and we coordinate all the activities, including contacting screen positive patients and making sure that they're referred to the colposcopy unit, which makes it easier for monitoring and evaluation. So Antigua and Barbuda's journey has been long, but we're happy to be where we are now, and we're grateful for the support that we've gotten. And as we move forward, we're hoping to establish our cancer and screening registry. And we are currently looking at, we're currently embarking on looking at the role of AI in colposcopy for improving our colposcopy services. And this is, again, the colposcopy workshop that was held along with the University of the West Indies Five Island campus and the Sir Leicester Bird Medical Center and the International Agency of Research in Cancer earlier this year, where we had our colleagues from the region, including Bahamas, join us to explore the role of AI, even as Antigua and Barbuda begins to utilize this technology and assess the role it could play in the future. So what's our take-home messages? Well, transitioning to HPV testing for cervical screening significantly improves the screening rates and efficiency, but it requires an increased pre-cancer diagnostic and treatment capacity. And countries have to be prepared to invest in the entire continuum of care and the public education that's needed to support that care. HPV testing access for countries has improved significantly through PAHO and the PAHO Strategic Fund, and achieving the 90-70-90 WHO targets as a region will require regional support, regional collaboration, and information sharing. And of course, implementing HPV testing offers opportunities to improve other aspects of our healthcare delivery. And these opportunities should be identified and capitalized upon. So I thank you for your time and attention, and I welcome any questions.
Thank you so much, Dr. Tulloch, for that presentation. The floor is now open for your comments and questions. Dr. Thompson.
Good day, Dr. Tulloch. Thank you for your very, very important topic, cervical cancer, HPV. The question I have is, we are treating women for cervical cancer.
I'm not hearing. So sorry, I'm not hearing anything. I can see that someone is speaking.
I apologize. So I want to say thank you again for your timely topic on HPV and how we are managing women that are getting this sexually transmitted infection. What I want to find out from you, what are we doing about the sexual partners? I know we are treating the women for HPV and the cervical cancer, but what about their partners? Any research or anything that is being done about the sexual partners? Thank you.
Thank you so much for that question, and that's a question we get all the time. And I'll say this: whenever a woman tests positive for HPV, we're actually diagnosing a couple, right? So both her and her partner her partner is likely to be positive as well. The reason we don't test men, or the primary reason, is because men are not affected the same way as women, meaning that because of cervical cancer, because we can actually pick up there's a pre-cancer state that we can do something about. That's why we test women, so that we can avail them to that. When we test men, we're not going to be intervening. There's no treatment for HPV. So when you look at the principles of screening, we wouldn't actually test men. And yes, men can be affected, but penile cancer is extremely uncommon. And so it would not meet the criteria for screening and testing, right? So the other thing to bear in mind is resources. And HPV test is expensive. So we're grateful to be able to access it through the strategic fund, but you have to use those resources wisely. And if you're not able to do anything for the men, then of course you have to ask yourself what would be the benefit of testing the men. I hope that puts it in context at least.
Thank you for that question, Dr. Thompson. Any further comments, questions for Dr. Tulloch? I will check the chat. No? Okay. So thank you once again, Dr. Tulloch, for your talk. We will now transition to our clinical research presenters for this afternoon. But before introducing our first presenter, a reminder, please, to all attendees to mute your mics and reserve your questions and comments for the end of the presentation. So first we have Dr. Thurston Dorsett. Dr. Thurston Dorsett is a family medicine physician practicing in Nassau, Bahamas for the Department of Public Health. She completed her family medicine doctorate of medicine degree with the University of the West Indies, Bahamas campus in June of this year. And today will present her DM research titled Factors Associated with the Quality of Life Among Elderly Bahamians Attending Selected Primary Care Clinics in New Providence, the Bahamas, a cross-sectional study. Please welcome Dr. Dion Thurston Dorsett.
All right. Can you all hear me? Okay. Good afternoon, everyone. I am Dr. Thurston Dorsett, and I am so happy to be sharing factors associated with quality of life among elderly Bahamians attending selected primary care clinics in New Providence, Bahamas, a cross-sectional study. I have no disclosures or conflicts of interest in regard to this presentation. You may or may not know, but the world's population is aging and growing at an unprecedented rate. By 2050, the UN projects that 1 in 6 people will be 65 years or older. And for the first time in world history, this population will outnumber children aged 5 years and younger. This demographic shift is also occurring quickly in the Caribbean, affecting both young and old age profile countries. The Bahamas fits right here between Jamaica and Barbados, and our elderly population is projected to double between 2023 and 2060. Population aging presents a significant global burden with a complex set of challenges to many aspects of society. There is a global initiative focused on keeping the elderly healthy, independent, functional, and contributing to their societies. Measures of quality of life are being used to evaluate the overall well-being of both elderly patients and elderly populations. And the goal is to maintain or improve quality of life with this increase in longevity that we are seeing. Quality of life is a multidimensional and highly subjective concept. The WHO defines quality of life as an individual's perception of their position in life in the context of culture and value systems in which they live and in relation to their goals, expectations, standards, and concerns. Our aim and objectives were to assess quality of life among elderly Bahamians attending selected primary care clinics in New Providence, to describe their socio-demographic characteristics, and then explore factors associated with quality of life among these seniors. The study setting was New Providence, Bahamas, home to our capital city and the most populous island in the Bahamas. A cross-sectional study was conducted from October 2024 to February 2025 among 5 selected clinics, which were chosen by convenient selection. Our study population included elderly people aged 65 and older attending public primary care clinics in New Providence, and participants were recruited using a convenience sampling approach. Our participants met the following inclusion criteria. They were 65 years or older, residents of the Bahamas, who were able to give informed consent and understand our questionnaire. They attended one of the selected clinics for routine follow-up visits, annual visits, or had a non-emergent complaint. They were able to understand and speak English and were willing to participate in our study. Persons who were acutely ill, L35, developed in Britain. It is validated and a highly reliable tool suitable for assessing quality of life in older adults. This tool has a self-reported global quality of life rating and 13 statements covering 7 domains like health, home and neighborhood, and financial circumstances. Participants were asked to indicate their level of agreement with each statement, and items were summed up for a total quality of life score. Higher scores indicated higher quality of life category. All data were entered into REDCap and analyzed using Stata 16.1 software. Descriptive and summary statistics were done to assess our data distribution. We used t-tests to compare our mean quality of life scores of our dichotomous independent variables. A Pearson's correlation test assessed the association between age and quality of life. And a linear regression was used to assess associations between quality of life scores and our socio-demographic variables. A multilinear regression model was constructed using the variables from our bivariate analysis to identify our predictors of quality of life. Moving to results, 367 seniors participated in our study, and our response rate was 92%. The majority of participants were female. Participants had a mean age of 74 years. Most participants were married and were living with their families. The largest proportion of our seniors had a secondary education, and most were living in uncrowded conditions. Most of our seniors were retired and relied on some form of government pension as their primary source of income. Most participants did not consume alcohol or experience a fall over the last 12 months. 92% of our seniors had a medical illness. And the top 3 were hypertension, diabetes, and arthritis, as shown here. Approximately 1/3 of our seniors had at least 2 medical illnesses, and just over 10% had as many as 4 to 6 medical illnesses. Most seniors rated their global quality of life as good, and the majority of them had a fair or better quality of life as indicated by their scores. Our participants scored highest and were most satisfied with the aspects of life in the psychological and emotional well-being domain. They were least satisfied with aspects of life in the financial circumstances domain. Statistically significant differences in the mean quality of life scores were observed between individuals with and without the medical conditions seen here: CKD, cardiovascular disease, dementia, and depression. Age and quality of life demonstrated a moderately negative correlation. However, it was not statistically significant in this data set. The red bars in this slide show our 6 negative associations with quality of life, and they were depression, dementia, crowded living conditions, daily alcohol use, CVD, and CKD. Green bars in this slide show our 2 positive associations with quality of life, which were having a tertiary education or being married. In our multivariate model, Red bars display our negative predictive factors of quality of life, which were depression, CKD, daily alcohol use, crowded living conditions, and family as the primary source of income. Whereas our green bars displayed our positive predictive factors, which were being married, living with family, or having a secondary or tertiary education. On to our discussion. This research highlights the quality of life among our study participants, and 95% of our study participants had a fair or better quality of life. This was better than what we had hypothesized and comparable to some of the other international studies in my lit review. There were a number of socio-demographic, medical, and socioeconomic factors influencing quality of life in this elderly population. Both marriage and living with family emerged as factors predictive of a better quality of life. And these relationships usually promote well-being by providing emotional, financial, and caregiving support, all of which enhance quality of life. Education plays a key protective role in quality of life among the elderly, and this was also observed in other studies. And we can understand this because education supports income generating capacity, lowers poverty risk, and improves health literacy, which preserve independence in later life. So we must all push education. We must continue to ask about those GPAs and use every visit to educate our patients. These factors were associated with lower quality of life, and most of them were identified as negative predictive factors in our study. For the sake of time, I will only touch on two aspects that we looked at. As physicians, we play a very strategic role in preserving quality of life for generations to come. 92.4% of our participants had a CNCD, and CNCDs have a detrimental impact on quality of life in this elderly population. Prevention is key. Early detection, and proper management of CNCDs are crucial. And I want to highlight depression, which emerged as a major negative predictive factor. Unfortunately, it is often underdiagnosed and undertreated in the elderly. So screening for depression is imperative in this population. We must also screen for alcohol misuse and abuse, which is also an important negative predictive factor in this population, and both of these can be easily missed. Researchers such as Phyto et al. In 2020 also looked at advocating the use of quality of life measures in clinical practice to identify patients with high mortality risk. These results highlighted the resilience of seniors in our study. Despite their challenges, participants showed strong faith, gratitude, and perseverance, which are all key elements of quality of life. Most had several positive predictive factors, which may explain why the majority of our seniors had a fair or better quality of life. Our study limitations include selection bias due to our convenient sampling approach, desirability bias, as our survey was researcher administered, and also recall bias. In addition, our participants were only recruited from the public primary care sector in New Providence, and these limitations can limit the generalizability of our findings. In conclusion, to the best of our knowledge, there is no published studies in the Bahamas that focus on quality of life and factors influencing quality of life in elderly Bahamians. These findings highlight gaps in our knowledge and the need for a multi-dimensional approach to address these critical factors in order to maintain or enhance quality of life in our population as it continues to age. I would like to acknowledge the following people. These are my references, and I thank you.
Excellent presentation. Any questions? Let me check any questions in the chat? Any questions from the room? Okay, so I have one question. Any of your findings came to a surprise to you? Any of those that you did not expect to be highlighted as a positive or negative predictor for quality of life?
That came as a surprise. I guess I would say family as primary source of income, but I do understand why that emerged as a negative predictive factor. Family as your primary source of income implies some dependence, and financial dependence also puts elders at risk for neglect and abuse and a lack of autonomy and lack of independence. And so I can understand why that emerged as one of our negative predictor factors.
Thank you for that great presentation, and congratulations once again on attaining your DM. Any further questions, comments? Okay, thank you. Just allow for a minute, please, for our next presenter.
Good day, excuse me, Dr. Hannah here. Can I ask a question?
Sure, go ahead.
Well, it's to Dr. Thurston as well. What factor of any disability of the female play in the study of the how they get it? Were they able to drive themselves, or did they have to depend on others to get healed? And I know that the sample was pretty much those persons who came to the test. We just wanted to know did mobility play a factor?
From what I encountered, most of our seniors were dropped off at the clinic, usually by children on their way to work. And some of them were still driving. I'm not sure I'm understanding your question, Dr. Hannah. Could you repeat that?
Yes, I was just wondering about the general mobility. You know, persons as they get older, they have arthritis and so on, they may not be able to move around much. And so you may have persons who may not come to the clinic just because they cannot get them when they're
Yes.
On their own or with the system. So I'm
Right.
just wondering about the general physical fitness and mobility of the persons in your study, were they generally fit? Do you think that that is a factor for the positive outcome?
Well, for the participants of the study, they were patients of the clinic who were able to either be brought and transported to the waiting area in a wheelchair, or they used canes, or they were just independently able to ambulate on their own. Now, we did not go into the homes. We did not go into nursing homes. We did not look at elderly who would have been institutionalized. So that was one of our study limitations. We did not evaluate those other populations of elderly Bahamians. So that's for further studies.
Thank you.
Any further questions or comments? Okay, we'll be ready in about a minute. Thank you for your patience. So next we have Dr. Anthea Wood Musgrove, who is also a family medicine physician practicing here in Nassau, Bahamas. She completed her doctorate of medicine in family medicine this past June with the UWI Bahamas campus, and she will be presenting her DM research topic, assessing the prevalence of diabetes distress and associated factors in patients with type 2 diabetes at community clinics in New Providence, the Bahamas. Please let us give Dr. Wood Musgrove our undivided attention. Welcome to the podium.
Thank you, Dr. Longley, for that introduction. I am Anthea Wood Musgrove, and my project is entitled Assessing the Prevalence of Diabetes Distress and Associated Factors in Patients with Type 2 Diabetes at Community Clinics in New Providence, Bahamas. There are no conflicts of interest or financial disclosures. Diabetes distress is the emotional and psychological burden of managing diabetes and its impact on daily life. As physicians, we have all dealt with diabetic patients, but have we dealt with diabetes distress? Perrin et al. Conducted a systematic review and meta-analysis of 55 articles, none of which were from the Caribbean, and found a worldwide diabetes distress prevalence of 36%. In Barbados, DeSantis et al. Had a diabetes distress prevalence of 17% in their patient population. Patients with diabetes can often present to our clinics with unstable glucose readings or passive or aggressive behavior. That is, if they adhere to their clinic appointments. Diabetes distress not only affects self-care, glycemic control, and quality of life, but it can also lead to burnout in patients and in their caregivers alike, including we medical professionals. However, it is poorly recognized in the Bahamas, evidenced by a lack of data. Numerous randomized controlled trials have found diabetes distress is amicable to various therapies and best treated by primary care physicians in the outpatient setting. So our question, what is the prevalence of diabetes distress, its associated factors, and the most common source of diabetes distress in patients with type 2 diabetes attending community clinics in New Providence, Bahamas? This study was important and is still relevant because screening for diabetes distress can reduce its burden, improve patient care, and raise awareness. However, there is no research done in the Bahamas and limited published data from the Caribbean. The aim and objectives was to report the prevalence of diabetes distress, determine socio-demographic and clinical factors associated with diabetes distress, and to determine the most common cause of diabetes distress in the study population. This study was cross-sectional in nature, conducted from October 2024 to February 2025 across 4 community clinics, including Elizabeth Estates, Flamingo Gardens, Fleming Street, and Elizabeth Estates Clinic. It used a convenient sampling approach and ascertained 295 adults with type 2 diabetes. Adults aged 19 to 80 with at least 1 year of type 2 diabetes, living in New Providence for at least 1 year, and able to consent were included.
Those pregnant, lactating, severely ill, or with major complications or psychiatric disorders were excluded. Our minimal sample size was surpassed in this study. Our instrument was a self-administered 55-item paper and pencil-based questionnaire, which included open-ended and multiple-choice questions, and was pre-tested for its clarity, cultural relevance, and completion time. Our screening tool was the Type 2 Diabetes Assessment System. It was created by Pileski et al. In 2022 for adults with type 2 diabetes, 19 and over. This tool had very good construct variability and internal consistency. It consisted of 2 portions. The core section has 8 sections that assess the overall diabetes-related emotional distress, and the sources questions assess 7 areas known to cause diabetes distress, like healthcare access and interpersonal issues. The tool uses a 5-point Likert scale, ranging from 1, meaning not at all, to 5, a very serious problem. Main core and sources scores are interpreted as no distress, having a score of less than 2, moderate distress, a main score of 2 to 2.9, and high distress, a main score of 3 or greater. Prior to data collection, ethical approval was granted from relevant bodies. Each participant gave informed consent prior to completing their questionnaires. Data was entered and stored into REDCap, cleaned for errors and duplications, then exported to Stater for analysis, which began with assessing for normality and descriptive statistics, which include frequencies and percentages for our categorical variables, and central measures of tendency for our continuous variables. Hypotheses tested included the non-parametric Mann-Whitney U-test, and magnitudes of association were assessed with Spearman's Rho and chi-square test of independence. A 95% confidence interval and a p-value of less than 0.05 were used to determine statistical significance. The outcome variable was dichotomized with core distress scores of 2 or more, indicating that presence of diabetes distress, and less than 2 indicating no diabetes distress. Other data analytical tools used was checking for multicollinarity using the Hosmer-Lemon-Chow test, as well as the receiver operating curve, which successfully assessed the model's ability to distinguish individuals with and without diabetes distress. So, what did we find? A response rate of 83.8%. The majority of our participants in the study were female, single, and with a high school education. The mean age of participants was 60.71 years, and both random blood glucose and hemoglobin A1C levels were above normal. 14.92% of participants experienced moderate diabetes distress and 16.94% high distress, creating a prevalence in our study of 31.86%. Chi-square analysis showed younger individuals had higher levels of distress, along with those that were not married and worked full-time. Additionally, those with insulin use as a part of their treatment regimen had higher levels of diabetes distress. Hemoglobin A1C levels that were higher was linked to higher moderate distress. And high distress was more common in those with depression and anxiety. Additionally, it was also found to be higher in those with diabetic complications, such as self-reported frequent urinary tract infections or sexual dysfunction. Random blood glucose and hemoglobin A1C levels showed a very weak but statistically significant correlation with core distress. And management demands was the most prevalent source of diabetes distress, followed closely by long-term health concerns. Our final logistic regression represents 15% of the variance of core distress found. Our protective factors included being older age, reducing distress by 5% per year, and the absence of complications, which lowered odds by 66.1%. Conversely, knowing one's hemoglobin A1C slightly increased odds by a minuscule 0.3%, while anxiety nearly tenfold increased the risk of diabetes distress. So, what did we find, and what does that really mean? Diabetes distress affected nearly 1/3 of our study population, and this is higher than our Bayesian counterparts, but similar to studies from the United States and Canada. This reflects significant psychosocial stress that may be linked to westernized lifestyle and underscores the need for routine diabetes distress screening in the Caribbean diabetes care setting. Younger individuals, those not married and full-time employed, reported higher distress linked to work stresses, limited support, and concern over complications. Additionally, those taking insulin had higher distress, reflecting treatment complexity and advanced disease state, while those with complications, such as urinary tract infections and sexual dysfunction, had greater distress and reduced quality of life. Depression and anxiety was strongly associated with diabetes distress, reinforcing the link between mental health and metabolic control. This study identified management demand as its primary source, highlighting the significant emotional and cognitive burden patients may face. For us physicians, simplifying treatment regimens and integrating various counseling and interventional education interventions may not only decrease or mitigate distress, but can also improve overall glycemic outcomes. In conclusion, diabetes distress can no longer be overlooked in our patient population. Its prevalence, it's been documented now in the Bahamas, and there's a critical role for all physicians, especially in those in primary care, to assess and appropriately manage diabetes distress, as well as to promote self-management measures to decrease the burden of diabetes distress. It is now time for a holistic approach in the diabetes management in the Bahamas through integration of mental health screenings to decrease the risk and the potential negative side effects of diabetes distress. Thank you. These are my responses.
Thank you for your presentation. Very interesting. I would like to open the floor to questions. All right, there's none in the chat. Any questions from the room? Okay, so I have a question. So with diabetes distress, outside of the role of the family physician, right? Did you come across any local resources that patients can get in contact with or attend to help with reduction of their diabetes distress? So you mentioned depression, you mentioned management burden. Are there any local resources that can further aid the patient outside of them going to their primary care physician?
Thank you, Dr. Longley. That is a great question. There have been in the past diabetic support groups and education groups that can help to assist person with resources, as well as social services. They are there to assist persons. For example, a common cause of diabetes distress may be healthcare access, documented in the literature. And therefore, healthcare access is not just getting to the clinics, so those restricted to family islands or don't have transportation might be impaired, but that also means being unable to afford their diabetic medications. And so you do have local services like social services and other nonprofit organizations that may be able to assist patients with diabetes to access the healthcare system and get some of the diabetic treatment that they would need.
All right. Thank you so much, Dr. Go ahead, Dr. Bloomfield.
Yeah, very interesting presentation. In a clinical setting, we, outside, I guess, internal medicine, we often see patients that we do the routine annual checks, elevated blood glucose, elevated hemoglobin A1C, and of course, we question them about what their status has been, happy, sad. But is there anything that you would probably advise us as physicians that we ought to be looking for in the general appearance, or questions that we should begin to ask in light of what you just said?
Thank you for that. Great question, Dr. Bloomfield. So yes, for any physician, once you are managing a patient for diabetes and you are aware that diabetes distress is a possibility, your eyes become a little bit more keen. Again, these patients might have uncontrolled glycemic indices like you may have indicated, but also just asking persons about their personal life, what's going on at home, on the job, asking about simple finances, those types of things. Are they able to get their medications? Are they stretching their medications because of financial constraints and difficulties? So having a simple conversation with our patients using the type 2 diabetes assessment system as a screening tool, now that you're aware of diabetes distress, can not only identify that distress is present, but it also can give you an indication of its source. And based on its source, you can then make recommendations. So that is something that any physician can do. And again, referral. Primary care physicians have a little bit more inept and information in relation to diabetic care and management. So referring those patients back to their primary care physicians so that a treatment plan could be tailored to give a more patient-centered approach to their management is also appropriate as well.
Thank you very much for that response. Really
You're
appreciated
welcome.
that. I
Thank
learned
you.
something more today. Thank you.
Thank you, Dr. Bonfilio.
Another question, please, Dr. Hannah, here again. How much, I'm not sure if it was looked into, but a lot of the diabetics have to use needles on a daily basis, either to do their glucose monitoring or to administer insulin. And, generally Bahamians tend not to like needles or are afraid of them. So how was that a factor in terms of causing distress? And do you think that the continuous monitoring systems that are now available may be useful in this situation?
Thank you, Dr. Hannah. Very good observation of our patients. So definitely a lot of patients, especially when they have first been diagnosed with diabetes, are very apprehensive and fearful of having to routinely check their blood glucose at home. And especially if they have to take insulin, they're fearful of those injections. And a very common cause, again, of diabetes distress is the fear of hypoglycemia that's also associated with having to take the insulin. So therefore, for these patients, continuous glucose monitoring would be beneficial. But unfortunately, it's very expensive, and most of our patients, especially in the governmental community clinics, may not be able to afford it. So of course, that is an option. But again, with diabetic education and encouragement, we can teach our patients how to properly monitor their glucose at home and overcome the fear associated with having to test sugars at home and take insulin when appropriate. So it's our position to encourage and educate our patients.
Thank you.
You're welcome. Thank you.
So I have a question as well.
Go ahead, Dr. Davis.
Yes, appreciate the presentation. And I noticed you cited, if I remember correctly, studies from the US and from Barbados. And I'm just wondering if those studies were also conducted at community clinics, and does that have a bearing on your interpretation of this data, recognizing that you're seeing the people who are probably most likely to be experiencing some kind of distress? Your thoughts on that, please.
Thank you, Dr. Davis. So the study from the United States cited was actually from a outpatient setting, a Veterans Affairs Clinic in the United States, and the Barbadian study was actually in a community clinic quite similar to the setup here in the Bahamas. So definitely it makes a vast difference on how we interpret our data. Because as we know, diabetic management can happen not just in the outpatient setting, but it can be in the outpatient setting associated with a hospital or some sort of tertiary institution, as opposed to a primary care institution like our study and the ones from Barbados. We would expect that persons in the primary care setting, like our community clinics, would not have as much complications, or at least are a little bit more amicable to our therapies, as opposed to those in tertiary settings where they might be uncontrolled or have been just released from hospital because of the complications that they had suffered from diabetes. So definitely it makes a difference. But in our setting and in the Bayesian setting, the clinical patients were the same for the most part.
Okay, thank you.
You're welcome. Thank you. Thank you.
Thank you, Anthea. Okay. So I'm loving the energy thus far for today. Hope we keep this momentum up for our next presenter. So up next is Dr. Rodina Ferguson. She is another family medicine physician practicing in Nassau, Bahamas for the Public Hospitals Authority. She also completed her doctorate of medicine in family medicine with the UWI Bahamas campus in June of this year. And today she will be presenting her DM research topic, Impact of Multimorbidity on Health-Related Quality of Life in Adult Patients Attending Public Clinics in New Providence, the Bahamas. Please let's extend a warm welcome to Dr. Ferguson Cooper. Dr. Cooper, are you ready?
Yes, I am. Just getting my screen together for you.
Great. You can start when you're ready.
All right, good afternoon. My name is Dr. Rodina Ferguson Cooper, and I am happy to be presenting my research entitled Impact of Multimorbidity on Health-Related Quality of Life in Adults Attending Public Clinics in New Providence, Bahamas. I have no financial conflicts or commercial relationships to disclose. So just to introduce my research, I just want to present a few key terms, which the first would be disease burden, which is the overall impact of diseases and injuries on a population's health, encompassing prevalence and severity of health outcomes. The global burden of disease in a 2021 published report highlighted that NCDs accounted for 75% of global deaths. There was a rising obesity rate, and low and middle income countries had a dual burden of infectious diseases as well as raising NCDs. The next key concept is multimorbidity. This is the coexistence of two or more chronic health conditions within an individual. And this is cited by the World Health Organization. In a systematic review and meta-analysis, one published in 2021 and the other in 2023, the global prevalence of multimorbidity was 37.2%, and there were rates as high as 43% in Latin America and the Caribbean. According to the United States Food and Drug Administration, health-related quality of life is defined as a multi-domain concept that represents the patient's general perception of the effect of illness and treatment on a physical, psychological, and social aspects of life. The Pan American Health Organization, in a cross-sectional study STEPS in 2019 conducted in the Bahamas, found that 38.8% of persons had 3 to 5 non-communicable disease risk factors, and that the Bahamas exceeded the regional prevalence for both overweight obesity as well as hypertension. So the rationale for my study is that multimorbidity presents a significant burden on individuals and communities at large. Understanding how multimorbidity impacts health-related quality of life is crucial for us to tailor our interventions. And based on my search, there were no published studies to date in the Bahamas on multimorbidity and health-related quality of life. The aim of the study was to investigate the impact of multimorbidity on patients' health-related quality of life with the focus on socioeconomic status. And the objectives are listed here, which were to assess that impact on overall health-related quality of life among affected individuals, to identify which chronic diseases had the most impact on health-related quality of life, and to investigate the correlation between socioeconomic status and health-related quality of life. A cross-sectional design was utilized for this study and was conducted at public clinics in New Providence between October 2024 and February 2025. The following clinics were canvassed. When we look at the persons that were to be included in the study, they would have been persons any gender, age 18 and older. Participants must have been able to understand and speak English, and they would have to have a self-reported medical diagnosis of at least 2 chronic illnesses that had occurred more than 6 months ago. The sample size was calculated by a validated sample size software based on the mean physical component summary and mental component summary scores that were presented in a 2019 study by Patty et al., and that was in the absence of any studies being conducted here in the Bahamas. We had anticipated that about 10% of persons would decline to participate in the study, which adjusted our canvassing numbers to 267. The questionnaire contained 45 questions, and 9 of which covered medical socio-demographic factors. The short form 36 version 2 form was utilized and consisted of 36 questions with the Likert scale response format. These questions were grouped into 8 scales and 2 domains: physical component summary and mental component summary, which would be known as PCS and MCS moving forward. With regard to ethical considerations, same was sought and approved by the following listed entities. Analysis was conducted using STATA version 16. Data were assessed for normality using histograms, and data cleaning included collapsing variables and analysis and correcting spelling errors. The descriptive statistics, continuous variables, and categorical variables were tested. The predictors of the study included the listed socio-demographic factors, and the outcomes were PCS and MCS. PCS and MCS were further categorized as being well below, which meant a greater than 1 standard deviation below the mean, below up to 1 standard deviation below the mean, and same or better, which was greater than or equal to the mean. We began with bivariate analysis to examine associations between independent variables and the 2 main outcomes, PCS and MCS, which was followed by a multivariate analysis, which aimed to identify independent predictors of health-related quality of life while controlling for potential confounding variables. 302 individuals were approached to participate in this study. 267 questionnaires were completed, giving us an 88.4% response rate. The sample consisted of 267 participants, with the majority, 71%, being female. The mean age was 61.42 years, with a standard deviation of 12.10 years. We also found that age was not statistically significantly different between sex. When we looked at ethnicity, 95% of participants were Black, 42% were single, and 42% had at least a high school diploma or equivalent. Only 12% of our participants were currently employed. 69% earned between $1,000 to $24,999 annually, and lastly, 81% of our participants were found to be residing in non-crowded conditions. The multimorbidity distribution in our study population revealed that almost half of the participants had 2 chronic diseases, and 21% had 4 or more. This figure here just graphically depicts the percentage of participants diagnosed with each chronic disease that we used in our questionnaire. Hypertension at 87%, diabetes 50%, and obesity at 37%. Those were the most prevalent. Other notable conditions included high cholesterol and arthritis. The overall health-related quality of life scores for the study population found that the physical component summary score had a mean of 48.9 with a standard deviation of 8.1, while the mental component summary score showed a higher mean of 55.3 with a standard deviation of 8. Significant predictors will be highlighted here in red throughout, but the analysis of PCS and MCS across our socio-demographic groups revealed notable disparities, particularly in relation to age and ethnicity. After adjusting for the other variables, individuals classified as elderly were 6.34 times more likely to report a same or better mental component summary score. Participants identifying with the other ethnicity were 85% less likely to report a same or better mental component summary score. Continuing with our objectives and analyzing how each chronic disease impacts health-related quality of life, the results of our ordinal logistic regression analysis that explored the association between having a medical condition and the odds of having the same or better PCS or MCS score represented here. Individuals with hypertension had 66% lower odds of having same or better physical component scores compared to persons without the disease. In contrast, they also had a 300% increase of odds of having same or better mental component scores. Both observations were statistically significant. Persons with arrhythmia had 79% lower odds of having same or better mental component summary scores to those without. Additionally, persons with arthritis had 52% lower odds of having same or better physical component scores compared to those without, and while persons with depression had 96% lower odds of having same or better mental component summary scores. There were statistically significant observations in the results of our ordinal logistic regression model that examined the relationship between the number of medical conditions and the odds of having the same or better physical component summary score. This model determined that persons with 3 conditions or more had a 57% and 71% respectively lower odd of having same or better physical component summary scores. The results of our stepwise regression, adjusting for depression, ethnicity, and age group, reveal that having a depression diagnosis significantly decreased the odds of achieving a same or better mental component score by 94%. Additionally, individuals from the other racial group had 86% lower odds. However, individuals in our elderly category had a 6-fold increase in the odds of having same or better mental component summary scores than those who were not elderly. When we look at the impact of multimorbidity on health-related quality of life, we see that it's significantly associated with poor physical health. Participants, as I said, with 3 conditions or greater than 3 conditions had up to 71% lower odds of being in that same or better physical component summary score. And this is in keeping with Fortin et al. In 2004, who agreed that the impact of multimorbidity on social and psychological aspects of health-related quality of life is less well-defined compared to its evident effect on physical domains. There was no direct relationship between multimorbidity and mental component summaries, despite multimorbidity affecting physical health outcomes. Mental health outcomes were less related to disease count and more tied to the type of chronic condition. Depression emerged as the strongest predictor of poor mental health. Participants with depression were 94% less likely to report good mental component summary scores. And this is supported by Honda, who emphasized that the emotional burden of having both physical and mental illnesses is rising. Hypertension and arthritis had a significant association with lowering physical component summary scores, and this reflects global patterns in cardiovascular burden and aligns with findings by Gonzalez-Chica et al. And Aoki et al. That have shown long-term impacts on physical independence and functional ability, especially in older persons with several comorbidities. Arthritis predicted significantly reduced mobility. Chronic pain and limited joint function impact physical independence and psychological resilience, consistent with Aoki Diaz, who noted musculoskeletal pain as a major factor in health-related quality of life reduction. Arrhythmia also negatively impacted the mental component summary score. So we know that sometimes arrhythmia may cause anxiety due to unpredictability and health risks, especially in multimorbid patients. Obesity and diabetes were not significant predictors of health-related quality of life in our study, hence we failed to reject our null hypothesis. However, existing literature consistently shows their negative impact. Age was a significant predictor or significant factor in mental health. Older adults had 6.24 times more likely to report better mental component summary scores. This is in contrast with some international studies, but may reflect cultural resilience and stronger family or social networks that we see here in the Caribbean. Ethnicity, non-Black participants had 85% lower odds of same or better mental component summary scores, and this may reflect differences in healthcare access, coping strategies, or social determinants, a finding that was echoed by Violin et al. The strengths of this study included that it was an adequately powered study. This instrument used was validated internationally. It's the first study in the Bahamas. It examined a broad range of social determinants of health, and it offers locally relevant evidence. My recommendations would be that we promote more integrated care, combining physical and mental health services for chronic disease management, include routine checks, especially for depression and chronic care protocols, a big push for public awareness, and that would be in the use of social media and SMS alerts to promote early detection and intervention, as well as supportive policies that ensure access to healthy food and recreational spaces to encourage lifestyle changes. And of course, a further research that could be a longitudinal study on multimorbidity, health-related quality of life, and social determinants. So in conclusion, multimorbidity negatively impacts health-related quality of life, especially in resource-limited settings like the Bahamas. Integrated patient-centered care models are essential. Emphasis on health promotion, early detection, and patient empowerment is key. Policy reforms and attention to social determinants are needed to improve equity and access, and findings provide valuable direction for strengthening chronic disease management. I'd like to acknowledge the following individuals. Thank you for your time. These are my references.
Thank you, Dr. Ferguson Cooper. I'd like to open the floor to questions and comments. Any from the room? Any questions or comments in the chat? You may feel free to open up your mics. No questions for Dr. Ferguson Cooper? Okay. Well, thank you, Dr. Ferguson Cooper, for your presentation.
Thank you so much.
Okay, thank you. At this point, I would like to introduce our next presenter, Dr. Lisette Fernander. Dr. Lisette Fernander is a senior house officer in the Department of Obstetrics and Gynecology at the Rand Memorial Hospital in Freeport, Grand Bahama. She attained a Bachelor of Medical Science with distinction from the University of the West Indies, St. Augustine's campus, and an MBBS degree from the University of the West Indies, Mona campus. She has a professional interest in maternal and reproductive health with dedication to the advancement of women's health through the Bahamas and the Caribbean. Today, she will present an audit of miscarriages and its management at Public Hospital in Freeport, Grand Bahama from January 2024 to December 2024. Let us welcome Dr. Fernander and give her our undivided attention. Dr. Fernander, you have the floor.
On my research topic titled An Methodology, Research and Discussion, my study limitations, conclusions, and finally recommendations. Beginning with an introduction. Miscarriage is defined by the American College of Obstetrics and Gynecology as the spontaneous loss of a pregnancy before 20 weeks of gestation. However, in the Bahamas, miscarriage is defined as the spontaneous loss of pregnancy before 24 weeks of gestation. Miscarriage can be further subdivided into early pregnancy loss versus second trimester miscarriage. Early pregnancy loss is defined as a non-viable intrauterine pregnancy with either an empty gestational sac or a gestational sac containing an embryo or fetus without fetal cardiac activity within the first 12 weeks and 6 days of gestation. Second trimester miscarriage is defined as the spontaneous loss of a pregnancy that occurs between 13 weeks and 23 weeks and 6 days of gestation. miscarriage is unfortunately common. It is estimated that between 10% to 20% of known pregnancies end in miscarriage, with the majority occurring during the first trimester. In the second trimester, spontaneous miscarriage is less common, but is associated with more significant maternal morbidity and mortality. Common presenting complaints associated with miscarriage include vaginal bleeding, low abdominal or pelvic pain, passage of tissue or clots per vagina, and symptoms of hemodynamic compromise, such as dizziness or lightheadedness, with recent studies indicating that vaginal bleeding and abdominal pain being the most frequent reported symptoms. Beyond being a physical health event, miscarriage carries a significant emotional and psychological toll on both patients and families. Research indicates that the causes of miscarriage are multifactorial, involving genetic, medical, lifestyle, and infectious factors. Effective management strategies aim to address both the physical and emotional needs of patients while minimizing risk and promoting optimal outcomes in future pregnancies. Several key risk factors are well established. The likelihood of miscarriage is strongly influenced by maternal age. Women over 35 years of age face a significantly higher risk due to increased rates of chromosomal abnormalities in the fetus. Genetic factors, particularly aneuploidy, accounts for about half of recurrent pregnancy losses. Lifestyle habits like smoking, alcohol consumption, excessive caffeine, and illicit drug use also increase miscarriage risk. Medical conditions such as diabetes, thyroid disorder, polycystic ovarian syndrome, and endometriosis further compromise pregnancy viability. Finally, infections like torch, bacterial, viral, or parasitic infections are known to trigger miscarriage, especially early in pregnancy. The complications of miscarriage can be both immediate and long-term. In the short term, patients may experience heavy pervaginal bleeding, infections, or incomplete expulsions of fetal tissue, each of which may require urgent medical or surgical intervention. Beyond the physical, miscarriage has profound psychological impacts. Grief, depression, and anxiety are common, and these effects often extend well beyond the acute episode. Women with recurrent miscarriage also face higher risk in future pregnancies, including preterm birth and increased anxiety. The management of miscarriage can be expectant, medical, or surgical, with the chosen approach guided by clinical status and patient preference. Expectant management allows a miscarriage to progress naturally without medical or surgical intervention, and is often appropriate for early, uncomplicated losses. Studies suggest that expectant management is successful in nearly 80% of incomplete miscarriages within 3 days, although rates are lower for missed miscarriages. Medical management typically uses misoprostol, sometimes combined with mifepristone, to induce uterine evacuation. Medical management is successful in more than 80% of cases, although incomplete expulsion or heavy bleeding can occur. When there is heavy bleeding, infection, or failed medical management, surgical approaches like dilation and curettage or manual vacuum aspirations are necessary. These procedures are highly effective but are reserved for specific cases. With that framework in mind, let's now look at the real-world data from Freeport. The objective of this study is to investigate the risk factors, complications, management strategies, and clinical outcomes of miscarriage at a public hospital in Freeport, Grand Bahama. The aim of this study is to provide a comprehensive evaluation of miscarriage by identifying risk factors, describing presentations, assessing management, and analyzing outcomes to support evidence-based, patient-centered care. Moving on to methodology. Data was obtained from patients' files who who presented to the emergency department at a public hospital in Freeport, Grand Bahama. Written permission to obtain patients' files was obtained from the medical chief of staff. Data was collected from patients' files that presented to hospital between January 2024 to December 2024. This is a retrospective observational study that observed the following variables: maternal, lifestyle, medical, and infectious risk factors, along with clinical presentations, management approaches, complication, and patient outcome of miscarriage. So we reviewed 19 patients who presented with miscarriage. The age ranged from 21 to 45, with a median age of 33, and most patients were multiparous. As shown in this chart, 74% of miscarriages occurred in patients under 35 years of age, while 26% occurred in those 35 years or older. This finding contrasts with existing literature, which indicates that miscarriages are more common in women of advanced age. The discrepancy may be attributed to the limited sample size and potential limitation in sample quality. Here you can see the presenting symptoms. Pervaginal bleeding and abdominal pain were clearly the leading complaints, while dizziness, headache, and vomiting were much less common. These findings are consistent with global literature, which identifies bleeding and pain as the most common presenting features of early pregnancy loss. This chart shows that 63% of miscarriages occur in the second trimester, while 37% occurred in the first trimester. This finding contrasts with existing literature, which reports that most miscarriages occur during the first trimester. The discrepancy may be explained by the small sample size, limitations in sample quality, and possible underreporting of early pregnancy losses by patients who did not present to hospital. This graph shows that alcohol use and the history of previous miscarriages were the leading contributing factors to miscarriage in this study. These findings are consistent with current literature, which highlights lifestyle factors such as alcohol consumption as significant risk and emphasizes that prior miscarriage substantially increases the likelihood of recurrence. Complications are where the clinical challenges become most clear. 5 patients experienced failed medical management, meaning they eventually required surgical evacuation. Excessive PV bleeding is defined in this study as 2 or more pad usage within 2 hours or the passage of large clots or tissue. Excessive PV bleeding was seen in 13 patients and 6 required readmission to hospital. Most strikingly, 8 patients needed blood transfusions, which highlights the severity of bleeding complications in miscarriage. This data emphasized the need for close monitoring, timely intervention, and individualized care plans for each patient. Looking at the management approaches, only 4 patients were managed expectantly. 5 patients received medical treatment with misoprostol, and 10 required surgical interventions with dilation and curettage. Of the 46% of cases undergoing surgical management, about 20% was due to failed medical management. In this study, the majority of cases were managed surgically, primarily due to failed medical management, approximately 20% of patients, or due to excessive PV bleeding. This observation is consistent with recent studies indicating that medical management achieves success in approximately 80% of cases, while surgical intervention remains a highly effective alternative, particularly in cases of failed medical management or when medical management is contraindicated or not feasible. So some of the limitations of this study includes the following. This was a retrospective design study which relied on existing records with possible gaps. Single-centered data from Freeport, Bahamas limits generalizability. This was a small sample size which may not capture all risk factors or outcomes. There was no documentation of psychosocial and emotional impacts. There could have been potential reporting bias in symptoms and outcome recording. The absence of data interpretation using statistical analysis was yet another limitation. An insufficient regional literature constrained the ability to benchmark results within the Caribbean context. So in conclusion, miscarriage is a multifactorial complication influenced by genetic, medical, lifestyle, and infectious factors. Most of the findings from a public hospital in Freeport, Grand Bahama align with global evidence. Prior histories such as social history and obstetric histories as key risk. Management most often required medical or surgical intervention due to incomplete miscarriage or complications. Complications such as bleeding, infections, and psychological distress highlight the need for comprehensive care. Individualized, evidence-based approaches are essential to improve outcome and support women experiencing pregnancy loss. The following recommendations are proposed to guide future practice and improve outcomes in the management of miscarriage cases. Enhance regional research on miscarriage to strengthen Caribbean-based evidence. Promote early screening and monitoring of women with known risk factors. Integrate psychological support into miscarriage management protocols. Standardize clinical guidelines for expectant medical and surgical care. Encourage patient-centered approaches to improve outcomes in future pregnancies. These are my references. Thank you.
Thank you, Dr. Fernanda, for your presentation. Excellent work. Any comments?
It's Dr. Bloomfield again.
Go ahead, Dr. Bloomfield.
Thanks for the presentation. I would encourage you to have another shot at this again. In terms,
sorry, Dr. Bloomfield.
Yeah, can you hear me?
Yes, we can hear you.
Yeah. In light of the fact that your numbers were so small, got a true picture of what the real story is. Even if it applies to Grand Bahama. Being an observational study, maybe you should have probably, if you get another opportunity, look at probably 5 years, because then you'd probably be able to pull out some of the stuff. Some of the conclusions then becomes a little bit obvious because it shows where a lot of surgical intervention took place. Certainly if you have a more second trimester miscarriages, according to your report, it would require surgical intervention more than people spontaneously aborting the pregnancies, the early ones. The other thing again, would probably look at again is the concept. How many of these people had miscarriages before? A percentage would have been pretty good to help us to see exactly where this stands. So a couple of things not borne out in real life. Sadly, I don't mean to criticize you because you embark on a study and you got the findings as relates to the limited period of time that you looked at. Certainly, the younger age group rather than the older age group is not in keeping with standard literature and reality. Previous miscarriages certainly play a role. And of course, the psychological impact, especially in the people who have had previous miscarriages. And again, what were the outcome after that to see whether they actually had pregnancies and successful pregnancies after that. Thank you for allowing me to comment. Thanks.
Thank you, Dr. Bloomfield, for your comments. Unfortunately, Dr. Fernanda got disconnected, but we appreciate your feedback and your commentary on the study.
Well, it's unfortunate she got disconnected because I had 2 questions for her.
Is there anyone in the room that would like to make any further comments on the study? No?
But do you happen to know if that presentation was pre-recorded?
It was indeed pre-recorded.
Okay. Thank you.
So my apologies on behalf of Dr. Fernanda. She got disconnected. Okay. So moving on to our next presenter, we have Ms. Kadeen Grant. She is a final year medical student at the University of West Indies, Mona. Her research interests are infectious diseases and medical microbiology, especially topics relating to bacterial infections and antimicrobial resistance. Ms. Grant is an aspiring infectious disease specialist and looks forward to contributing to the body of infectious disease research in the Caribbean. She will be presenting her research, metronidazole-induced encephalopathy, a rapid review of case reports. Welcome, Ms. Kadeen Grant, to her presentation.
Hello everyone, my name is Kadeen Grant and today I'll be presenting on my research entitled Metronidazole-Induced Encephalopathy, a rapid review of case reports. I have no conflicts of interest to declare for this presentation. Metronidazole is an antimicrobial drug used for treating infections caused by anaerobic microorganisms. So in terms of the mechanism of action, I'll be referring to this diagram. So the mechanism of action happens through a series of redox reactions. So here we have ferredoxin that gets reduced by the action of pyruvate ferredoxin oxyreductase. And this reduced ferredoxin is now able to interact with metronidazole, which becomes oxidized into a nitro radical anion, which causes oxidative cell damage and thus results in cell death. So metronidazole-induced encephalopathy is an adverse drug reaction characterized by central nervous system dysfunction, and some of the symptoms of that, you'd have peripheral neuropathy, dysarthria, ataxic gait, and seizures. So by May 25, 2023, there were 392 cases of MIE, which is metronidazole-induced encephalopathy, reported on VG-Access, which is a database by the WHO. So how this study sought to answer this question: how are metronidazole and encephalopathy connected? So this is my methodology. So the rapid review was done in accordance with the Cochrane Rapid Review Guidelines adopted from PRISMA. And no ethical approval was needed for the study because it was analysis of secondary analysis of data obtained from peer-reviewed studies. So I'm just going to give you an overview of my methodology. So first, I did a systematic search on PubMed using the key terms metronidazole or metronidazole-induced and encephalopathy and case reports. I then filtered it by language and date, and the case reports that I chose, I extracted patient demographics such as age and gender, dose and route of metronidazole, amongst other things. And also from drugs.com, I extracted the frequency of MIE. So additional literature was used from PubMed in order to get information on the mechanism of action of MIE and also the risk factors. So the records were identified from PubMed, and I had 15, and in the end, by exclusion, I ended up with 5 case reports, which I included in this study. So starting, if I could get a pointer. Starting here, you can see that MIE affects both male and female and of varying ages. So we have 16 being youngest, 86 being oldest, and you have varying routes. You have PO and IV, and the cumulative doses varied as well. The time of onset after drug initiation. So at least a month had passed for these cases after metronidazole initiation. For the presentation, it was varying. You had dysarthria, paresthesias, unstable gait, and for concomitant therapies, you can see that they're varying. So it wasn't due to interaction. It may not have been due to interaction with metronidazole or due to these drugs. And the outcome, most patients, they had persistence of symptoms, even after cessation of metronidazole. And we only had one risk factor, and that was mild renal dysfunction. So on to the results. So according to drugs.com, the metronidazole-induced encephalopathy is actually rare, and the pathway is proposed to be a result of two different pathways. So pathway 1 is due to a redox reaction. So metronidazole is reduced, then oxidized. Then when it's combined with that superoxide radical, it becomes neurotoxic, and then you have encephalopathy. Also, the reduced drug can be combined with semiquinone radical, and then you can have encephalopathy. So that's pathway 1, redox reaction. So pathway 2 is through thiamine deficiency. So metronidazole is converted to a compound called aminopyrimidine imidazolium via the gut bacterial thiaminase 1. And this compound antagonizes thiamine deficient enzymes. And this results in a decreased ATP production, oxidative stress, reduced myelin sheaths, reduced GABA inhibition, and thus neuroexcitotoxicity. There's neurodegeneration and thus encephalopathy. So these are showing on the left, you can see the risk factors of MIE. So it's a longer duration, with the median duration being 15 days. Higher cumulative doses of metronidazole, with the average being 93.4 grams. Severe hepatic dysfunction, renal insufficiency, and genitourinary cancer with chronic kidney disease. So on the right, you have possible prevention measures for MIE. So it's about being cautious with patients that are at risk, such as patients with liver function and brain abscesses. Substitute metronidazole for another antibiotic, and also supplementing metronidazole with high doses of thiamine. So on to the discussion. So this study included 5 case reports. There was a significant variation, as you saw, with dose and duration of MIE, as it occurred in patients with a range of 500 milligram per day to 1,800 milligram per day of metronidazole for 28 to 44 days. So at-risk patients on metronidazole should be regularly assessed for encephalopathy post at least 15 days of therapy, and drug substitution may be, or drug dose adjustment may be implemented. So the symptoms that may be key to early diagnosis are dysarthria and paresthesia, as most patients presented with these, with 80% presenting with dysarthria and 60% with paresthesia. There's also evidence of symptoms post-drug cessation, as seen in the 5 case reports. Based on the mechanism of MIE, a high dose of thiamine may be beneficial, but further research will need to support this. So in conclusion, MIE is a rare drug, adverse drug reaction for metronidazole that can occur at varied range of dose and duration. So regular observation of at-risk patients of MIE is recommended, the drug substitution or drug adjustment is an option for these patients. And thiamine supplementation may prove beneficial as the mechanism of MIE does involve thiamine deficiency, but this would need to be confirmed by further research. And these are my references. And I'd like to acknowledge Prof. Gosso Williams for her guidance through the Pharmacovigilance Research Scholars Program. And thank you for listening to my research. If you have any questions, you can direct it to me via my email. Thank you so much.
Thank you, Ms. Kadeen Grant, for that presentation. Ms. Grant, are you online?
Yes, I'm online.
Okay. Any questions for Ms. Grant on the presentation? Questions, comments? Anyone in the chat, in the room?
This one is pre-recorded as well.
Hello? Pardon, can you repeat?
I was asking if this presentation was also pre-recorded.
She's in the room. She's online. It's pre-recorded, but she's online. The presentation was pre-recorded, but she's online.
Okay.
Okay, so we will move along to our final presenter of this session. Closing our session is Dr. Nina Thompson. Dr. Thompson is a former registered nurse whom, after 10 years of practicing and teaching nursing, was inspired to make a transition in her healthcare career to become a medical doctor. She attained her MBBS degree from the University of the West Indies Trinidad campus in 2007. And she has successfully completed her doctorate of medicine in family medicine at the UWI Bahamas campus this past June. Today, she will present her DM research topic, anosmia and ageusia, and potential risk factors for these two pathoses in COVID-19 adult patients in New Providence, the Bahamas. Please help me welcome Dr. Nina Thompson.
Thank you for your kind words. As been stated, my name is Nina Thompson, Nina Simone Thompson. My research is entitled Anosmia and Ageusia and Potential Risk Factors for These Two Conditions in COVID-19 Adults in New Providence, the Bahamas. This research project was conducted in partial fulfillment of the Doctor of Medicine degree in family medicine. I have no commercial relationships or financial conflicts with regards to this presentation. Did it not move? It has been approximately 5 years since the world experienced the monumental effects of the COVID-19 pandemic. For the few persons in the Bahamas and the millions worldwide with long COVID, it has become a burden. Some of the personal and global burdens of this disease include decreased quality of life, economic challenges, ongoing loss of smell and taste. Can you imagine for a minute being unable to smell your favorite perfume or taste your favorite food or drink? The World Health Organization and the Centers for Disease Control and Prevention in 2020 recognized new loss of smell or taste as clinical symptoms of this disease. In the same year, Kasugi et al. From Brazil reported sudden loss of smell was a new symptom of COVID-19 infection. Mutiawati et al. In a systematic review on the global prevalence of anosmia noted that of the more than 32,000 COVID-19 patients from 107 studies, 38% had anosmia. They also noted that of the more than 30,000 COVID-19 patients from 101 studies, approximately 37% had dysgeusia. Lee et al. In a Korean study reported that of the more than 3,000 self-reported cases, 15% reported anosmia or ageusia. It was more common among females. The average recovery was 7 days for both symptoms, and most recovered within 3 weeks. While working at a public clinic that was managing COVID-19 patients, many were presenting with loss of smell and/or taste. After searching the literature, I found many studies, many global studies, few regional studies. None were published in the Bahamas, and therefore I decided that to gain insight into this interesting topic, I would look more in depth. The study's aim is to assess anosmia, loss of smell, and/or ageusia, loss of taste, related risk factors in COVID-19 positive patients, given their medical socio-demographic profile. What is the loss of smell and taste-related risk factors in COVID-19 positive patients, given the medical socio-demographic characteristics in New Providence, the Bahamas? And this study was conducted over a 1-year period from March 1, 2020 to February 28, 2021. From the question, the objectives are as follows: to determine the prevalence of loss of smell and/or taste in COVID-19 positive patients, to determine the participants' recall duration from onset to clinical recovery, to assess loss of smell and taste-related risk factors in study participants, and fourthly, to assess the degree to which the measures of effect are modified by the participants' medical socio-demographic characteristics. A retrospective unmatched case control study was conducted from January 2023 to April 2023, utilizing random digit telephone dialing and telephone interviews. The inclusion criteria was COVID-19 positive patients who visited Accident Emergency Department and South Beach Health Center, 18 years and older, English speaking and resident of the Bahamas. Persons who could not be reached by telephone, that were incarcerated, had a history of mental illness, or were admitted to intensive care were excluded. A list of telephone numbers were generated from the patient's medical records or the triage screening form. The numbers were placed in a random numbers generator, and a simple random approach was used to select the participants for the study. Secondly, the additional component of the questionnaire was obtained from the anosmia reporting tool developed by the ENT and infectious disease patient group. Their tool consisted of 17 items. Ethical approval was obtained from the public hospitals and the University of the West Indies Research Ethics Committee, and permission was granted from the medical chief of staff and the hospital administrator. Verbal and voluntary informed consent was obtained from the individuals at the start of the interview. State version 16 statistical software was used to analyze the data. For descriptive analysis and comparison, we utilize chi-squared test, proportion testing, and independent sample t-test. All of these are represented as charts, figures, and tables as appropriate. A p-value of 0.05 or less and 95% confidence interval was used to determine statistical significance. For logistic regression model, it was based on risk factors, and Pearson's correlation was used to check for correlations among 2 or more variables. There were 143 cases and 322 controls, and there were more females in both groups. There were no statistical differences in age distribution between cases and controls. The highest proportion was seen in the 40 to 59 years age group. There was a higher proportion of females in both groups based on sex of the patient. There were more, however, the proportion of females in the case group was higher. Roughly similar amount of single and married persons was seen in both groups. there were more non-healthcare workers in both groups. The majority of participants in both groups had a senior high school level of education. And the majority of the participants in both groups were employed full-time. Hypertension and diabetes, overweight and obesity were the most common medical conditions seen in both groups. The proportion of persons with self-reported history of smoking was slightly higher among cases. And the proportion of persons with self-reported history of alcohol consumption was similar for both groups. More controls were exposed to COVID-19 via close contact. There was no statistically significant difference between the number of days of loss of smell before and after testing when using the paired t-test. However, upon conducting the one-tail test, the number of days was significantly greater. The number of days without taste, after testing was statistically significantly greater than the number of days before testing. Approximately 80% of them had loss of smell at the beginning, 20% had it midway, and no individual at the end of the COVID-19 illness. Approximately 65% of them had loss of taste at the beginning, 33% midway, and 3% at the end of the illness. In case groups, over 90% of the participants had full recovery of their sense of smell and or taste. In the model adjusted for marital status, healthcare worker status, education status, employment status, age and sex status, there was a significant odds of being a case based on sex status, with females having a 1.7-fold higher odds of being a case. The model was also looked at the odds of being a case based on exposure-related risk factors, and all of these risk factors were significant. A person with travel history had a 14.6-fold higher odds of being a case. There was no significant odds of being a case based on the other comorbidities outlined here. There were no significant odds of being a case based on alcohol consumption. However, a person who smoked had a 52% reduced odds of being a case. For my discussion, in our study, when we compare to other persons, approximately 31% of the participants had anosmia and or ageusia, which supported the hypothesis. The duration for both conditions was less than a week. Recovery was less than a month, and the odds of being a case was higher for persons with a travel history and being female. Comparing to Alani and Achara, their findings were lower, and when we compared Iqbal et al. From Pakistan and Hovath in Australia, they had higher prevalences than our study. Statistical significance was noted between sex and loss of smell and taste. More females, approximately 67%, had loss of smell and taste. And when we compared it to Klopfenstein et al. In France, they had similar findings. However, Lechian et al. Said their findings were higher, and Dev et al. In Delhi, India, reported there were more males in their study that had loss of smell and or taste. Most of the participants had full resolution of their symptoms in less than a month. Similarly, Lee et al. In Korea reported that their participants recovered sense of smell within 3 weeks. And Vieira et al. In Italy reported that less of their participants reported recovery in less than a month. A little over a quarter of the participants in the case group and 1/3 in the control group reported close contact exposure. Patel et al. In the United Kingdom said theirs was higher, and Alani and Achara in India said close contact was not a risk factor for the persons in their group.
Travel history. So participants with recent travel history, as stated, had a 14.6-fold higher odds of being a case. Alani and Achara reported lower findings for their participants, and Patel et al. And Iqbal et al. Reported no significant difference for travel history among their study participants. In our study, smoking status was a protective factor. Persons who smoked had a 52% reduced odds of loss of smell and or taste. Galuzzi in Italy said the persons that smoked had an increased risk, and Alani and Achara reported that the persons in their study had a reduced risk. The limitations of our study is that they allowed for the examination of past exposure and related risk factors. A few disadvantages included potential selection bias, researcher bias, and some level of subjectivity. There was also recall or information bias because this study was retroactive. Strains. First, the study was conducted on loss of smell and taste among COVID-19 adults in New Providence. The sample size was large enough to capture multiple risk factors. It was economical, and the design was easy to implement because we're using the telephone. Recommendations. Multifactorial approach is needed on the individual, family, physician, community, and governmental level. Hopefully we can get retraining of the sense of smell and taste for those 143 persons that since COVID are not able to smell or taste. More herbs, recommend that they use more herbs, spices, color, and texture in food preparation, and that a support group for individuals with these conditions be established. In conclusion, anosmia and ageusia was seen in a little under 1/3 of the participants. It was more common among females and persons with recent travel history. The majority had full recovery in less than a month. COVID-19 is still with us. Therefore, health promotion approaches are relevant at all levels. And as we think about those persons that are not able to smell or taste, maybe when you're drinking your latte or having your crack conch, maybe you'll think about some of these people because it becomes serious. Not being able to know that your house is burning or your food is spoiled. So, if for them, so we just, don't take it for granted. And also for the persons that lost their lives during COVID-19, we want to just pause a minute and just think about them. And I want to say thank you to all of you that were present. These are my references and my acknowledgement, all these wonderful people that helped with this project. Lastly, but certainly not least, Father God, it had been a good time, and I'm happy that I'm able to stand here to say that I finished the race. Thank you.
Proud of you, Dr. Thompson. Great presentation. I would like to start off with a question. So you mentioned that persons who smoked were less likely to have loss of taste and loss of smell?
Yes.
Right. So did you come across any literature that may explain why that may be so?
I think that was specific for the Bahamas. I'm not advocating smoking, but it just seemed that the persons in the Bahamas that smoked didn't have a loss of smell and taste. And we know that viral illnesses can also contribute to loss of smell and taste. So, it is not sure why the persons in the Bahamas didn't get it. And maybe if the other people had smoked, maybe they wouldn't have gotten it as well. But we don't know. But I didn't see it in any other studies that said that it was protective. But certainly in the people that I spoke with over the telephone, it was protective.
And when you say persons that smoke, that is cigarette or other substances?
Unfortunately, we're talking about the other substances in the Bahamas.
Thank you. Interesting. So, any other questions or comments for Dr. Thompson? Anything in the chat? Anyone on Zoom? Feel free to open up your mic.
Okay.
Following up on that, Dr. Sinqui here. Thank you very much, Nina, Dr. Thompson, and congratulations on achieving your DM. Just wanted to follow up on that same question. You said you didn't see any reference to a protection with smoking, but did they assess that at all in any other study?
I don't recall it being assessed in any other study, but that's a good question, Dr. Sinqui. I will look again and see if, smoking was a protective factor in all the other persons. But there were so many people. I mean, we had a small pocket of people that lost their sense of taste and smell in the Bahamas. But worldwide, there were so many other people that are still actually suffering with this what we call long COVID or long hauler syndrome. So I will, look into the literature again to see if there's anybody, if any studies mention that. But because COVID-19 was 5 years ago, I don't know if they were actually looking so much to see whether smoking was predictive as much as just presenting the data, because it was so new to us at the time. So I am sure if I'm in hindsight, if I'm looking back and, even moving forward, just to see how that is actually being looked at. Thank you for your question.
Dr. Davis, I saw you had your mic open, and Dr. Winston Campbell. Dr. Davis, then Dr. Campbell.
Okay. Thank you for the presentation. I enjoyed that. Question though, I noticed when you're doing the comparison with the literature findings, I'm just wondering if there's a time factor in there in terms of which strain could have been having the impact at the time of those studies versus your study. Did you see anything around that?
Well, they were all conducted during the first strain when, because this was March of 2020 when COVID first started. So this would have been the first strain. So most of the literature that I saw was based on the first strain, because by the time we had other strains, the symptoms were not even important at the time. Loss of smell was not even in the mix. But in 2020, for sure, the CDC and the World Health Organization realized that loss of smell and taste was certainly associated with COVID-19, because that was sometimes the only symptom that persons presented with. And even in our setting, when I interviewed persons, they said the only thing they had was loss of smell or taste.
Okay, thank you. One last question, if I may, please. In your statistical analysis, and a few of those slides you went by fairly quickly, but I did note that your age groupings, your age bins were unequal. Did you account for that in your analysis?
Sorry again, the age grouping in terms of the 40?
In terms of, you go from 18 to 25, which is about 8.7, then you get 25 to 39, which is 19, and you go from 40 to 59 or 40 to something, I can't remember what it was, but each grouping contained a different range of ages. You had, 5 years in one grouping, 10 years in the other, 15. I was just wondering if in your statistics, you accounted for the fact that the age ranges were different, therefore you're going to capture different number of individuals in each grouping.
Certainly, I recognize that, and thanks for your question. I recognize that it would have captured people in different stages of their lives, but I think when I looked at it, it was going to be, the study would have, in terms of how many persons I would get, it might have just been less people in the younger age group. And based on what the statistics were saying, it was more considered people with comorbidities who would have been the older age group. So maybe that's why I kind of spread it out that way. So I hope that kind of answers your question.
It doesn't answer my question, but that's not a bad thing. I just wanted to say that, normally you would have some fixed age groups, from 10 to 19, 20 to 29, so that, I'm not stating this well. If you do have different bins for your ages, then you have to sort of account for that based on what tests you're doing. I'm just curious if you had, but we won't belabor that. I think you're fine. Thank you.
Thank you. But I will do some research on, or have a talk with the biostatistician, the epidemiologist, and see what their take is on that information as well.
All right, thank you.
Good day, Dr. Hannah here with another question.
Go ahead, Dr. Hannah.
First of all, congratulations, Nina and Dion Thurston and all of you who would have completed your DM. My question, Nina, how did you check for multiple infections? We know that persons, some have had COVID multiple times. Did that factor into your findings?
Well, thank you for your question, Dr. Hannah. During the time we did the study, most of the persons, only had COVID once. So I didn't come across people who had it more than once. And so I didn't take that into consideration. Sorry.
Okay, thank you.
Thank you, Dr. Thompson. Thank you to everyone for your questions and your comments. This concludes session 6 of Research Day Conference. It was my pleasure hosting this session. And thank you all for your attention and your participation. Once again, thank you, Dr. Tulloch, for joining us today. We appreciate your valuable contributions and unwavering commitment to advocating for women's health through your work with cervical cancer prevention and care. And thank you to all of our presenters for sharing your interesting research. Congratulations to all of the recent DM graduates. And finally, special thanks to our sponsors, all of whom have made this Research Day Conference possible. Want to note Cell Collab Clinical, Consultant Physician Staff Association, Doctors Hospital, Medical Association of the Bahamas, Medical Protection Society, Nestle, National Insurance Board, Public Hospitals Authority, Spotadoc, Springer Nature, STATA, the Ministry of Health and Wellness, and individuals such as Dr. Pinder Butler and Dr. Wells for their contribution. A gentle reminder to complete the feedback forms on Sunshine Learner and to claim your CMEs. The code will be displayed on the screen. And at this time, I would like to welcome our moderator for the next session, Dr. Dawn Major, and continue to enjoy the research conference. Have a good evening.
Hello, hello.
Hi. Hello, can you guys hear me?
Hello, yes, we can hear you, sir.
Awesome, awesome. All right, I'd like to thank you all for, sticking around for this 7th and final session to our wonderful and exciting 19th annual Research Day. And this session is actually topicked Trauma, Spine, and Bone Health, Integrating Research, Clinical Practice, and Legal Awareness. I am the moderator for this session, Dr. Dawn Major. I am a surgical oncologist and hepatobiliary surgeon here in the Bahamas, and I have the privilege of introducing our first keynote speaker. This is Dr. Natalie Medley Singh, who obtained her MBBS degree with distinction in obs and gynae, as well as honors in general surgery at the University of West Indies in 2008. Her passion for women's health drove her to pursue a career in obstetrics and gynecology, and she completed her residency in 2015. She did a fellowship in gynae oncology and then an editorial fellowship with the International Journal of Gynecological Cancer, and she now serves as the IJGC Early Career Editorial Board, as well as the editorial board of the Obstetrician and Gynecologist, another peer-reviewed journal. Her current position is a consultant OB at the University of West Indies and a lecturer at UWI. She enjoys these roles as well as her clinical research, teaching the residents as well as the medical students. Let us welcome Dr. Singh to the podium, where she's going to talk to us about the 10 key rules of high-risk HPV testing in cervical cancer screening. Dr. Medley.
Okay, thank you for that welcome. I want to thank the organizers for inviting me to share with you today. I really have been enjoying this conference. The talks have been excellent. I was especially happy to see my medical student, Kadeen Grant, presenting earlier. So it's really been, it's been going really well. And my topic, endometrial cancer on the rise, why, and what can we do about this? And I think this is perfectly suited to the theme of your research conference. So I have no disclosures. And today I want to share briefly with you on the epidemiology of endometrial cancer, the histology and molecular profiles of endometrial cancer, some risk factors, and ways in which we can reduce endometrial cancer risk. So briefly, endometrial cancer is cancer which arises from the endometrium or the lining of the uterus, seen here. This represents more than 95% of uterine cancers. So in literature where we see endometrial uterine cancers being described, most of these will be endometrial cancers. Now, this is separate from cervical cancer. And my colleague and good friend, Dr. Toller, would have spoken earlier about cervical cancer. So anatomically, the uterus is one structure, but oncologically, it's a separate entity altogether, cervical from uterine cancers. So again, endometrial cancer comprises most of uterine cancers. The lifetime risk of endometrial cancer is 3%, and most women are diagnosed in the 6th and the 7th decade, with the median age being 65 years. So most women are postmenopausal, of course, over 90%. But we have 10% of women who are under 50 and 4% under 40 years. And diagnosing endometrial cancer can be quite a challenge in this younger cohort. Overall survival is good, about over 95%, because most women have are diagnosed early with good histological types, which I mentioned, but metastatic or advanced endometrial cancer can be quite a challenge to manage with much lower survival rates. So generally, endometrial cancer is thought to be the most common gynecological cancer in developed countries, where high-income countries, the incidence stated about 11 per 100,000, low-resource countries, about 3 per 100,000. So generally, what's accepted is that cervical cancer is the most common gynae cancer in developing countries, primarily because of issues with screening and so on. However, in Jamaica, from our cancer registry, what we found in our last review, the data is older, but we had a 14.8%, 14.8 per 100,000 incidence of endometrial cancer versus 15.7. So cervix and endometrial cancers were neck and neck. So we are dealing with developing country challenges as well as developed country challenges, with both cancers being roughly equal. And here we have a pictorial depiction of the incidence of endometrial cancer in darkest blue, and it predominates in high-income countries, North America, Northern Europe, Australia, and this is in stark contrast again to what we see with cervical cancer generally. So in addition to these economic disparities with endometrial cancer, there are also racial disparities where Black women are disproportionately affected, experiencing higher mortality rates. We see more aggressive subtypes in Black women, more advanced disease or more advanced stages at the time of diagnosis, and also treatment disparities as well. So this is something that we could discuss at length. There are many questions. Is it due to biological differences in tumor behavior? Is it due to just treatment disparities? We do know that Black women are underrepresented in clinical trials, for example. So do the treatments work the same way? Or is it just social factors, access to care, delayed diagnosis? Lots of our women have fibroids, which can, confound the picture as well. So endometrial cancer is divided histologically into two main types. We have the type 1s, account for 80% of endometrial cancers, and these arise due to high unopposed estrogen. So the endometrium is exposed to estrogen for a long time. This is thought to be what predisposes to type 1 endometrial cancer. Luckily, there's the most common type. These are the less aggressive category. So most of them are endometrioids, seen here, and well differentiated, usually grade 1 or grade 2, versus the type 2 cancers, more aggressive types, serous, clear cell, carcinoma, sarcomas, and these are not hormonally sensitive or dependent when compared to the type 1s. Most of them occur in an atrophic environment, seen at an diagnosed at an older age and more advanced stage, and unfortunately also more common in Black women. So estrogen, as mentioned, or prolonged unopposed estrogen is a risk factor for the most common type of endometrial cancer, as it stimulates mitotic activity in the endometrium, inducing differentiation, causing proliferation, hyperplasia, and then neoplasia. Progesterone, on the other hand, opposes this estrogenic effect by decreasing estrogen receptors and encouraging a more secretory change. In this review, I wanted to share with you a 5-year review The reason it was done was looking at the correlation between preoperative histology from endometrial sampling versus what the final histology after surgery came back showing. But what we found interestingly was, and this is a study done at UWI, we found we have a 50-50 split between type 1 and type 2 endometrial cancers. So we don't enjoy this 80-20 split. So a lot of our women have, so it confirms that a lot of women have advanced disease, or more aggressive disease, I should say. So the world is moving away from just this dichotomous histological classification to a more molecular classification. And the Cancer Genome Atlas divides the molecular profiles of endometrial cancer into these 4 main groups: the Pol E ultramutated group, microsatellite instability or MSI group, the high copy number variant, of which P53 predominates here, and the copy number low are those without a specific driver mutation. And these are shown here. So why is this important? It's really important because of treatment and prognosis. So the poly ultramutated group have a more favorable prognosis, extremely favorable, whereas those driven by a P53 mutation are more aggressive. Those with a microsatellite deficient or mismatch repair deficient tumors and those with no specific driver mutation, they fall somewhere in the middle, somewhere intermediate. So for example, women who have endometrioid, as I mentioned, usually these are more low grade and they tend to do better, lower recurrence, present early, and so on. So oftentimes in these women, if they present early enough, we actually can do surgery, and surgery alone may be curative, right? And they have 95% 5-year survival and so on. But you do have a subset of women who have type 1, they should have early stage, less aggressive disease, and they come back with recurrence and just behave not in keeping with the typical type 1 patient. And these women may actually have a P53 mutation. So in knowing this information, you may have send this patient to get adjuvant treatments. And instead of just surgery, you may send her to get chemotherapy and radiotherapy, knowing she has a P53 mutation on board and high likelihood of recurrence. So it's very useful in that sense. And also for treatment. So the MSI category or microsatellite unstable group benefit significantly from, or benefit more from immunotherapy than other groups as well. So endometrial cancer is increasing globally, and not just increasing, but increasing rapidly. According to the IARC, it's said to be increased by more than 50% by 2040. And here we have data looking at the standardized rates for the USA, Canada, and UK. Over the last 20 years, we can see a significant increase, uptick up in the endometrial cancer incidence. When we look at cervical cancer, it's the opposite. It's on decline. So endometrial cancer is definitely increasing there. Further data from the UK looking at the different types. So the type 1s, the estrogen-dependent types is actually where we see the increase, or where they notice the increase. The type 2s are more steady. And when looking at endometrial cancer by age group, we found that the under 60-year-olds was a more steady incidence versus an uptrend in the older women. Further data from the cancer registry in Jamaica looking at breast cancer, cervix, ovarian, and endometrial cancer, we can see breast cancer trending up, cervical cancer downward trend from all those review periods. But when we look at endometrial cancer, we see a steady increase. And as I mentioned before, it was neck and neck with cervix at the last review period. And I'm sure it has now surpassed cervix when we get new information from the registry. Using Globocan, though, looking at more recent data, looking at new cases. So looking at 2018, we see breast cancer the most common in women, followed by colorectal, then cervix uteri, but then uterine, of which endometrial cancers predominate, was the second most common gynae, so followed behind cervix. But now in 2022, we have a different picture. So after breast cancer, then what do we have? Uterine cancers, then cervix. So the new cases of endometrial cancer actually were steadily increasing and actually surpassed cervical cancer. And in the Bahamas, similar picture here from Globocan, breast cancer, uterine, than cervix, right? So traditionally, even though we're told the endometrial cancer, the cancer of the developing world, we need to be on guard in developing countries because we have increasing numbers of endometrial cancer. We're doing a good job with attention to cervix, but endometrial cancer has been creeping up on us. So why is this? What are the risk factors for endometrial cancer? So here we see relative risk for some of the conditions. We have obesity, about a 2.5 relative risk, and all the factors of the metabolic syndrome, about 2 times increased risk. So hypertension, hyperlipidemia, diabetes. Looking at reproductive factors like polycystic ovarian syndrome, about a 3-fold increased risk there. Unopposed estrogen, up to 30 times increased risk, especially if over 5 years. So no woman with a uterus should ever be placed on prolonged unopposed estrogen. Rarely, you may have women with a granulosa cell tumor or any estrogen-producing tumor. About 20 to 25% of them already may have coexisting endometrial cancer or hyperplasia as well. Early menarche, late menopause, we see a 2-fold increased risk, especially menarches before 12 and menopause is after 55. And tamoxifen, a 4 times increased risk in postmenopausal women. Genetic factors account for about 5% of endometrial cancers, of which Lynch syndrome is the most significant, which confers a 40 to 60% lifetime risk of endometrial cancer, in addition to a 10 to 12% risk of ovarian. And this is compared to the 2% risk of ovarian cancer. So sometimes we forget about ovarian cancer and we just think of colon and endometrium with Lynch syndrome. And this is an autosomal dominant condition with mutations in mismatch repair genes. And then we have Cowden syndrome, not as common, but this confers a 30% risk of endometrial cancer, in addition to renal, colorectal, and melanoma as well. So let's take a deeper dive now into some of these risk factors, starting with obesity. So endometrial cancer is on the rise, and we also know we have a obesity pandemic as well. So obesity is more strongly associated with the development of endometrial cancer than any other cancer in women. Over 50% of endometrial cancer cases are attributed to being overweight or obese. There's a 50% increase in the risk of developing endometrial cancer for every 5 BMI units. Central adiposity is thought to be a more accurate marker of risk. We're looking at the waist to hip ratio than just the BMI alone, however. And not only is there an increase in the risk of the estrogen-dependent types of endometrial cancer, but they have found that the non-endometrioid and more aggressive types are also found to be linked to obesity. So once diagnosed, obesity worsens the prognosis. So it increases the chance of developing endometrial cancer, and it worsens your prognosis with endometrial cancer because it increases the all-cause mortality. As a matter of fact, one study showed that 67% of deaths in one review were a result of non-cancerous causes and were obesity-related causes in women with endometrial cancer. There's generally limited public knowledge on the association of endometrial cancer and obesity. And on our part, as healthcare workers, there's hesitancy on our end in discussing obesity with patients and managing obesity with patients. And one study found that only 29% of women with endometrial cancer were counseled about weight loss by their physicians. And all who were counseled attempted to lose weight. So we need to do our part and educate our patients and help them to manage obesity. So after adjustment for other risk factors, a woman with a BMI over 40 has a 7-fold odds of developing type 1 endometrial cancer compared to normal weight. Obesity also increases endometrial cancer diagnosis in our younger women as well. And there are several factors thought to explain the pathophysiology behind obesity and endometrial cancer. What we know is that in premenopausal women, estrogen production is primarily from the ovaries. After menopause, this switches to the adipocytes through a process called aromatization, where androgens are converted to estrogens in these peripheral sites. So this increased estrogen production does 2 main things. It produces genotoxic metabolites, which causes DNA damage and promotes genetic instability and mutations and malignancy. Also, obesity causes increased estrogen levels are associated with the production of obesity-associated pro-inflammatory adipokines. So we have increased production of leptin, interleukin 6, tumor necrosis factor alpha, abnormal insulin signaling, and insulin resistance. And all these result in a cascade of endometrial hyperproliferation and neoplasia. In addition to this, sex hormone binding globulin levels are decreased in women with obesity, and this further increases the pool of circulating estrogens. So it's several factors at play. Now let's switch gears to reproductive factors. So these play a vital role not only in the etiology of endometrial cancer, but also linked to breast cancer and ovarian cancer as well. So multiparity decreases the risk of endometrial cancer by up to 70%. And any additional birth among parous women after the birth of the second child decreases the risk by a further 10% for each new child. Delivery after age 40, interestingly, was associated with as much as a 60% reduction in endometrial cancer risk. The mechanisms at play: the endometrial exposure to estrogen is reduced during pregnancy. Pregnancy causes progesterone increase and decrease in estrogen levels. There's suppression of the endometrial mitotic activity. There's protection from anovulatory cycles. And interestingly, the shedding of the endometrium at delivery is thought to remove some precancerous cells. A meta-analysis found that breastfeeding reduces the risk of endometrial cancer by up to 33%, with a dose-response relationship noted. So for each additional month of breastfeeding, the risk was reduced by a further 2%. PCOS and infertility. So PCOS in and of itself increases the risk of endometrial cancer by about 3 times, and infertility as well increases the risk. So in a woman with PCOS and infertility, then the risk is even more. Factors at play: chronic anovulation resulting in hyperestrogenic states because of the lower progesterone levels, hyperinsulinemia associated with PCOS, and of course, many women with PCOS are also obese. They have increase in the production again of insulin-like growth factor 1, tumor necrosis alpha, insulin resistance, and all this leads to a cascade of endometrial, may lead to endometrial cancer. Fertility treatment is controversial. Is it the fertility treatment which increases the risk or may increase the risk of endometrial cancer? Is it that these women may be nulliparous or have other confounding factors? One meta-analysis found there was no significant link between fertility drugs and the development of endometrial cancer. A cohort study found that there was a slight increase in the risk of ovarian, endometrial, and breast cancer in women who underwent fertility treatment. So verdict is still out there. Endometriosis shares similar features with malignancies: development of local and distant disease, women who have endometriosis in the lungs, the brain, resistance to apoptosis, invasion and damage of surrounding tissues, the production of chronic inflammation, local and systemic, and endometriosis is definitely linked to some ovarian cancers. Clear cell and endometrioid cancers are linked to endometriosis, but does it increase the risk of endometrial cancer? So we have cohort studies. One such study looked at 392 women with one such study looked at women with endometriosis, found that 392 developed endometrial cancer. They thought it was significant and stated that women with endometriosis may be at increased risk of endometrial cancer and should be monitored closely. A meta-analysis looking at 17 studies found no significant link between endometriosis and endometrial cancer. Now let's look at SERMs, or selective estrogen receptor modulators, have definitely been found to increase the risk of endometrial cancers, and we rely on these drugs a lot in managing women with breast cancer. So tamoxifen has an estrogenic effect on the uterus, thereby increasing the risk of endometrial cancer, but on the breast, it has an anti-estrogenic effect, and as such reduces recurrent breast cancer. A safer option is raloxifene, which has anti-estrogenic effects on the breast and endometrium. So it reduces the risk of breast cancer without increasing endometrial cancer risk. So finally, can we reduce the risk of endometrial cancer? So let's see what can be done. Firstly, public health interventions that decrease the overall prevalence of obesity may have the greatest impact on decreasing endometrial cancer rates in the population. So in studies looking at weight loss and the reduction in the risk of endometrial cancer, there's one large prospective cohort study which found a non-significant risk reduction with intentional weight loss of at least 20 pounds. Another study stated that weight loss actually should be sustained because they found that regaining weight or weight cycling repeatedly was associated with an increased risk. Exercise, meta-analysis of 20 cohort and case control studies found up to a 30% reduction in endometrial cancer risk in women who reported moderate or high intensity exercise. The Nurses' Health Study found a 35% reduction in women who exercise compared to those who did not do any type of exercise at all. And just daily walking in otherwise sedentary women was found to reduce the risk. And the ACS prevention study found a reduced risk in endometrial cancer was only noted, however, in women who were overweight or obese, suggesting that women at the highest risk benefited the most from exercise. Diet, several studies have looked at this. Two main ones here, the dietary arm of the Women's Health Initiative, or that famous WHI study, randomized women to a low-fat diet rich in fruits, vegetables, and grains, and they found no difference in the endometrial cancer incidence after a follow-up of 8 years. When looking at the Mediterranean diet, case control studies suggested a decreased risk. Prospective data from WHI cohort study found no difference in the risk. What's found, however, is that diets with a high glycemic load increase the risk by up to 20%. No effect was found with dairy and endometrial cancer risk. Now, coffee and tea. Coffee consumption may lower the risk of endometrial cancer. Many of us are happy to hear this. Similar reduction is seen with green tea, but no such link with the black tea. Alcohol, no association with alcohol and endometrial cancer, but sugar-sweetened beverages may increase the risk of type 1 endometrial cancer independent of BMI. And smoking may reduce the risk of endometrial cancer due to anti-estrogenic effects, but this is not something we would promote at all because of the many health consequences. I'm going to just jump over this slide. Bariatric surgery, they found overall about a 60% reduction in the risk of endometrial cancer after bariatric surgery compared to obese controls who did not have surgery. The risk reduction may be as high as 81% if women are actually able to maintain the normal weight after surgery. In a study looking at women who presented for bariatric surgery, so asymptomatic women were found to have endometrial hyperplasia, about 10% of them, so almost 1 in 10 came in because they're obese and presented for bariatric surgery. And 10% up to 10% actually had precancerous changes in the endometrium. But interestingly, regression was noted in most of them after bariatric surgery. Looking at pharmacoprevention now, starting with the oral contraceptive pills, meta-analysis of 36 case control studies showed about a 31% risk reduction in women who ever used the pill compared to those who used the pill compared to those who never used the pill. And the longer the duration, the lower the risk. And these effects were thought to persist for at least 30 years after cessation of use of the pill. Progesterone-only medication like the injectable Depo-Provera or depo-medroxyprogesterone acetate, significant risk reduction for endometrial cancer. Even the levonorgestrel implant, 31% risk reduction in endometrial cancer risk. Hormone replacement therapy. It is something women should be worried about, starting HRT and the risk of endometrial cancer. Well, what we know for sure is estrogen-only HRT increases the risk of endometrial cancer. As was stated before, effects of estrogen on the endometrium. So this should not be done in a woman who has a uterus. It's an option for women who have had a hysterectomy, where they can explore estrogen-only HRT, but not if they have a uterus in. So the safest way of giving HRT is found to be the continuous or combined continuous HRT. This may actually lower the risk. So from the Million Woman study, they found a risk reduction of about 30%. And so they stated that this is, if it's going to be given, this is the best way in a woman who has a uterus. Not cyclical progesterone and certainly not estrogen only if a woman has her uterus in. Aspirin may reduce the risk. There's some studies which look promising. From meta-analysis of 9 case control studies, found some reduction. However, we still need more data on this before this can be recommended. And metformin has antiproliferative effects on the endometrium, on hyperplastic and cancerous cells in vitro, And we do have studies looking at this which are inconclusive. One study did not prove, a meta-analysis by Z et al. Did not show any significant reduction, but they stated that it could reduce the mortality risk in women who are diabetic and have endometrial cancer, and also prolong the progression-free survival. And what's very popular right now, very fashionable, is glucagon-like peptide 1 or GLP-1 receptor agonist. So we have women on Wegovy and all these semaglutide derivatives, and we've been hearing talk of these in the media and celebrities and so on. So it really works in managing obesity. So by extension, does it work in reducing the risk of endometrial cancer? So we know that these receptors or these agents or these receptors play a role in diabetes and endometrial cancer. So maybe we can use them for endometrial. They play a role in obesity and diabetes, so maybe play a role for endometrial cancer. It's found that these agonists have been reported in vitro to cause autophagy of endometrial cancer cells, and there's preclinical data showing an antiproliferative effect of GLP-1 agonists on endometrial cancer cell lines and organoids, and GLP-1 receptor expression has been reported in some endometrial cancers. So with all this, there are actually phase 1 and phase 2 trials. Haven't seen any phase 3 or phase 4 studies yet, but it will be interesting to see what comes out of these. So there's this one, for example, looking at using levonorgestrel intrauterine device with semaglutide, for example, versus levonorgestrel alone in managing women with endometrial hyperplasia looking for regression of disease. So we can look out for these results. So there's a summary table of the different lifestyle pharmacotherapy which can be used. So finally, should we therefore just screen for endometrial cancer? So we know cervical cancer, for example, is established. It meets certain requirements to be screened for, but why not endometrial cancer? I mean, it is a public health problem. There's acceptable treatment. The natural history is understood, however, not as clearly defined from a precancerous stage to a cancerous stage like we see with cervix. So we do have a major limitation there. So there isn't a defined latent or early symptomatic stage. So we do have endometrial hyperplasia, which can be simple, can be atypical, but up to 50% of women who we diagnose with atypical hyperplasia already have cancer on board. So there isn't a real clear latent asymptomatic stage. So population-based screening has no role currently in detecting endometrial cancer at women at average risk. Screening is, however, recommended for women with Lynch syndrome. So with women with Lynch syndrome, as I stated earlier, up to a 40 to 60% risk of endometrial cancer versus the 3% lifetime risk. So we strongly advise hysterectomy by age 40. We also advise removal of the tubes and ovaries because, as mentioned, they're also at an increased risk of ovarian cancer. Alternatively, or by age 35, we should start offering them endometrial sampling or discuss with them placing a levonorgestrel intrauterine device to prevent endometrial cancer. So what should we do instead? So there's no set guidance on screening all women for endometrial cancer, but we know most of these women are postmenopausal. We should advise them to have any vaginal bleeding should be investigated. We should have a low index of suspicion in premenopausal women, especially those under 40, as I said, 4%. So not everybody who has abnormal bleeding, it's due to fibroids. The fibroids could just be, innocent bystanders. No evidence to support screening in obese women, but we should take this into consideration as well when we risk assess our patients. And we should appropriately treat endometrial hyperplasia to prevent progression. Another thing that's commonly discussed is looking at the endometrial thickness. So in postmenopausal women, we have established guidelines on what endometrial thickness is concerning for cancer versus those which are less concerning. So from Smith and Beidman's major landmark paper, we have established that an endometrial thickness of less than 5 millimeters on ultrasound is associated with about a 1% risk of cancer. And this has a sensitivity of about 96%. So the cutoff we use now in a woman who is postmenopausal, bleeding more than 5 millimeters, more than 4 millimeters is a significant thickness and should be investigated. But what about women? We may see women who have an incidentally detected thing in the endometrium. She does an ultrasound for some other reason. She's not bleeding. She's postmenopausal. What do we do in this case where she's not bleeding but it's thick? So the same group, Smith and Bindman, reported on a theoretical cohort of women and found that who are not bleeding and found that a cutoff of about 11 millimeters or more equated to the risk of cancer as a woman who is bleeding of 5 millimeters. And as such, the guidelines suggest in a woman who is asymptomatic, not bleeding, with an incidentally detected thing endometrium, you can use a higher threshold. In premenopausal women, the guidelines aren't as clear, and part of the reason for this is because of the cyclical variation in the endometrium due to the hormonal cycle. So what can be done? One, assess the endometrium when just after the menses, days 4 to 6, ideally when it should be at its thinnest, and a cutoff of about 8 millimeters showed the best sensitivity and specificity for detecting hyperplasia and cancer in the premenopausal women. In one review, women who actually had hyperplasia or cancer had a thickness of closer to 18 millimeters, but they thought 8 millimeters was a reasonable cutoff. And from the ACOG committee's opinion, they give us some guidance on this as well. So what is stated that ultrasound screening should be the first line in low-risk women with postmenopausal bleeding. So what I mentioned earlier about the 4 millimeter cutoff is useful in low-risk women. If you have a high-risk patient, right? So you have patients who are high risk of endometrial cancer, you don't even need to go through the ultrasound pathway. You should really just screen her. You don't need to triage her with ultrasound at all. If she's high risk bleeding, she needs to be screened. Also, we should bear in mind that endometrial cancer can present with a thickness of less than 3 millimeters. As I mentioned before, the type 2s, the more aggressive types, can arise on a thinner endometrium. So we should always have a high index of suspicion, especially in our population. As I mentioned, we have a lot of type 2 cancers. Any woman with persistent or recurrent bleeding should be investigated regardless of the endometrial thickness. Endometrial measurement of more than 4 in a woman who is not bleeding, as I mentioned, does not routinely require evaluation. However, you should risk assess the patient, but a higher cutoff of 11 can be used. Right? So we should always individualize and risk assess our patients. And this is just an algorithm just showing you management of postmenopausal women who are bleeding, low risk, ultrasound, high risk, endometrial sampling. You don't even need to do the ultrasound. Postmenopausal bleeding, postmenopausal not bleeding, high risk, and endometrium is more than 4 millimeters, you need to assess. If she's low risk and more than 4, you may decide to investigate or use a higher cutoff as well. And these are some of the risk factors which we discussed earlier. So with that, I'd like to thank you for your attention. Sorry I can't be there with you in person today. As you can see from these photos, I enjoyed my last trip there in May. So looking forward to visiting the Bahamas again. So I'll take any questions you may have at this time.
Thank you, Dr. Medley. We have time for one question. Do you have a question from the group?
Yeah, Dr. Bloomfield here.
All right, Chief.
Good afternoon. Excellent presentation. I would be so happy if you'd make this presentation available for us. If not open publicly, certainly by requesting by email. I think it was a very interesting presentation. One of the problems that we face is the issue with obesity. I think sooner or later we have to start recognizing obesity and how we actually define obesity versus overweight as one of the NCDs, because it's very, very difficult for people to get a grip when you make the suggestion that they might be overweight or they may be obese. And then what is it that they do? A lot of people are actually embarrassed. Sometimes just the mere suggestion that they need to start taking better control. You know, they often resort to alternative medicines and tricks, figuring that that's going to put an end to all of the factors and the things that obesity can lead to. But I would love for you to make your presentation available certainly to me and other people like me. Very, very interesting.
Thank you for your comments. And I can share it with the organizers to have them circulate it to you. And I agree with you because it's a linear progression with the risk from being normal weight, overweight, and obese. So there isn't anything medical that happens at a BMI of 30 that might not already be at increased, the patient is at increased risk of from just being overweight. So it's a continuum, and we should start to address the issue from persons who are overweight all the way up. As you said, there's a lot of issues with embarrassment. We're not comfortable talking to the person about weight because oftentimes we may think it's just cosmetic. But when we can open person's eyes to the fact that this is your health, it's a disease that's going to put you at risk of breast and endometrial cancer and so on, then maybe some of the stigma and the embarrassment will go. So a lot of it is work that we need to do as as healthcare providers. So yeah, I agree with you on that.
Okay, thank you again,
Yeah.
Dr. Medley. I just want to
Thank
make
you.
one point. I'd really like to see, a collab.
Moderating.
Pardon? Well, I'd really like to see, I don't know if you guys have this in the works, but I'd really like to see a collab within the Caribbean, because it's interesting to see that, type 1 and type 2 is like 50-50 for us Black people, or us people here in the Caribbean. But in the other areas is, 80-20. And as you pointed out, the type 2s tend to be the worst. So
Right.
nice to see what happens in the different Caribbean countries as a whole, just to see if we could figure out why is this happening to us.
Yes, I agree. And oftentimes we are trained based on where the studies were done. And that's what we're taught. That's what we run with all throughout mid school and in our careers. But when we actually stop and look at what's our local practice, we may realize it differs significantly from the places who write the textbooks or do the studies. So I don't know if it's a case where it's increasing the type 2s or it's just been that way, but we just haven't, it hasn't gotten a lot of attention based on compared to where the studies have been, been done. Yeah, but so yeah, collaboration would be useful to see what's the experience in the other islands as well in the region.
All right, thank you again. And we now move on to our next speaker. Our next speaker actually is one of our own, Dr. Burrows, and she's actually going to be talking about thoracic spinal tumors masquerading as lower back pain. Now, Dr. Burrows is an SHO, or Senior House Officer in the Department of Surgery at Princess Margaret Hospital, Nassau, Bahamas, and she began her medical training at UWI St. Augustine's College in Trinidad, where she completed a preclinical, and then she came home to the Bahamas to finish up her clinical years. Her interests include surgical education, clinical research, and improving access to quality surgical care in underserved regions. She believes that nurturing curiosity both inside and outside the hospital is essential to personal growth and professional excellence. Her journey reflects a deep commitment to lifelong learning, service, and meaningful engagement with the world around her. Let us now welcome Dr. Burrows to the podium.
Hi, good night. Is everyone able to hear me and the screen is visible?
Yes, we can hear you, and the screen is visible, yes.
Okay, thank you. So good afternoon. I'll be presenting case reports on benign spinal tumors masquerading as lower back pain. I have no disclosures for this presentation. Spinal tumors are neoplasms that can arise from the vertebrae, meninges, or the spinal cord itself. They can be classified as extradural, intradural, extramedullary, or intradural, intramedullary. They can also be classified as benign or malignant, with the majority of these regions being metastatic. The majority of benign spinal tumors are schwannomas and meningiomas, with schwannomas commonly occurring in the lumbar spine and meningiomas commonly occurring within the thoracic spine. Rarely, patients with spinal tumors may also present with a primary complaint of lower back pain, which is one of the most common presenting complaints to the primary care physician or accident emergency department. When these patients do present, the origin of their back pain is often believed to be musculoskeletal in origin, and this often results in continued treatment with analgesia until patients present with worsening of symptoms, such as lower limb weakness, resulting in difficulty ambulating. This is when it's noticed that the lower back pain can sometimes present with a more sinister pathology, such as spinal tumors. And these two case reports describe such scenarios. Case 1 is a 39-year-old male who had a 2-month history of left lumbar pain, who presented to a peripheral hospital on the Family Island where he was seen and assessed as having this pain being musculoskeletal in origin. So he was discharged on oral analgesia and no follow-up care was arranged. The patient then returned to the same facility about 8 months later with the pain now progressively worsened. So the plan was him to have physiotherapy and orthopedic clinic. The patient then decided to come to Nassau, the capital, for further assessment. The patient then presented to a general practitioner where he had an MRI of the lumbar sacral spine completed. The patient, at that time, the GP then decided to continue the patient on oral analgesia. But 1 week later, the patient then began to have progressive lower limb weakness. And 3 weeks later, the patient was then confined to a wheelchair. And then this is when the patient was referred to a private orthopedic spine surgeon. On physical exam at the time, it was noted that the patient had decreased power in both the left and right side, also associated with hyperreflexia and clonus. He also had decreased sensation at the level of T9. At this time, he was assessed as having thoracic myelopathy due to a thoracic intradural extramedullary tumor. He was then sent to have a thoracic MRI completed. The patient also had initial x-rays completed. These were his initial lumbar sacral spine x-rays, which were unremarkable. He had an MRI, this is the MRI that was requested by the general practitioner, which was also unremarkable. These are the axial views of that image. This is now the thoracic MRI, which was requested by the spine surgeon, which shows a well-circumscribed intradural extramedullary mass at the level of T9, which did enhance with contrast. This is the image. This is the T2 weighted image. And this is the axial view of the image, showing the spinal tumor arising from the nerve root, pushing the spinal cord over to the right side. And this is the coronal view of the image. So at this time, the patient was then booked to have posterior thoracic decompression and resection of the spinal cord tumor with posterior fixation of the thoracic spine. These are some intraoperative images. This shows the expanded fecal sac secondary to the presence of the tumor. And these are pedicle screws that were also placed to ensure that the spine was stabilized. An intraoperative ultrasound image was also completed during the procedure to help with locating the tumor. And this shows where the spinal cord tumor was compressed to the side. This shows where the spinal cord was compressed to the side secondary to the presence of the tumor. This is when a durotomy was performed. This shows the spinal cord tumor and also the spinal cord being compressed. This image now shows when the spinal cord tumor was resected and also shows where there is an indentation on the spinal cord. So the tumor was then sent to histology. This is an example of the slide, and it had classic features of a schwannoma with Antoni A and Antoni B bodies, and also hyalinized blood vessels. The patient had a good outcome postoperatively, and at about 6 weeks, he was able to ambulate with a walker. And at 6 months, he was able to ambulate independently and is currently driving. Now, case 2 is a 44-year-old female who complained of intermittent dull lower back pain that was non-radiating with a severity of 3 to 4 out of 10. She initially presented to her general practitioner, who ordered x-rays, had the patient on oral analgesia, and then later decided to order an MRI of the lumbar sacral spine. Based on those findings, the patient was referred to an orthopedic spine surgeon. At that time, surgery was offered to the patient, but the patient defaulted. But she represented 1 year later with worsening of a lower back pain. On her initial physical examination, when she was first seen by the spine surgeon, it was noted that she had decreased power in both lower limbs associated with hyperreflexia, And at this time, she was assessed as having thoracic myelopathy due to thoracic intradural extramedullary tumor. Now, these are exam findings 1 year later after she defaulted, showing that the lower limb weakness continued to worsen and is now associated with clonus. This was the initial MRI that was requested by the primary care physician, showing that the patient had mild disc herniation at the level of L5 to S1, and also an incidental finding of a well-circumscribed benign tumor at the level of T12. This is the patient's first thoracic MRI imaging that was completed, showing the tumor again, and then this shows that it enhances with some enhancement with contrast. This is the T2 image. Now, this is the second thoracic MRI that was completed after the patient had defaulted for 1 year. So you see the well-circumscribed mass with some enhancement with contrast. This is the T2 axial image showing a hyper-intense tumor coming from the right with the compression of the spinal cord to the left. And this is a comparative slide to show the initial size of the tumor at a first MRI and the increase in size during the second imaging. So this patient was then booked to also have resection of a spinal cord tumor, and the specimen was sent for histology. This is a slide from the specimen showing classic features again of a schwannoma with Antoni A and Antoni B bodies. The patient did have a good outcome and is now able to ambulate independently. Now, there are a few of these cases reported in literature. Bouquet et al. Discusses 7 patients who initially presented with lower back pain that were believed to be lumbar pathology. So they had lumbar surgeries completed, but they then represented with worsening of their lower back pain and also with progressive neurological deficits in their lower limbs. So they were later diagnosed with having benign intradural spinal tumors. While Nafo et al. Also discusses a case of an elderly female who had persistent right leg pain and was assessed as having degenerative disc disease and had an L1 to L2 discectomy completed. She then represented with worsening right leg pain, and she was later diagnosed with having a benign intradural spinal tumor. Now, overall, these patients show good recovery, but functional outcome is also based on the severity of motor function at the time of the diagnosis. Ranwa et al. Discusses where there were 130 patients who had resection of the intradural extramedullary tumor, and 49.3% of them had significant improvement in their motor function. While Singh et al. Discussed 180 cases of resection for spinal schwannomas, and 67% of these patients returned to normal ambulation. So we recommend that when patients do present with lower back pain, which is deemed to be musculoskeletal in origin, patients should be treated with NSAIDs and muscle relaxants and reviewed by their primary care physician in about 2 weeks. Now, if this pain is unresolved, they should not be elevated to opioids, but they should be referred to a spine surgeon for further assessment. So in conclusion, lower back pain is a common presenting complaint and is often assessed as being mechanical in origin, but it can be associated with a more ominous diagnosis such as benign spinal tumors. So we shouldn't try to meticulously evaluate patients to ensure that cases like these are no longer missed. So these are my references. Thank you. Does anyone have any questions?
Thank you, Dr. Burrows, for that wonderful presentation. Yeah, so does anyone have any questions about this? Comments? All right, Dr. Burrows, I guess I have a question. Not sure if you were there for any of these operations, but how did you get this tumor out? Did it just shell out, or how did you get this off of the spinal cord?
Ideally, we should have a cruiser. That's a surgical instrument that's usually used to dissect tumors at the level of the spine, but we've had to use the suction to help get some of it out, and also basically taking it out piece by piece meticulously for the most part.
Okay. And these are benign tumors, yeah? So
Yes, sir.
not necessarily have to worry about any margins per se. And it's interesting also to see that they were all in the thoracic region. Is that a common place that they tend to be?
The schwannoma is commonly in thoracic and meningioma is commonly in the lumbar spine.
Okay. All right, I see Dr. Mortimer has his hand raised.
Yes, good evening and excellent presentation, Dr. Burrows. The referral to the orthopedic spinal specialist, I want to ask it, you're talking about thoracic pain or lower back pain or both? When you say that the patient should be referred after 2 weeks of,
Both of these,
analgesia.
yes, sir. Both of these patients had lower back pain on their initial presentation, but on completing the full neurological assessment, based on them both having lower limb weakness and also being associated with hyperreflexia and clonus, that suggested that the pathology was higher than the lumbar spine. So that's why the thoracic imaging was also ordered, and that's when the tumors were revealed.
Okay. Well, lower back pain is a very common presentation to primary care doctors. So the orthopedic spinal specialist is going to be overwhelmed. When do you recommend a primary care doctor should order an MRI? Because I do order them sometimes with contrast, but can you clarify, what a primary care doctor should do when presented with such a, this type of patient, when it comes to the diagnostics and the imaging and that kind of thing, and then the referral to.
Yes, sir. So you can continue to request the lumbar MRIs. It's just that when on the physical examination, like how both of those patients had bilateral lower limb weakness associated with hyperreflexia and clonus. So those physical exam findings suggest that the lesion, what's going on, is higher than the lumbar spine. That suggests that it must be in the thoracic spine. So when you're monitoring them patients, you could also request a thoracic MRI, but the main take home here is that when managing patients with lower back pain, you can give them oral analgesia. If that doesn't resolve the pain, when they come to follow up within the 2 weeks, that's when they should be referred to the spine surgeon specialist. So we have orthopedic spine surgeon specialists and we have the neurosurgery spine specialists, so that they can be further evaluated.
Excellent. Okay. And in a short time, so that they don't go on for a year and then present when the symptoms have been, have gotten worse and the condition has worsened, of course.
Yes, sir.
So early referral, that's the message you were saying.
Yes, sir.
Opposed to waiting. Okay, thank you.
I believe we have time for one more question. I see Donnie Davis, hand is raised.
Yes, thank you. Definitely enjoyed the presentation. My question though is you've landed on a strong and definitive conclusion and a recommendation. How do you have this share? What mechanism do you see for the sharing of this conclusion with colleagues?
So it can continue to be presented on platforms such as this, and we also plan to publish the research as well to have it accessible to others.
Okay, good stuff. Thank you.
Yes, sir.
Okay, thank you, Dr. Burrows. All right, our next speaker will be speaking to us. One of our very own yet again. And she is no stranger to the podium. This would be Dr. Delicia Bodie. Apparently she just recently got out of the operating room, so she's been pretty busy today, and she's blessing us with her time now to talk to us. Dr. Bodie is a general surgeon at Princess Margaret Hospital, and she is actually the first Bahamian female surgeon to pass our DM surgery program here in the Bahamas. She currently serves as a general surgeon at Doctors Hospital, as well as a senior registrar here at PMH. She's a strong advocate for continuing education and advancing techniques. She is recognized as Associate Fellow of the American College of Surgeons, and she further honed her expertise by completing the MIS Master's course of Advanced MIS and Robotic Techniques for Emergency General Surgery at the ACS Clinical Conference just this month in Chicago. Her professional affiliations include the Caribbean College of Surgeons and the Society of Laparoscopic Surgeons. She was honored in 2024 as one of the Professional Services Bahamas top 40 under 40 successful and influential professionals. Let us now welcome Dr. Bodie, who is going to be talking to us about the clinical epidemiology of trauma patients presenting to the Princess Margaret Hospital, implementation of a national cancer or trauma registry. Sorry. Dr. Bodie.
Good evening, everyone. Thank you again to the UWI SCMR for allowing me to give this last talk for the conference. And without any further ado, I will proceed. I have no disclosures for this presentation. So trauma is defined as any physical injury resulting from sudden force, such as violence, accident, or impact. And trauma can encounter and range from minor or life-threatening injury and can be classified as blunt, accelerating, decelerating, or penetrating trauma. The Bahamas and Princess Margaret Hospital in particular is no stranger to trauma or trauma-related mass casualty incidents. And this slide is actually taken from my 2020 presentation on the distribution of trauma-related mass casualties following the aftermath of Hurricane Dorian. And it emphasizes the number and degree of trauma cases that we encounter here at Princess Margaret Hospital. In 2019, the World Bank reported an almost 14% mortality rate from traumatic injuries. And for that same year, the rate of age-adjusted mortality for external causes was upward of 90 per 100,000 population, including road traffic accidents and homicides. In Jamaica, Plummer et al. Reported the peak incidence of trauma to be in the second and third decades with a male to female ratio of 2.5 to 1, and the distribution in descending order, including intentional injury accounting for almost 50%, motor vehicle accidents, falls, and burns. In the US, trauma is the leading cause of death in persons up to age 45 years and the fourth leading cause of death for all ages. With increasing prevalence of trauma-related presentations to the Princess Margaret Hospital, we thought it imperative to evaluate the clinical epidemiology and patterns of trauma presentations and to improve management and outcomes for patients. The aim of the study was to evaluate the clinical epidemiology of trauma-related presentations to the Princess Margaret Hospital with objectives of implementing a trauma registry at the Princess Margaret Hospital, identifying temporal patterns of presentations, and identifying locations of trauma-associated geographic hotspots. For this study, a retrospective chart review was performed and included all patients who presented to the Princess Margaret Hospital with trauma-related injuries in 2024. Any patient who presented without a trauma-related diagnosis or presenting outside of the study period was excluded. We collected data from the PMH emergency room registration logbooks. Patients' demographics, diagnosis, mechanism, and level of injury, as well as their dispositions were evaluated. Temporal and geographic patterns of distributions were identified. So a total of 3,626 documented trauma-related presentations occurred or presented to the Princess Margaret Hospital just last year. Looking at the distribution, the majority of cases were from New Providence. and we did not note any temporal pattern of distribution for the trauma cases. The majority of patients were male, and patients younger than 18 and the age 26 to 35 age group presented more frequently for evaluation and management of trauma-related injuries. The majority of cases presented were classified as level 3 traumas or consultations. And looking at the actual diagnoses, soft tissue injuries were the most common trauma-related diagnosis. Soft tissue injuries, lacerations, and fractures occurred more frequently in the pediatric age group. And with regards to mechanism of action, motor vehicle injuries by far were the most common mechanism. Motor vehicle collisions, physical assaults, and falls occurred more frequently in males. And of note, males in the 26 to 35 age group were more commonly involved in motor vehicle collisions and physical assaults. Males aged 26 to 35 years old were involved in motor vehicle collisions more frequently as the most frequent indication for admission. And looking at our discharges, luckily almost 85% of patients who did present to Princess Margaret Hospital with trauma-related diagnoses were discharged from the ER. With regards to our admissions, although we see here admissions for ICU and specifically, although burn injuries accounted for only 2.4% of trauma presentations, they were actually the most common indication for ICU admission and accounting for over 50% of trauma ICU admissions. We unfortunately were unable to determine the type of burn injuries due to the lack of documentation. However, the highest documented total body surface area was 25%. Similarly, when we look at our OR trauma cases, penetrating traumas only accounted for 4.4% of the overall trauma presentations. However, they represented 75% of our OR trauma cases. We were unable to determine the exact mechanism of penetrating trauma, again due to lack of documentation, but the presumed was gunshot injury as the most common mechanism. This slide shows the constituency map of New Providence, and it highlights the constituency areas from where the most frequent trauma patients reside. We were not able to distinguish from the records whether or not in terms of the trauma actually occurred in these areas or if this is just their actual place of residence. When we do look at trauma mechanisms by constituencies, these are the top two, the Carmichael and Pinewood areas. We see that motor vehicle collisions were more common in both, and penetrating trauma most common in Pinewood constituency. And this graph displays the record of trauma deaths reported by the Royal Bahamas Police Force in 2024 by mechanism. There's a red line at the bottom of the first curve that actually represents PMH trauma deaths. We were not able to determine the immediate to early trauma deaths as this was outside of the scope of the study. Looking at trauma deaths, they were equally distributed between penetrating motor vehicle collisions and polytrauma patients. So looking at the limitations of the study, we were limited in that some entries did not have a diagnosis, and we most likely did not capture all of the trauma presentations to Princess Margaret Hospital. Of note, there was no data available regarding the mode of transportation to hospital, meaning private car versus EMS or air ambulance. And we were also unable to discern between blunt and penetrating injuries, which were accidental versus intentional. And lastly, we were unable to determine whether trauma happened at the patient's residence or if this residence is just documented as where they live. So in conclusion, the volume of trauma and trauma admissions to the Princess Margaret Hospital far exceeds the requirement for establishment of a level 1 or criteria for a level 1 trauma center. There is growing concern about the number of young males involved in trauma-related injuries and concerned about the type of trauma occurring in certain constituency areas, namely the Carmichael, Pinewood, and Fox Hill constituencies. The predominance of motor vehicles presenting to the Princess Margaret Hospital also raises grave concern about adherence to road traffic safety practices and highlights the need for enforcement of these safety practices and implementation of necessary reprimands by the respective authorities. These are my references, and I'd like to thank you all for your attention.
Awesome presentation, Dr. Bodie. We truly enjoyed it.
Thank
Do
you.
we have any questions from the group? All right, Bodie, I got two questions for you, right?
Okay.
Just looking at your charts, right, I found something was quite interesting with the, I guess, the distribution or the age distribution of the trauma cases. And it looked like it was 20% in the 18, under 18, and then it dipped down to 18 to 25. They had like 15%, and then it bounced back up from 25 to 30 plus.
Yep.
What do you think happened to those 18 to 25? Why do you think they stopped getting involved in trauma? Or why do you think there was a dip?
I'm not sure why there's a dip in that area. I know usually the pediatric, they're usually more active. They come in with the cuts, the lacerations, the slip and falls. And then you typically have the older, the 26 to 35, who are the young adults and free reign. And this usually, or what we noticed was usually the ones who were involved in the motor vehicle and the penetrating trauma. So I think it's those who have free reign, and then those who need more in terms of observation or closer watch are the ones who are typically involved in the motor vehicle collisions. Maybe that age group in between, I'm not sure. Maybe those are those who are off to university and not involved in anything, but we didn't pinpoint anything why there was a dip in that 18 to 25 age group.
Because I remember being 18 to 25. I thought I was Superman at that time. But again, you know, it would be more prone to trauma. Okay, but then my other question for you is that you see that 85% of them are actually discharged home. That's a pretty high number for all these traumas. So is there somewhere else these trauma patients could possibly be seen to try and minimize the burden on the emergency room? I don't know. I'm just asking because that's a lot of people that just discharge from the ER.
Well, I think that's the general issue with the ER. It's being used as a clinic for any other thing, even chronic non-communicable diseases. So I think having active use of the polyclinics, the community clinics for minor injuries would be beneficial. But who's to say what is what when the patient comes in with their quote-unquote emergency? But I think probably advocating that what actually classifies as a minor trauma and encouraging persons who meet criteria for minor traumas to go to the community clinics would help. And that same thing is even reflective in the presentation where most of our referrals were actually consultations. So persons who didn't actually need the full surgical and ER team meeting them in the ER on presentation. That was the most of the referrals or presentations to hospital.
Okay, great. Dr. Davis really wants me to ask you this question because she put it in the group and then she direct messaged me just to make sure that I don't miss it. So Dr. Davis says, good afternoon. Given the findings from Dr. Bodie's study, how soon will a trauma team be established?
Is that Dr. Raquel Davis?
Davis McKinsey. I think maybe Pavio.
Oh, well, we will leave that to the heads of the department to make that decision.
Dr. Bloomfield says significant changes with consequences will be necessary to change the reckless behavior of drivers on motor vehicles.
I'm sorry, that was a comment or a question? Oh.
Yeah, more like a comment. Significant changes will be necessary to change the reckless behavior of drivers of motor vehicles.
Yes, I agree.
So basically, adherence to the road of the law of the road, which there really isn't any law.
So we would need the assistance of our policemen to strictly enforce those road traffic regulations.
Definitely. All right, I don't see any hands raised. Okay, I think you're off the hook now. Thank you again,
Thank
Dr.
you.
Bodie. Truly appreciate taking the time in your busy schedule. All right, so we're winding down now. We just have two more presenters. So coming to the end of our talks here. So our next presenter is going to be looking at the effects of cannabis on fracture healing, a zebrafish model. And this will be given to us by Dr. Akeem Smith, who is a fourth-year orthopedic surgery resident at UWI Mona. He earned his bachelor's MBBS degree with honors from UWI, where he demonstrated consistent academic excellence and leadership. During his tenure as vice president of the UWI Mona Guild of Students, he contributed significantly to student welfare initiatives and institutional development. His outstanding service and representation have been recognized through numerous awards, including commendations from the Prime Minister of Jamaica and the Spanish Embassy. Notably, he served as a junior ambassador representing Jamaica, reflecting his commitment to national service and diplomacy. He exemplifies the integration of scholarly achievement, leadership, and service, aligning with the university's mission to advance knowledge and contribute meaningfully to national and regional development. Let us now welcome Dr. Smith, to the podium.
Hi, good evening, pleasant evening. Are you seeing me?
Yep, all good.
All right. Thank you for having me this evening. I'll just be doing a presentation on behalf of the UWI Mona and the University Hospital of the West Indies in Jamaica. And the title is The Effect of Cannabis Extracts on Fracture Healing Using an Animal Model, specifically the zebrafish model. I have no disclosures this evening, and this is my outline. So in terms of the cannabis extracts, there's been a potential for cannabis over the last 2 decades, which has garnered some renewed interest. However, the literature presents conflicting evidence regarding the health benefits of cannabis extracts, particularly concerning those effects on bone growth itself. This study aimed to elucidate the impact of different cannabis extracts on bone healing and regeneration, particularly in adult zebrafish following caudal fin fracture and amputation. So just to give a bit of background, in North America, the US has nearly about 8 million fractures per year, costing some $21 billion annually. However, unfortunately, about 10% of these fractures, you can experience complications during healing, which can lead to pain and limited mobility. So there's been a demonstrated need in medicine and a market for developing novel therapeutics to improve fracture healing. However, these studies in humans are quite tedious and models are limited because of their invasive nature. So this brings me to the topic of the zebrafish. So you're thinking, what can these small fish really teach us? Known as denario fish, they're quite tiny, measuring just about the length of your fingernail. Remarkably, they share about 85% of genes, and you can compare that to other mammals like mice, which shares up to 90%. So it's quite similar. However, the fish, they can actually do something quite incredible. In fact, they can robustly regenerate their appendages after amputation or injury. So you could actually, if you look at this picture, I don't know if you can see my pointer, but the white dashed line that indicates an area that you could actually fracture. And then over time, as short as 2 weeks, the fin will actually grow back. And it ossifies similar to our bone healing, undergoing enchondral ossification. So we could actually over time observe without that invasive manipulation that's needed in the lab. So here you can see a histological analysis. If you were to amputate the fin, put them under the light microscope, you could actually stain it with a dye, which has a high affinity for calcium, and then you could actually look at our morphology for calcium deposition and healing. And here you can see from left to right, you can see the early stages of bone healing all the way to the ossification period. And if you just pay attention to the row C, where you see the alizarin red, You can actually see from the left going all the way to the right. You can see 1 DPC for day post crushing. You can see the actual injury. And then as you go all the way to the end, you can see where the bone starts to reorganize and heal. So the aim of this study was to determine the effects of variants of cannabis, specifically tetrahydrocannabinol, THC delta 8, cannabidiol, which is CBD, and the aromatic compounds found in cannabis, known as terpenes, and how they affect the fracture healing and the caudal fin regeneration in the zebrafish. So the hypothesis was that the cannabidiol group would actually accelerate the rate of regeneration and increase the bone thickness of the caudal fin. So it was an experimental study in Nature from October to March 2024 to 2025. And this was a collaborative effect between the Department of Biochemistry, Basic Medical Sciences, and the University of the West Indies, Mona. This was the first of its kind collaborating between 2 departments, Basic Sciences and Clinical Sciences. And we had gained ethical approval from the MCREC and the UWI Mona. So here you can just see a picture of the lab setup. Just partly you can see the bath with a shoal of fish. And what we had done was we had divided them into 4 groups. A control group, which received no exposure to any extracts. One that was exposed to CBD only, 1 to THC only, and then 1 to the terpenes. The fracture was induced on day 0, and then we analyzed the fracture pattern at day 1, day 5, day 10, and then finally at day 15. After which we amputated and looked at it under the microscope. So here you can just see a picture just showing the staining of the fin. You can see methylene blue and the negative stain being the alzarin, and there you can see the pattern towards the extreme left is the crush area, and you can see as the fin regenerates. So the inclusion criteria included adult zebrafish, and they mature fully at 6 months. They underwent the same diet. We included a similar fracture pattern across the board using a bone crusher with PPSI of 6. The exclusion criteria would have had to exclude any previous injured fish, any fish that showed any sign of any illness, and any fish that was previously exposed to local anesthesia. So in terms of the results and data, we had used the one-way ANOVA F test. And here you can just see on the graph, looking at the Y and X axis, we had measured the caudal fin regeneration at the top, the middle section, and the lower section of the fish. So we had measured here at the upper border of the fin, then the mid border, and then the lower border. And then we populated that onto the graph. And then there you can see that the control group had the greatest regeneration, up to 84%. The THC was nearest to that, while the terpenes had the lowest. And it was similar across measuring the top, the mid portion, and the lower portion of the fin. And there you can see again the similar pattern. The data was analyzed, and the F values were high, and the P values were quite significant amongst all groups. And there you can see when we had compared each group, they were all statistically significant as well. The characteristics, as I said, were assessed under the microscope. And just looking at this picture, we tried to mimic somewhat the picture I had shown you in the 4th slide with the alizarin red. This is just a normal fin that's stained, and you can see the degree of purple stain, that's the affinity for calcium, and this is normal. This was the fin after it had been fractured and regenerated. You can see that linear uptake of the dye. This region with the irregular area was the area which was crushed, And there you see where the fin had regenerated with a normal uptake of the dye. This was the CBD stain group, and here you can see at the fractured area, there was actually increased uptake of the dye, indicating an increased affinity with calcium and increased calcium deposition. And at that region, the width of the fin was also thicker. This was the THC group, and there you can see there's less staining, which indicated that there was less affinity. And this is the terpene group, which was basically showing almost no affinity in the caudal region or the regeneration, showing minimal calcium deposition. So the THC group had shown a significant concentration-dependent reduction in the regeneration. However, it was more dense compared to the other groups except the CBD group. And this was in keeping with previous studies by Heath et al. And Kim et al. The CBD group, however, showed decreased regeneration as well. However, it showed the most dense callus deposition and greater thickness. And this was in keeping with previous studies by Lee et al. And Kogan et al., which had shown that CBD had actually shown increased deposition and maturation of collagen, strengthening bone structure regeneration. So overall, the regenerate bone exposed to THC and CBD had showed a marked increase in thickness, density, and staining, correlating with increased calcium deposition. The limitations of this study included the fracture pattern, the uptake of the drug by the fish because it was given in a water bath by diffusion. If you had missed recording the analysis because of their rapid turnover time, just missing a day could skew the results, and there may have been some observer bias throughout. So in concluding, the observed growth, there was inhibition with all groups. However, there was less with THC compared to CBD. However, the CBD showed the greatest thickness, which would show that there may have been a greater oppositional growth in terms of the width versus longitudinal growth. So this gave the overall impression that THC and CBD extract, they may have a greater qualitative versus a quantitative effect on bone healing and caudal fin regeneration. So with future considerations, this can be applied in diseases such as abnormal deposition of bone in your soft tissues and around bone, such as heterotopic ossification. And here you can just see a stain of heterotopic ossification with the red dye. So this could actually be applied in this scenario. So with this study, you can go on to validate it in mammals and then even one day go on to validate it within humans. And this concludes my presentation. These are my references. Thank you.
Thank you, Dr. Smith, for that interesting presentation. Do we have any questions or comments? See any hands being raised? Nothing in the chat. So Dr. Smith, zebrafish, like what make you choose? Well, like how'd you guys choose that?
Well,
Like 30,000 fish in the sea. Like how y'all know to go get zebra?
Well, so the zebrafish has actually been used to study other compounds and chemicals at the university, including nicotine and alcohol, and their psychoactive effects. They look at the behavior of the fish. So it's readily available, and because of that similarity with other mammals, it just sprung up out of a conversation. We had actually wanted to see if we could actually also radiologically analyze the fish. However, in terms of fracture in the area and then doing x-rays serially to see how it heals. However, because they were so tiny, we don't have the equipment to assess that. A micro CT would have been helpful to increase the robustity or power of the test.
Okay. All right. Good. So if no other questions or comments, I implore you to keep up the good work.
All right, thank you.
Thank
Thank
you.
you everyone for having me.
All right. We have one more speaker who's our keynote speaker, but before I move on to that, Dr. Holliday has put in the chat just a reminder to complete the feedback for this year's presentation. And you got to sign up in order. So you got to complete the feedback and you got to sign up in order to get your CME, claim your CME credits. Also, there's the QR code that you can scan to actually go ahead and do that, because you don't want to miss out on getting your credits. And I'd also like to take this time, let's see, where is that now, to give a little shout out to our sponsors. And our sponsors for this year's event are that of Cell Collab Clinical, Consultant Physicians Staff Association, Doctors Hospital, the Medical Association of the Bahamas, the Medical Protection Society, Nestle, National Insurance Board, Public Hospitals Authority, Spotted Doc, Springer Nature, STATA, the Ministry of Health and Wellness, and individuals such as Dr. Pinna Butler and Dr. Wells for all of their contribution. And without further ado, I would like to move on to our final presenter for our conference, as well as for tonight. And that is none other than Dr. Brian Charles. Now, Dr. Brian Charles gained his Bachelor in Science degree in Natural Sciences with honors from the University of the West Indies, Cave Hill, Barbados, in 1983. Then he worked for a year as a project engineer for the computer chip manufacturer Intel. Dr. Charles' medical career began in 1984 when he entered medical school at UWI Mona in Jamaica. And in 1989, he graduated with honors in pathology. After his internship began, he began a specialty postgraduate training in emergency medicine at the Cave Hill Facility of Medical Sciences, Queen Elizabeth Hospital, Barbados. He was one of the first 2 graduates in the specialty in the region, gaining a master's and doctorate degrees in emergency medicine. He further subspecialized in hyperbaric medicine and emergency cardiac care. Dr. Charles has also had training in mass casualty management, incident, command, and medical management of disasters. At the QEH, the main medical facility in Barbados, he was the consultant in the accident emergency department for 10 years. Dr. Charles was awarded the Silver Crown of Merit in 2008 National Awards for the Government of Barbados for outstanding service to the nation. Let us welcome Dr. Charles, where he's going to now talk to us about understanding negligence and malpractice, tips for safe practice. Thank you, Dr. Charles.
Yes, thank you very much, Don. Just confirm for me that you are seeing my screen and that you hear me clearly, please.
Yes, we are seeing your screen and we can hear you perfectly.
Awesome. Thank you. Thank you. I'm honored to be the last presenter, and I'm very impressed that you have so many persons still on the conference after 3 days of really exciting topics. And that speaks a lot to the organizers and to the UWI research facility as a whole. I'm very proud of that, to be a part of it. I just want, before I go on, to say that our prayers are with our colleagues in Jamaica while they prepare for some inclement weather. So let's hope that everything goes well down there. I know that you in the Bahamas are quite used to having bad weather and stuff. But today we're going to talk a little bit about medical negligence and malpractice. I'm not going to spend too much time on it, but just to give you a few tips as to how to practice safely and what we see mostly as problems from a medical legal standpoint. Let me say that some of you or most of you should have heard already of Medical Protection Society. We are a sponsor of your conference, and we're happy to do that. We would like to do that every year, actually, because we are the world's leading protection against anything against doctors and healthcare professionals. And our mandate, or what I like to call our philosophy, really is to support safe practice in medicine and helping to avert problems before they actually happen. My disclosures are really quite simple. I'm an emergency physician, and tonight I don't intend to present anything of a clinical nature to you, but rather to present on things that are very important to our medical practice. So as Don said in the introduction, I'm a medical consultant for medical protection since 2002 for the Caribbean region, and I have seen quite a few cases throughout the Caribbean where doctors and other persons, institutions, as well as some nurses as well, have gotten into trouble and gotten on the wrong side of the, I don't want to say the wrong side of the law because that will imply a criminal activity, but rather civil activities in terms of lawsuits. Atal Gawande said that the important question isn't how to keep bad physicians from harming patients, but how to keep good physicians from harming patients. And as you all know, we are all good physicians, with our very excellent training from the University of the West Indies. As we've been here for most of the day and for 2 days previous to today, I want to have some interaction with our presentation. So what I'm going to ask you to do, everyone, if you can take out your smartphones, and if you can see the screen, either hit the QR code, or if you can enter menti.com into your URL and type in the code 866-35634. That will allow you to be interactive during this presentation and to be able to share some of your opinions as I'm doing the presentation. So I will just leave 30 seconds while we're doing that. We have 3 persons who have already signed in. So you can just use your smartphones, your tablets, your laptops, anything that has web-based and join in, because then everybody will be able to see your participation. I kind of like this medium because not only that you're sitting, listening, and probably getting bored, but you're actually answering questions and doing things interactively as we go on into the presentation. So I'm going to go into the next slide. Unfortunately, only 4 persons have registered. Hopefully they can go on sometime later. So for those 5 people are on now, you can vote or you can hit on your screens. What is your practice level? Just so that I have an idea of who would be in the audience. Is it that we are having difficulty in voting? I see only 1 person has responded disappointedly. 2 people, so 2 consultants. Any registrars, senior house officers, students?
I don't know if other people are having the same issue I'm having, but it's just taking me to, it's not allowing me to kind of log in to do this.
No?
No. I mean, I see other people are logged in, but
yeah,
no, I don't know.
So have you, you did a QR code or you entered
Yeah, if you go back 1 slide, let me do it again, I guess. Because I
All right,
did the QR code and I can tell you what it says.
Yeah, let me get the QR code in for you again.
All right. Let me just
The fact that some people are on,
yeah, so it works.
It's a good thing.
So once I click the QR code, it takes me to a page say join on your smartphone or devices for interactive participation during the presentation. Join our presentation on your smartphone, and it gives
that's it.
gives the number or scan the QR code.
Yeah, no, so that's fine. Once you got that first slide, that's it. So that's good. That's good. You're there.
And then you click the thumbs up.
No, if you want, yeah.
Okay.
So are you seeing this slide? What is your practice level?
Yes.
Good. Right. So you can vote. And you just did. Right. Okay, good. Yeah. All right. So not to spend too much time, this was just an introductory so that everyone can get familiar with what we're doing. We have 1 SHO. Okay, so the next slide is asking, have you ever been sued or complained for? Bearing in mind, in my introduction, I said that medical protection is there for protection of doctors and healthcare workers. And I am very impressed. The majority of those persons who have responded said no, they have not been sued or complained for. And that's really good. That's really good. I will tell you that there's some presentations that I have given where it's the opposite. Okay, and there's nothing wrong in that, because as I will show you in a little while, regardless of how good your practice is, sometimes things will go wrong, and this is why you have to be you have to be prepared for what could go wrong. All right, so those of you who typed yes, which is I think only 3 or 4 of you, how did it make you feel being sued or being complained for, either from medical counsel or any disciplinary? How did you make you feel? You can just type your response. There's nothing to vote. Sad, okay. I will add some for you. Stress, aggravated, disturbed, all of those things when someone complains about your practice. You know, we have spent years training to be doctors. We've had the best expertise, the best exposure, yet, and you're doing the best you can for persons, but sometimes people, things go wrong. And what I want to show you what some studies have shown, and these studies are quite old, but they have not changed in anything recent. And this study from Harvard shows that out of 27,000 negligent effects in 1 year, negligent events, claims came out of that from only 3,600. That is one claim for every 7.5 negligent events. And out of those claims, half of them showed no negligence or no identifiable injury. A third of them, there was no negligence, but there was identified injury. And only 1/6 of them had true negligence. Also, in another study 6 years later from New York, it showed that 4% of the admissions had adverse events, and that 1/4 of these, the incident was related to malpractice or negligence. So that goes to show that even some adverse events, not all of them are due to medical negligence. And only 1/8 of these 1% were the subject of claims. And 2 out of 3 of the claims came from patients with absolutely no negligence or no adverse outcomes. So what does that say? It says really that if you are negligent, it is unlikely that you will be sued or complained against. And if you are sued, it is also unlikely that you actually have been negligent. This doesn't give us a license to go and practice willy-nilly and be careless in our practice, but it just goes to show that just being sued, the fact that you are sued, doesn't mean that you are negligent. And the question we should ask is, why the mismatch? Now, it has been shown in many studies that for you to get your patients to sue you, there must be two combining factors. The first one must be a predisposing factor, in that you either are in a hurry, you're rude, your bedside manner is not good, your patients are not supportive of what you're doing, and there must be a precipitating event. So there must be an adverse event. So, something happens in your practice, something that was not intentional and caused harm, right? So adverse events or unmet expectations, high costs, or adverse management. When there's a combination of these two, the predisposing factor and the precipitating factor, then you are likely to get sued. I will say to you that in my experience, that I know of doctors who have very poor, I don't say bedside, very poor clinical acumen, right? I know of at least 2 here in Barbados, but they are fantastic with their patients. Their patients love them. And in all the years of their practice, they have never been sued. And on the converse, I know of doctors who are excellent in their clinical acumen, however, poor or shoddy bedside manner, and those are the ones that are getting sued. So the message here is that if you have predisposing factors and you have precipitating factors, you are likely to be sued. So these are the 7 things that really present with medical legal risk as to what could lead to problems from a clinical standpoint. The first one, and I know that the last 3 days have been based on research. The first one is very important in that consent is paramount. if you cannot show consent or proper consent to a person who complains or sues you, we cannot, in fact, we will never be able to defend you successfully. So when the consent process has not been done properly, we almost automatically tell the doctor or the nurse that we will have to settle this case. It makes no sense proceeding it any further because we're going to lose. And rather than waste time, waste money, we aim to settle if the consent process is not complete. Clinical records and documentation. If you do not document properly, if you do not write everything clearly so that we, years from now, years after the event, can reproduce what has happened, then we are not going to be able to defend. So documentation is the second thing. Those are the two main things I've found over my 23 years in practicing medical legal in the Caribbean are the main problems that our profession has that can lead to lawsuits, successful lawsuits. Careful prescribing, I'm not going to speak about that. Confidentiality. The only thing I want to say about that is that you must be careful with your breaches of confidentiality, not necessarily by you, the clinician, but by your ancillary staff, because they may not be as robust in their confidentiality practices, but you are vicariously liable if they breach confidentiality in your practice. So we have had a couple of cases, but they're not too many. Competence, I find that in the Caribbean region, we tend not to have persons acting outside of their sphere, thankfully. Communication is important, and having a chaperone for private examinations is also important. I like to show the slide. The slide shows that, a surgeon is going into theater, but following the surgeon is an attorney because, a lot of cases are tied into negligence and lawsuits. So even in research, the principles of medical ethics still do apply. So let's go back to our medical school days. What are the principles of medical ethics? Please type them out as you can remember them. And you are allowed, more than one entry. So you can type, enter, and type again if you can remember. Just as a revision. Do no harm. So that's non-malfeasance. So that's one. There are three more. Medical ethics. Autonomy, yes, that's two for me. And consent, that's number one. So there are two more. Autonomy, yes, go ahead. Beneficence, so do no harm and always do good. Beneficence, one more. This last one tends to be a little bit trickier. Justice, thank you very much. Justice is the last one. So those are the four principles of medical ethics. And if you follow those principles, you should not go wrong in a medical legal environment. All right. And let's explain what justice means. Justice means that you should give to your patients the same amount of care that you will give to your family or to anyone else. Everyone is deservedly of your best efforts. And if the patient is not satisfied with the care that you have given, they have a right to complain and to pursue compensation for that. And that is where the medical legal part comes in. All right, so very good on that. So the next thing is, in terms of definitions, clinical negligence and medical malpractice just means that when you fall below your standard that your profession has set, and it causes either harm or damage to your patients, you are medically negligent, or you can suffer a malpractice suit. And I want to go into a case. Let me see where I can pull it up. Do I have it here? Should be yours. Oh, I actually shut it down. I don't know why. So I want to give you all a case of and ask you some questions just to highlight some of the things that I spoke about in terms of negligence. And this is an actual case from our region. And so I'm not showing you the case, but I'm reading it out just to save time. And it is that of a Mrs. F. Mrs. M, sorry, a 70-year-old woman who was admitted to a cardiac surgery unit. She had a triple bypass surgery and had a new lease of life because now her angina has gone, but the grafts gradually became blocked. As a result, she had decreased effort tolerance, she had put on weight and had to be brought back into hospital. Investigations showed that there was diffuse disease in the graft, and she was offered to have an open heart surgery to replace the grafts. The consultant anesthetist, Dr. E, spoke to Mrs. M prior to the surgery and told her that part of the anesthetic technique was that he's going to do a thoracic epidural. She was not amenable to a general anesthesia because of the weight that she had put on, and the team thought an epidural was a much better way for her to go. She consented to this in a proper manner, and the epidural was placed, and eventually she had the anesthetic in the routine manner, and as usual with cardiac surgery, she was given a large dose of heparin, and the bypass was done. Everything went well. The heparin was reversed with protamine. She was transferred to the ICU, and the epidural infusion for analgesia was commenced as planned. She had a stable night, and the instruction was that as the sedation was reduced, that the epidural catheter was to be removed. This was done, and when the nurse examined her, she realized that Mrs. M, after removal of the catheter, could not move her legs. She was awake, but she could not feel nor move her legs. Several hours later, she still complained that they was unable to move, and the nurse called the doctor who did the surgery, but he was in theater at the time and was not able to come to the nurse, and he had spoken to his registrar to ask the registrar to go ahead and to evaluate Mrs. M. Several hours passed before Mrs. M was evaluated by the registrar, and when he found that there was a dense motor and sensory block at the level of T6. Yes?
Sorry to interrupt, but do you have slides for this? Because we're just seeing what says presentation.
No, I don't have.
Okay, so we shouldn't be seeing any slides. Okay, just
you
confirm.
shouldn't be seeing any slides.
Okay, all right, good.
You shouldn't be seeing any slides for this.
Cool.
I've just taken down the presentations.
Right. Sorry about that.
Right, that's fine. That's absolutely fine. Right, so because of the dense hemiplegia, and he ordered an emergency CT scan, which showed a large hematoma in the epidural space, compressing the cord. She was then rushed to theater, and an emergency laminectomy was done. Although she recovered, she remained paraplegic, and a lawsuit was brought against the doctor and the hospital. So again, I'm hoping that you all can see this. What do you think we should do with this case? You all can vote. Should we defend it? Should we settle it, or are we not sure? We should defend. One person thinks we should settle. There's 16 of us. I'll be interested to see what the thinking is. 5 persons have voted. Defend. Okay. All right. So at least give one more person. Right. Good. So we have 4 persons saying to defend, 3 persons saying to settle. I will tell you what we did in this case is that we settled the case. And the reason for that is that the care of the patient fell below the standard that is accustomed to a person who has had an epidural. If you have had an epidural and you post-surgery, and the nurse has informed you that something is wrong and that she is not feeling her feet and she's not moving her legs, that is an emergency, and that should have been seen right away. So we could not defend this case because we would not have been successful. So this is the type of thing that we do, and we settle for that. So No, let's not do. So, okay, so what risks were evident in this case? Yes, that's right. So competence, because they fell below the level of expectation for a case like this. Very good. That's exactly what I was expecting. Communication too, because there was a breakdown between the registrar seeing the patient and the instruction from the consultant. I can agree with that. Yeah. Okay. So the learning points was this, in this case, is that all reasonable steps should be taken to ensure that patients are aware of the risk. So this is the consent. Good documentation is important for good defense, right? So if in this case, no documentation or follow-up was done for over 12 hours, despite anesthetist saying otherwise, clear instruction must be given to all staff, and that includes the nursing staff. So I want to give a few words on consent because it's the number one thing that we find that we cannot defend in the Caribbean region. Consent gives the right to self-determination as with the autonomy part of your ethics. It avoids allegations of assault and avoids negligence claims. It also satisfies the medical councils throughout. And you will find that all the medical councils in the Caribbean, and I've checked this, have explicitly stated that consent must be done in every encounter with your patients. So that's something that we must follow. Everything that we do is consensual. We must involve our patients with what we're doing. And it starts immediately when the patient comes to us and when the patient seeks advice. And it is a continuing process. Consent may be expressed, implied, assumed, verbal, and written. Needless to say, just because consent is written or the patient signs a consent form, that does not mean that there's that doesn't mean that there's a good consent process. So signing on the dotted line is not for the court a necessary prerequisite for the consent process. So you must be able to show that you've done this. With regards to documentation, if there's no documentation, no records, there's no defense. And an adequate medical record is one that enables us to reconstruct the consult years after it has been done. Without a reference to memory, the courts do not accept you saying that I remember that I did this and this is what I always do. Always remember also that the patient and the legal team have access to their records. So the function of record keeping is as an aid memoir to keep an accurate and clear picture of the treatment and to assist in communication, but it also helps with legal matters and with complaints. Good records must be legible, they must be contemporaneous, meaning that they must be made at the same time. They must be objective, leave out the subjective feelings, emotions, etc. They must include a date and a time and a signature, and they must be accurate, appropriate, and adequate. Now, in terms of when things go wrong, what happens? How does the court determine that you have been medically negligent? Well, there are three things that must be proven, not by yourself, but by the person claiming that you are negligent. They must prove that you breached the duty of care. They must prove that you acted beneath the standards for your level of training and for your profession. And they must prove that damage occurred because of what you did. When those three things are satisfied, then you are shown to be negligent. The first one, which is duty of care, is not usually in contention because someone comes to you for care, you're trained as a doctor, then you can, you have a duty of care to that patient. But what is usually highly contestable is the standard of care. Now, if a patient complains or sues because of something that you have done and it went wrong, we or the courts will actually ask someone in the profession of similar standing and experience and training whether or not this process that you did fell below the standard that is accustomed to by the profession. And if you breach that standard, if you fall below the level that is expected of you, then almost automatically you are going to we are not going to be able to defend you. And the last one, in terms of the harm, the person usually will not complain or sue if there was no harm. Frequently, as I was mentioning about consent, the issue is that there's a failure to warn of a complication. And how much information you give during your consent procedure really depends on the case that you are consenting, what the person is consented to. So, for example, a person who makes a livelihood by using their hands, if they are a musician or pianist or something like that, and they are going for hand surgery, you are going to be very much more detailed in your explanation as to the side effects and the risk of your procedure than someone who is a footballer, soccer player, who does not depend on the livelihood of using their hands. So the amount of information that you give really varies depending on the case that you're dealing with. In some cases, certain information would be necessary, and the doctor is always obliged to have the patient's best interest at heart, giving that patient some time to make a decision, giving them sufficient information to make them make that balanced decision. How much money and what does the patient get in terms of their compensation? Well, that is a matter for the court to decide, but just to let you know that there are general damages and there are special damages. And what brings up the cost is where you have special damages where persons may have to go outside of our jurisdiction for care. So we need to be very careful about that in terms of lawsuits. However, I thought I would throw in this slide. On the positive side, the courts do accept that things will go wrong without there being any negligence on the part of the doctors. And if you go back to the beginning of the presentation where I said that if you are sued, it doesn't mean that you're negligent. The courts do understand this. So the fact that there's been a poor outcome doesn't necessarily mean that there's been negligence and that you are guaranteed of a perfect result. And the courts understand that. So having considered the case and what I just said, is there anything that you would do differently to consider to ensure safe practice? And you can type a couple of things, you can type more than one response. Are there any things that you would do to ensure safe practice? Maybe you can think about this. I can just move off the slide in the interest of time, but think about things that you would do to ensure safe practice, going back to the 7 risks that I spoke of. So somebody says, yes, they're still thinking. I like that. Right. So the burden of proof really, again, lies with the claimant in that you must show that the doctor owed a duty of care, which is usually obvious. There must be a breach of that duty in that the standards have fallen below what's expected. There must be consequential harm of your actions and that damage or loss has resulted. I slipped in this last slide here very quickly just to say that apology has a great effect when things go wrong. If you do have a really good apology, and the thing about having a good apology is that it's quite disarming, and if you have and the patient may actually not pursue a claim against you if you show that you are empathetic and that you have apologized. It can release a lot of the anxieties for yourself as well as the patient when they see that you are a caring type of doctor. So when you apologize for something going wrong, it doesn't mean that you are admitting liability. All right. So if there's anything that you take away from here, is that an apology really, if things go wrong, you must be empathetic and you must show the patient that you understand what they're going. So I want to summarize very quickly to say that effective communication is essential to minimize risk for patients. Consent is a process. Proof of negligence is multifactorial, and the doctors must consider all aspects to combat problems before they come back to bite you years later. And though elements of negligence may not be 100% satisfied, the courts usually side with the claimant So be careful about that. So the courts are not on our side. They're usually on the side of the claimant, even though I did say the courts do understand that things don't always go right. So attention to these 7 things will prevent most medical legal challenges, and that is consent, good documentation, careful prescribing, confidentiality, competence, communication, and chaperone. And Don, I thank you for your time. I thank your audience for staying so late and for listening to us as a sponsor of your conference. And congrats on a very good conference. Thank you.
Thank you, Dr. Charles, for that information that you brought forward to us tonight. We truly appreciate it, and we enjoyed the interactive portion of it.
Yeah.
I just want to know if anybody has any questions for Dr. Charles. Let's see.
Thank you for that presentation, Dr. Charles. I have a question, and I hope it's not out of the scope of what you just discussed, but I was thinking about under the topic of elements of negligence that you spoke about, and you said that it's often necessary to have another medical practitioner verify that malpractice did indeed occur. So in instances where a doctor may acknowledge privately that malpractice took place, but may refuse to state it on the record, what do you have to say about a culture or an unspoken code within the medical community, and how might this impact or affect a patient's ability to seek justice and maintain trust in the healthcare system?
Absolutely fantastic question. Let me tell you that what happens is that when the patient feels aggrieved or they have an adverse event, things do not go right as were planned, and they sue, the court then asks you, the doctor, for a report. And as part of your, being a good doctor, you will provide that report to the court. And then the court then uses that report to determine how to proceed with the lawsuit. Now, you, the doctor, who will automatically need representation, and this is what medical protection does. We provide that representation for you, even if you are saying that there will be a sort of a code of silence. When we seek to see if you have fallen below the standard, we tend not to use any persons within your jurisdiction. So, for example, at this point in time, the 24th of October, I have maybe 3 active cases from Jamaica. I have 1 from Bahamas. I have 2 from Barbados. For those cases, I would not seek an expert from those jurisdictions. So if you are being sued, I'm going to ask for someone of similar training and experience as you from another island, so that it doesn't affect what you just spoke about, the code of silence. And I'll tell you, I'll be honest with you that I do find that sometimes, it's a small community. Many of our peers, our senior doctors, have all gone through UWI, so we all know them. They have been our examiners. And if they are sued and they're asking us to provide evidence that they have breached the standard, we feel a way about doing it. But remember, we owe the patient the justice, right? So if they have been wronged, we owe that patient the right to complain and the right to seek compensation. So I hope that answers your question.
All right. I think one more question from the group, and then we'll move on. Dr. Mortimer?
Yes, Dr. Moxie. Yes. What is the proper way to transfer notes from one physician to another if a patient wants to go on to another physician? And sort of, anyway, explain, please. Do
Yes.
you transfer the whole note? Do you transcribe? Do you copy, keeping a record for yourself?
Okay. So the first thing I want to say,
and to protect yourself from any future,
confidentiality issue.
Right, and
Yes.
lawsuits and that kind of thing.
The
When
first
people
thing
open the
I
note
want
with
to
a
say,
signed comb and say, oh, see, he forgot that.
yeah, the first thing is that notes that you make during your encounter with the patient, remember, belong to the patient. Okay, so the patient has a right to request their notes in entirety. Now, if a patient is transferring from your care to another person's care and you have permission from the patient to transfer the notes, then you should transfer the notes in its entirety to the patient. And the safest way to do that is either by encrypted electronic transfer or give the patient a copy of their notes themselves and you keep your copy as well. And I hope that answers your question just very briefly.
Okay, thank you.
Yeah.
Okay, thank you again, Dr. Charles.
Okay, you're welcome, Don.
I know it said you were our last presenter, but I kind of told a little lie, a little white lie there. We actually have one more presentation, and that presentation will be given to us by our dean here at the SCMR, Dr. Sabrika Pinder. Are you there?
I am here. Can you see me? Can you hear me?
Yes, we can see you, we can hear you.
All right, wonderful. I'm so glad that all of you are still with us this evening as we come to the close of our wonderful Research Days conference. I would be remiss if I don't make a small presentation because we can truly never repay our Research Days conference chairmen for all of the hard work that they've done over this time. I know Mr. Blake is very surprised because I've been hiding these, and I know Dr. Halliday is very surprised as well. But I want to make a presentation to Mr. Blake on behalf of the UWI School of Clinical Medicine and Research. We thank you for all of your efforts. I know how excited you've been to put this conference on, and may God continue to richly bless you. Can I give you a hug? Yes, you may. Dr. I know you are. Dr. Darren Halliday, can you come for me, please? Dr. Halliday, I'm sorry for calling you out on the spot, but I couldn't let this week go by without expressing our gratitude on behalf of the School of Clinical Medicine Research. You have been with us through all of the changing scenes of life of this Research Day conference. And so we really love you and we appreciate you. Thank you so much. This is just a small token of appreciation on behalf of us here. Now, Mr. Blake, you may come and do the honors.
Well, thank you very much, Dr. Pinder Butler. That was truly surprising, and I'm thankful for that. So, on behalf of the committee, that's Dr. Halliday and everyone else who have helped to plan, we bring the 19th annual conference Research Days to a close. And I'm honestly grateful and proud for how the last 3 days have been, as we've had some very dynamic and engaging speakers. And the sessions we had, they encompassed cancer research, technology in healthcare, regional partnership, and I'm truly humbled by our DM students as to how they presented their work, how they answered their questions, and I think that's pretty much looking forward to more of these presentations going forward. And these presentations did spark very good conversations. And I must also say how thankful I am to the moderators. You were all excellent from night 1 to night 3. And the keynote speakers, you're also very good, very engaging, and I really love a lot of those topics. You could see I got messages from persons about a lot of these keynote talks and asking for the content of their presentations as well. The presentations altogether were excellent. The attendees also very good. The committee, the attention to detail, the thought that you had as you put together the different components of the conference, from the in-person activities to the virtual activities, all very good. But I cannot leave without mentioning our office trio. I call them our trio, and it's just 3 young people, just in their early 20s. That's Ernest, Ronaldo, and Victoria. And additionally, the student volunteers were all very good, and we appreciate all you have done over the last months and weeks leading up to the conference. Of note, key mention must be made of our technical lead. That's Dr. Holiday, who, if he's not here, he ensured that he was here. Somebody was here to do what he wanted to get done. And also to our office manager, that's Miss Tanya Kelly. Her planning skills were all placed on display throughout this event. To our director, Dr. Pinda Butler, your exceptional leadership, I must commend you on that. And I look forward to your leadership over the next few years. Thank you very much for the opportunity to execute the conference. To all your attendees, your questions, they were thought-provoking, and it gave us a lot of things to think about as we plan for our 20th year next year. So whether you joined us remotely or in person for the workshop or the opening night, we thank you very much. And we want you to take the momentum forward. And I want to close by saying, let us publish, and I should repeat, let us publish, collaborate, mentor, and advocate. So before we go, please remember to claim for your CMEs, complete the conference feedback, complete the speaker's feedback, as we'll need all of those information to actually give you your CME credits going forward. And Dr. Holiday can share the information in the chat and on the screen for you to claim for it. So on behalf of the School of Clinical Medicine and Research, we and the entire conference planning team, I thank you once more. And I look forward to seeing you next year for our 20th anniversary, which promises to be bigger and better and in person. So good night, everyone. And we pray for our brothers and sisters in the region as the hurricane comes on us.